morning. Good morning. On behalf of ANF BIHAR, I welcome you all to 6th East Zone Neocon and BIHAR Neocon 2025. पूरे ऑर्गेनाइजिंग कमेटी बिहार नियोकॉन एंड ईस्ट जोन नियोकॉन की तरफ से मैं डॉक्टर चंदन सिंह आप सभी का भगवान बुद्ध, भगवान महावीर, गुरु गोविंद सिंह जी और माता सीता की धरती बिहार में आपका हार्दिक अभिनंदन करता हूं। हम सब यहाँ एकत्र हुए हैं न्यूरोलॉजी के ईस्ट जोन नियोकॉन, साथ में बिहार नियोकॉन पूरे पूर्वी भारत के सबसे बड़े कॉन्फ्रेंस के रूप में आज होने जा रहा है और आप सभी भारत के विभिन्न हिस्सों से यहाँ पे आए हैं। आपका तहे दिल से मैं स्वागत करता हूँ। हम कोशिश करेंगे कि अगले 2 दिनों तक हर एक तरीके से आपको अपने कॉन्फ्रेंस में साथ रखें और आपको बोर ना होने दें। किसी भी कॉन्फ्रेंस की जो मेन थीम है वो साइंटिफिक सेशंस, खाना पीना बाकी चीज़ें एक्स्ट्रा हैं। कल हम लोगों ने 3 वर्कशॉप किए जो काफ़ी अच्छे तरीके से हम लोगों ने कार्यान्वित किए और ऐसे ही हम लोग कोशिश करेंगे कि साइंस के साथ चलते हुए अगले 2 दिनों तक, आज से लेकर कल दोपहर तक, आपको अपडेट करते रहें। नई चीज़ें जो आ रही हैं न्यूरोलॉजी में, जो पुरानी चीज़ें हो रही हैं, उन पे डिबेट करें, उन पे पैनल डिस्कशन करें और जब आप यहाँ से जाएं तो कुछ ना कुछ हमारे ज्ञान में बढ़ोतरी हो, इसीलिए कॉन्फ्रेंस को रखा गया है। मैं भगवान को थैंक यू करते हुए कि उन्होंने मौका दिया बिहार स्टेट पटना को कि ये कॉन्फ्रेंस हम लोग ऑर्गेनाइज कर सके। आपकी इजाज़त से मैं इस कार्यक्रम का शुभारंभ करना चाहूँगा। वक्रतुंडम महाकाया सूर्यकोटि समप्रभ निर्विघ्नं करो समदेव सर्व कार्येषु सर्वदा। भगवान गणेश को याद करते हुए मैं पहले सेशंस के लिए हमारे स्पीकर डॉक्टर रुपेश कुमार से आग्रह करूंगा कृपया स्टेज पे आए और इस सेशन को चेयर करने के लिए हमारे साथ डॉक्टर परमेश्वर प्रसाद सर, डॉक्टर बनवाल सर, डॉक्टर पंकज कश्यप। हर एक स्पीकर का सीवी स्क्रीन पे आएगा। मैं चेयरपर्सन सर से रिक्वेस्ट करूंगा कि सीवी को कृपया स्क्रीन से देख के स्पीकर के बारे में बताएं। सारे स्पीकर से नम्र निवेदन है कि जो टाइम अलॉटेड है उसको पालन करें जितने भी लोग हैं और मैं क्षमा चाहूँगा कि हमने 15 मिनट का विलंब किया, इसके लिए मैं क्षमा प्रार्थी हूँ ऑर्गेनाइजिंग टीम की तरफ से। धन्यवाद।
उसको चंदन
Dr. Rupesh, my dear student, now growing to great heights. He has been a bright student. His topic is growth charts in children. Such a nice study that will help us know so many things, because the growth of child means how the child is growing. If the child not growing, what is the cause of growth not growing, and we have to go into details why the child is not growing. Rupesh, you may go forward.
Thank you, sir. Banwal sir was my teacher, and under his guidance I took 3-year training for my postgraduate. So you know, the first session we reached by sharp 9, and you know, all chair was empty. So Dr. Chandan said, okay, you start, sir. Then I said, okay, you at least 10% will come, then I will start. So you know, just I'm starting because I have allotted 10-minute times and we have to discuss a vast topic. So you know, growth chart in neonate. So under these headings I'll discuss introduction, what should be the quality of the ideal growth chart, what growth chart is available, what is challenges, pros and cons, and what is the best possible growth chart for the newborn. So what is growth chart? It is graphic representation of growth of reference population for clinical use. It has growth curve which display the size of the newborn or child at the point of the age, their growth rate over the period of the time. Why growth monitoring is important? Monitor the growth of infant to detect any deviation from the normal. So the first chart was published by the Count Filbert de Montbéliard in France in 18th century. After that, Henry Bodwith published in Massachusetts 1891 one chart, and Lubchenco, we all know the first intrauterine growth chart was widely used once. So growth chart are two common type, growth reference and growth standard chart. Growth standard means, how baby will grow during optimal nutrition and optimal health. So a standard growth. And it is about the data from the controlled healthy environment as compared to difference chart, how baby is growing rather than how baby should be growing, prepared from the sample in a given population at the time. Longitudinal data, the all longitudinal and cross-sectional. Take a sample at the birth and follow them and create a chart, over the period of the time. We can see here, so from the newborn to the over the period of the time, and cross-sectional is, collecting data at different age at one time. It requires less resources and time. So what should be the ideal growth chart? It should be the growth standard rather than growth reference. Should be longitudinal, then cross-sectional. So types of growth chart, intrauterine growth can be monitored intrauterine or postnatal chart. So how you will collect data in intrauterine? Data is collected from ultrasound measurement or anthropometry measurement at the time of the birth for intrauterine. They are based on the cross-sectional data. As compared to postnatal, serial anthropometry over the time starting from the birth in preterm baby. So these are the following chart. Lubchenco is all well known. That was all I'm not going to detail because we have time constant. So these are the intrauterine. Over that, Lubchenco was widely used once. So this is Lubchenco. That was the weight, length, and hair circumference. So initially, Lubchenco is this Lubchenco. Actually, I'm not going detail of that because I have to discuss, current what we are using. So Lubchenco chart was 400, 700 newborn between 26 to 42 week was taken into the sample. Weight, length, and head circumference was measured. First describe SGA, LGA, and AGA. What is drawback? It is, all data was collected from the US, so it is not applicable for the all geographical area, and that was collected in high altitude region. So postnatal growth chart, among that Dennis Wright, Ehrencranz, and Intergrowth 21. So Ehrencranz and Intergrowth 21, these two charts are still used. Dennis and Wright are now not used. So Wright's postnatal chart, that was from the till postnatal from the till 105 days of life they have plotted. That include weight, length, and head circumference. The sample size was very small. Only 205 child was sample was collected, a newborn sample was collected. This is, Ehrencranz postnatal growth chart. What is beauty of this chart? We can see the initial dip. We all know the newborn, when growing initial there is dip, after that it is growing. So, and it is applicable for the VLBW baby from 500 gram to 1500 gram. And it also included, morbidity. How if baby have morbidity, because most of the baby in that VLB growth, baby will have some morbidity. If there is associated morbidity, in that case, how baby will grow. So, two things special about Ehrencranz is a postnatal dip and the associated adjusted chart for the morbidity, because most of the that VLBW baby will have the morbidity. So, these two things are peculiarity of this. Fetal infant growth chart, that included Babson, Binda, Fenton 2003, 2013, and now again 2025 Fenton growth chart came. So Fenton chart was first was 2003 and revised in 2013, and now in 2025 the third Fenton growth chart came that I'll discuss at the end of the slide. So again, the data was collected from the all developed country, US and European countries. So you know, because their growth potential and everything is different from the ours. So this is the again demerit for, so but we don't have better than that. So later I'll discuss about intergrowth, so how they overcome all these things. So all data was collected from the all developed country. So you know, the Fenton chart, we all aware about that. For the boys and girls, we have the separate growth chart. So the sample size was very vast, 4 million for the 2013 Fenton 2, and now in Fenton 3 that have collected 4.8 million sample size, and that have the recent population and age specific. For the male and female, they have different chart. For the boys and girls, they have 5 centiles, and accordingly they have classified AGA, SGA and LGA. So now the most commonly used chart is Intergrowth 21. Intergrowth 21 project is large scale collaboration for perinatal health consisting of more than 300 healthcare provider and researcher. 27 organization was involved, and more than 18 country. So data was collected from the more than 18 country. You know, so all we can see here. So from the USA, from the, you know, continent wise, if we will go continent wise, collect USA, North America, South America, European country, African country, our India was also included, and China. So you know, the geographical whole geographical area was covered in Intergrowth 1. As compared to that, what we discussed in Fenton, that was collected from the European and the American countries. So their growth potential and everything is different from the ours. So you know, that was, you know, how they are collected, because our growth potential is not like the US. How baby is growing in US and European countries, entirely different. You know, even in our setup, how people from the BIHAR is growing and how people from the Punjab is growing, because height, weight, length. So you know, we have to develop our own chart. If we can collect sample from 2 lakh in BIHAR, so that growth chart will definitely will be different from that of the other state. So you know, total 5,600 pregnancy till delivery. You know, so that was based on the 3, you know, newborn cross-sectional study. Total 5,600 sample was there, and how they have collected, you know, the fetal growth from the early pregnancy, that was longitudinal study, postnatal growth of the preterm. Actually, you know, I can't discuss all these things, how they have collected data, because, you know, again, on that we have to, we will discuss, that will take time. So, you know, main thing I would like to say, they have collected data from the all geographical area, and how they have fetal growth chart, how they have collected fetal growth longitudinal study they have done, postnatal growth of the preterm they have done, and newborn size at the birth. These 3 was the parameter. So follow up, just I'll take 2 more minutes. Follow up till 2 years of the age they have done in that. So you know, in 2014 they have generated internal standard for the fetal measurement and newborn size for the weight, length and head circumference. So these are the age specific both. Weight, length and head circumference. One is the weight, other for length and head circumference for the boy. Other is again for the weight and length and head circumference for the girl. So now, you know, we have discussed the 3 growth, Fenton, Ehrenkranz and Intergrowth 21. So which one is used? What is the merit and demerit of these 3? So you know, Ehrenkranz, as we discussed, what is pros? So account for postnatal weight loss and account for the morbidity. This is pros of Ehrenkranz chart. What is cons? Data was collected from the developed country. So applicability, we can't apply in our setup, or our setup, not our, means anywhere in the world. You know, wide variation in the clinical and nutritional practices. Growth reference not a standard. Fenton chart, again, problem is the large, good thing is large sample size and widely used. Problem is the reference chart, not a growth standard chart. It is, you know, if again for the centile, if we, for the fetal growth, EUGR, if we will plot on that, more baby will go for the more 50% or 30% of the baby will go for the 3rd or 10th centile. So problem don't account for the postnatal weight loss and cross-sectional study. Now the intergrowth 21. What is strength? Longitudinal data, growth standard, then the reference data, and more recent. So EUGR, incidence of EUGR is less as compared to, what we discuss in the Fenton. So, and now, intergrowth 21 can be continued with the WHO MGRS chart after 40 weeks of the age. Drawback is, for the preterm, less than 32 week, applicability is less because healthy preterm is lesser in that case, hard to get healthy preterm less than 32 weeker. So these chart also don't account for the postnatal weight loss. So intergrowth 21 methodologically is strong, can be used for the fetus and newborn more than 32 week. Use intergrowth 21 less than 32 week, we can use Fenton and Ehrenkrantz chart, and term baby WHO MGRS. The third Fenton that was came in 2025 till November 2024. That data was collected from the last 2013 10 year. So again they have collected data from the all developed countries, so I'm not going into detail of that because we are almost time is finished, so I'm stopping. Thank you for the giving me the opportunity here for the, thank you everyone. BIHAR data, as I said, sir, if we can do research, sir, we can collect our data, because I said, it is completely geographical, because how Chinese people look like, how just leave all other, how the North Indian people, how Punjabi, how South Indian. So we have the scope for our setup also, for our geographical region also, we can collect data and we can put our, in AIMS they are using that chart from, I don't know what they have named it, but in AIMS Delhi they have for their own population they have collected, they have made one chart. So
not have our data,
so that yes.
You can ask all the NNF members to do for it.
Oh, okay sir, okay sir, okay, sir.
Yeah.
Thank you sir. Any other question?
Which chart is best for Indian context?
So as I discussed, intergrowth 21 at present we can use for more than 32 weeker, less than 32 weeker either Fenton, better Fenton or Ehrenkrantz, both we can use, both have some pros and cons.
Thank you, Dr. Rupesh Kumar, for your nice presentation. Growth monitoring is most important aspect of monitoring the baby from newborn period. You have cleared from growth from intrauterine life to newborn period. Thank you very much.
Thank you sir, thank you everyone.
थैंक यू डॉक्टर रुपेश। ओपनिंग बैट्समैन ने काफ़ी अच्छी बल्लेबाजी की वीरेंद्र सहवाग की तरह, और इसी के साथ हम आगे बढ़ते हैं। वी विल मूव ऑन टू सर, आई विल रिक्वेस्ट ऑल द चेयरपर्सन एंड स्पीकर टू प्लीज कम फॉर मोमेंटो डिस्ट्रीब्यूशन। डॉक्टर रुपेश, I will request Dr. Bhavesh to please assist in the memento distribution. And moving on, next we have Dr. Kiran Shankar Das, and for chairing the session we have Dr. S.K. Pansari sir, Dr. Manoj Kumar sir from Kurji. I will request Bhupender sir to please chair the session. Dr. Kiran Shankar Das sir, please. Pansari sir and Bhupender sir.
Thank you, Chandan. Our learned speaker, Dr. Kiran Shankar Das. He is an associate professor, Department of Neurology, RIMS, Ranchi. He has MD, DCH and fellowship in neurology. His area of interest in neurorehabilitation, and he remained treasurer NNF Jharkhand, co-founder AK Focus Academy, Jharkhand Divisional PG Quiz Coordinator, and he is an author of Self-Assessment Review, DM Neurology and Pediatrics. So, I request Dr. Kiran Shankar Das to start his deliberation.
So, metabolic bone disease. Thank you, Chairperson, sir. With your permission, can I start? Yes, thank you, sir. So, metabolic bone disease. The definition of metabolic bone disease, it defines as decreased bone mineral content compared to the expected level for that gestation in combination with radiographic and biochemical changes. So, it's a decreased bone mineral content compared to the expected level for that gestation in combination with radiographic and biochemical changes. So the incidence of metabolic bone disease in very low birth weight is 16 to 23%, and ELBW, it's a very high, it's in 40 to 60%. So what is the physiology of bone mineralization? The fetal bone accretion, the most of the calcium, phosphate and magnesium occurs by active transport from the maternal circulation and mostly by placental transport. The function and activity of osteoblast and osteoclast are influenced by the availability of the mineral before birth. That means maternal. By 25 weeks, mineral accretion is approx 60 milligram per day and increased to more than 300 milligram per day between 35 to 38th week of gestation. So the predominantly bone mineralization occurs during the last trimester and peak around the 36 to 38. That's why the preterm baby has the deficit bone mineralization and leads to the metabolic bone disease. So the high calcitonin levels favor the mineral deposition. Parathyroid hormone related protein is produced by chondrocytes and perichondral cells, and it has an additive role with parathyroid hormone in the regulation of the fetal calcium and phosphates. So the placental transport, this flow chart shows the placental transport of calcium, phosphate and magnesium from the maternal to fetal circulation, and the fetus is a hypercalcemic condition that leads to the calcium sensing receptors, leads to the decreased parathyroid hormone, and that leads to the increased parathyroid hormone related protein, which again that is helpful in the calcium phosphate regulation and bone formation. Again, decreased parathyroid hormone decreases the 1-alpha hydroxylase that is responsible for that decreases the calcitriol level. So after birth, there is a rapid change in the mineral supply, hormonal environment and mechanical stresses. The placental sources of mineral is interrupted, and breathing determines an increase in blood pH with a consequent decline in serum and ionized calcium over the first 12 to 24 hours. These events stimulate the bone remodeling, causing an increased bone resorption and decreased bone density. So, what are the risk factors for metabolic bone disease of prematurity? The antenatal risk factors are placental insufficiency, preeclampsia, chorioamnitis, most of the neuromuscular disorders, genetic polymorphism, that is vitamin D receptor, estrogen receptor and collagen alpha 1 receptor polymorphism, male gender are more prone, postnatal factors, prolonged TPN for more than 4 weeks, bronchopulmonary dysplasia, necrotizing enterocolitis, liver diseases, renal diseases, and the medication we used in NICU, mainly loop diuretics, methylxanthine and glucocorticoids, all are responsible for the metabolic bone diseases. So whom to screen? The target populations are gestational age 30 weeks and gestational age 30 to 34 weeks with one of the following risk factor: on TPN for more than 2 weeks, or baby having cholestasis, and use of bone active medication like steroid, loop diuretics, or methylxanthine for more than 2 weeks. So these are the target population whom to screen for metabolic bone diseases. When to screen? At 4 weeks and at 2 weeks if on TPN since birth. So what to screen? The primary investigation to screen for the metabolic bone disease is serum calcium, serum phosphorus, and these are the primary investigation, serum alkaline phosphatase. So the diagnosis of metabolic bone disease, we can do the serum phosphorus and alkaline phosphatase level. If serum phosphorus level less than 5.6 and alkaline phosphatase more than 900 IU per liter, its specificity is 100%. Again, the serum parathyroid level, it's more than 100 picogram per ml is abnormal. Tubular reabsorption of phosphate in normal value is 78 to 91%. If it is more than 95% with low or normal parathyroid suggestive of phosphate deficiency. So X-ray, by X-ray, the X-ray is a late feature because only after 20 to 40% of bone demineralization, the X-ray picture is evident. So there is a Koji scoring. Grade 1 presence of bone rarefaction, grade 2, grade 1 changes plus metaphyseal alteration, shadow, and subperiosteal bone formation, and grade 3 spontaneous fracture. Again, we can do the dual energy extra absorptiometry test, that is DEXA. This is gold standard to assess metabolic bone disease. It's a low ionogic radiation, generally done in lumbar spine, forearm, on calcaneus areas. If bone mineral density is more than 0.06 gram per centimeter square. Again, we can do with quantitative ultrasound. It generally does the speed of sound and measures both mineral content and organic matrix. So how will we approach this patient? So screen calcium phosphate and alkaline phosphate if any risk factor is there. So if abnormal, if it is more than 900 and phosphate level 5.6 and normal, then monitor every 2 weeks until discharge or 40 weeks post-menstrual age. So if abnormal alkaline phosphate is more than 900 or phosphate less than 5.6, maximize supplementation calcium, phosphorus, and vitamin D as tolerated. Consider stopping bone active medication like loop diuretics, methylxanthine, or steroid, and repeat screen after 2 weeks. If no response, then X-ray, knee, wrist, serum parathyroid and 25 hydroxylase and TRP. If parathyroid hormone more than 100 picogram per ml, 25 hydroxylase D is less than 20 nanogram, low phosphorus, low TRP, likely calcium and vitamin D deficiency. Consider supplement calcium and vitamin D3 2000 IU per day for 3 months with adequate maintenance therapy. So again, if serum parathyroid level less than 100 picogram and 25 hydroxylase more than 20 nanogram per ml, low phosphate or normal elevated TRP, likely phosphate deficiency. Consider adding phosphate supplement and start with 20 milligram per kg to maximum 50 milligram per kg or per kg. So again, monitor serum calcium and alkaline phosphate every 2 weekly. Stop monitoring if alkaline phosphatase is less than 500 or 600 IU per liter and phosphorus more than 5.6 milligram per deciliter. So again, if the serum parathyroid level less than mainly phosphate deficiency, so we have to give the calcium supplement also with the phosphate, and it is because they enhance the absorption of calcium in the ratio of 2:1. And but in calcium deficiency, we have to cautious about to supplement with phosphorus because it stimulates the parathyroid hormone, and that again leads to the bone resorption that will reverse can occur. So calcium, phosphate, and vitamin D supplementation in preterm babies, according to our American Association of Pediatric and Aspirin recommendation, after getting full enteral feed, 120 to 200 milligram per kg per day by American Academy of Pediatrician, and 120 to 200 milligram per kg per day as per the aspirin. The phosphate recommendation is 75 to 100, 40 milligram per kg per day according to American Association, and 70 to 115 milligram per kg per day according to aspirin. Vitamin D, 200 to 400 IU per day. So how will you do, for the prevention, the antenatally optimally timely supplement of calcium and vitamin D during pregnancy as per the current guidelines in the mother, follow protocol for prevention of preterm labor, early detection and prevention and treatment for fetal growth retardation, because fetal, most of the time placental insufficiency leads to the, these are the antenatal risk factor, so we have to take care for the fetal growth restriction. Postnatally start trophic feed as early as possible in BLBW or ELBW, rapid advancement of enteral feed, use HMF once infant start tolerating 60 to 80 ml per kg per day of enteral feed. If feeding with HMF is not tolerated, then start elemental minerals, usually begins with 20 mg per kg per day of elemental calcium and go up, and phosphorus 10 to 20 mg per kg of elemental phosphorus, and then increase to desired required, and the vitamin D therapy also. So common pitfalls is metabolic bone disease has actually no symptom but directly lands up with complications. The best way of intervention in metabolic bone disease, optimal mineral supplementation. Thank you.
Hello. Thank you very much, Dr. Kiran Sankar. I think I discussed very well. Now, anybody want to ask any question? Yes.
नहीं सर,
Many people generally do it.
नहीं, लेकिन आइडियली नहीं करना चाहिए सर, क्योंकि स्क्रीनिंग प्रोटोकॉल फिक्स है तो स्क्रीनिंग करके ही करना चाहिए. जी जी.
Okay. Anybody else? It's okay. Thank you very much, Dr. Kiran Sankar.
Thank you sir, thank you.
Thank you.
I will request all the speaker and chairperson to please come for the memento distribution. I will request Shravan sir or Bhavesh sir to please assist in the. And moving on, next we have Dr. Neeta Kelwani. I will request Dr. Neeta Kelwani to please come on the dais. And for chairing that session, we have Dr. Vijay Kumar Singh, very senior pediatrician from Bihar, and Dr. Payod Kumar sir, very famous pediatrician from Patna. So I will request Dr. Vijay sir and Dr. Payod sir to please chair the session, and Neeta ma'am on the dais.
Thanks. Dr. Neeta Kelwani is a senior teacher and neonatologist in Ruban Hospital, Patna. She is a very dedicated pediatrician. She has interest in research and publishing papers. I know her personally, and his area of interest are patient safety and neonatal jaundice. This topic is going to be a great knowledge achievement for all the delegates. Thanks.
Can I start, sir? Yes. Good morning, everybody. So my topic is neonatal severity assessment scores. So when a newborn is ill, it's very important that assessment begins soon after birth, and not just a single assessment, but ongoing assessment is really important. Why do we need scores? Why do we need scores? We need scores because, you know, when I was in training, I used to be really fed up with paperwork. ये भरना है, वो भरना है, हिस्ट्री लिखना है. हिस्ट्री बच्चे की तो लिखनी है, लेकिन मदर की भी पूरी हिस्ट्री चाहिए. एंटीनेटल क्या था, पेरीनेटल क्या था. But then once you finish your training and you're on the other side, so you are now the treating consultant, then it makes sense, everything makes sense. So स्पेशली स्कोरिंग सिस्टम क्यों ज़रूरी है कि जिसने स्कोर लिया बच्चे का इलनेस का, वो अगर 2 मिनट बाद भी स्कोर ले तो ज़्यादा डिफरेंस नहीं आना चाहिए अनलेस कि डिजीज़ प्रोग्रेस कर गया हो 2 मिनट में. और अगर आपने स्कोर लिया है और आपके कलीग ने नेक्स्ट डे वैसे ही किसी बच्चे का स्कोर लिया है, तो उन दोनों के स्कोर में भी बहुत डिफरेंस नहीं होना चाहिए, तभी वो असेसमेंट स्कोर वैलिड कहलाता है. एंड स्पेशली विद द काइंड ऑफ जॉब वी ऑल डू, we have got juniors doing nights or out of hours shifts for us, and then you are on the other side of the phone. So as soon as they tell you कि मैम ये स्कोर है, it kind of sparks कि नहीं इतना सिक है बच्चा या उतना सिक नहीं है. So this is the importance of scoring system. The other thing is scoring सिर्फ जन्म के शुरू के 24 घंटे का काम नहीं है. इसके बाद भी बच्चा कैसा है, throughout while the baby is admitted, you have to keep on doing this assessment of the severity of illness of the newborn, because a very well baby can become sick, a sick baby becomes well, extubates and then again becomes sick. So this is kind of ongoing illness that we have to monitor. इतना ही नहीं, जब हम लोग बच्चों की छुट्टी भी करते हैं न्यूबॉर्न्स की, तो एक रैंडम स्कोर हम लोग पेरेंट्स के दिमाग में भी बिठा देते हैं कि ये डेंजर साइंस हैं, वैसा हो तो ले आना. तो इतना इम्पोर्टेंस है इन स्कोर्स का, जो 10 मिनट में कवर करना थोड़ा मुश्किल है, बट मैं ट्राई करती हूँ. So these are the tools that help us to assess the condition of critically ill newborns, and they actually help us to predict outcomes and help clinicians to prioritize care of the sick newborn. It is very crucial to identify these newborns because newborns are very resilient. The sooner you pick, the sooner you start treatment. जल्दी से CPAP शुरू हो गया तो intubate नहीं करना पड़ेगा, and vice versa. We have to be very, very observant of these newborns. So we all are aware of these common scores: Silverman-Anderson score, Downs score, newborn early warning score. I'll briefly talk about SNAP and crib. So Silverman-Anderson score is it's a very quick non-invasive tool, and as we all know, the majority of illness that we see in newborn population is respiratory. So this score is mainly focused on assessment of RDS or respiratory distress in newborn. So the areas that we have to look at is, if you imagine the anterior axillary line, so anterior axillary line के आगे है आपका upper chest, उसके पीछे है lower chest. So start from lower chest, upper chest, xiphoid, grunting and nasal flaring. ये 5 चीज़ें आपको देखनी है, very in an order. So going from back of the chest, front of the chest, xiphoid, grunting and nasal flaring. And then you give scores. So if the movement of the upper chest is synchronous, and there are no retractions, and there are no xiphoid retractions, no nasal flaring, no grunting, the score is 0. But if any of these features are present, like there is lag on inspiration, or if there is seesaw movement of the chest, upper chest, or if you see marked intercostal, subcostal recessions, or xiphoid retractions, the score worsens. So as the score worsens, the number that you allot to the score increases. So each score, so if there is no distress, the score will be around 0. If the score is between 1 to less than 3 but more than 0, that means ki you need to be vigilant and keep on reassessing this baby. This baby can become worse. So mild respiratory distress. So normally you start oxygen or nasal prong oxygen, or keep an eye if the saturations are stable. But if this is worsening, so if it's moving towards 4 to 6, that means now the retractions are appearing or nasal flaring is there. So that means this is moderate distress, and this baby probably will benefit from some more support than just oxygen, and probably some investigations as well. And if the score is more than 7, then that signifies severe respiratory distress and impending respiratory failure. So you need to be ready with escalating your care that you have to give to this newborn. So a higher score, and Silverman-Anderson score means that it's getting worse. Single assessment is not important. You need to keep on reassessing the baby. And high risk neonates, sometimes this score can be a bit fallacious, because if they are apneic or getting tired, then your score for the distress will come less. So do not just depend on the numbers, keep your eyes open. So as we saw, there is no comment on skin color, perfusion of the baby, any breath sounds, what you can hear, and respiratory rate. So this is the downside of this score. So there's another scoring system that also some units use, and that is the Downs score. Here they have covered about the color of the skin, if there is cyanosis, if the cyanosis is present in room air or on oxygen. So if the baby is still cyanosed on oxygen, the score is worse. It's 2. Retractions, as we saw in Anderson scores, grunt, whether it's audible with stetho or without stetho, air entry, whether it's decreased or not audible, and the rate, as we can see here, they have actually mentioned if there is apnea, that also means the score is worse. So जन के बाद हमें ये 2 स्कोर्स मेनली काम आते हैं. एबगर स्कोर में बहुत इंटर असेसर वेरिएबिलिटी पाया गया. So it is not very validated score, but these 2 scores can be adopted by the units. Newborn early warning score is actually short form is NEWS. For pediatrics we say PEWS, pediatric early warning score. Newborn early warning score is mainly for once the baby is admitted and now baby is on some kind of support or treatment on the NICU. So this early warning score uses traffic light system. There are various parameters, as you can see: heart rate, color, breathing, temperature, consciousness, baby is feeding and not. And one more line which has not been shown in the slide, any parental concerns. अगर parents के concern है तो उसका भी scoring किया जाता है. So this is how a news chart looks like. You can see a white color. अगर आपके उस zone में आते हैं vitals, normal में तो white रहेगा. अगर थोड़ा गड़बड़ है तो yellow, बहुत गड़बड़ है तो orange, and then red. So just because it's quite a long chart, I have shown some parameters. So suppose your baby's respiratory rate is between 40 to 60 and they are breathing in air with a normal temperature, so everything looks good. In this white row you can see the 0, so the score is 0, baby is good. But if anything deviates, so अगर rate घट रहा है तो भी score है 1, और अगर बढ़ रहा है तो भी है score 1. So this is very good for trainees and especially nursing staff, because एक चीज़ है हम लोग को रटना बहुत पड़ता है, but जैसे हम लोग सीनियर होते जाते हैं हमारा अनुभव बढ़ता जाता है, हम देख के कहते हैं ये बच्चा तेज सांस ले रहा है. लेकिन नर्सेज एंड डॉक्टर्स जो ट्रेनिंग में हैं उनके लिए डिफ़िकल्ट है इतने नंबर्स हेड में रखना कि कितना होगा. प्री टर्म है तो 60 से ऊपर, टर्म है तो 50 के ऊपर, all these. Then अगर 6 months का है तो कितना रेट, कितना हार्ट रेट. So this chart is very handy. You can actually see work of breathing. So all the parameters, there is a बीच का which is normal, and then extremes में जाएगा, then the score increases. So news score is very good. If your readings are in white column, then that means baby is fine. If they are in yellow column, then that means you need to reassess your baby again. If they are in orange, that means don't delay, do something and reassess. And if it's in the red zone, that means urgent, maybe a crash call. SNAP score is score for neonatal acute physiology. This is again used in the first 24 hours. There are lots of parameters in SNAP scoring. At least around 26 parameters. So what they did, they reduced this to SNAP 2, and they just used 6 variables in the first 12 hours. We talked in other scoring systems. Limitations is समय समय पे डेटा कलेक्ट करना होता है और मेंटेन करना होता है. उसी तरह का एक डिफरेंट स्कोरिंग है क्रिप स्कोरिंग, क्लिनिकल रिस्क इंडेक्स फॉर बेबीज. This tool is very important for, suppose if you are running a neonatal unit and suddenly you are seeing इतना mortality rate हो गया. Now the management's questioning, इतने बच्चे क्यों मर रहे हैं? You can show the CRIP score. CRIP score means कि आप अपने सेंटर पे कितने सिक बच्चों को रिसीव कर रहे हैं. क्या आपके यहाँ मेजॉरिटी बच्चे तो ये हैं सारे CRIP score के. So 5 वेरिएबल्स हैं क्रिब 2 के. क्रिब 1 आई एम जस्ट स्किपिंग बिकॉज ऑफ द टाइम. बर्थ वेट, gestational age, gender, admission temperature. We all know admission hypothermia is one of the critical things that can affect actually neonatal outcomes. And base excess. So CRIB score में हम ये बोल सकते हैं कि हमारे यहाँ का जो CRIB score है, हमारे यहाँ का जो patient profile है, उनका CRIB score high है. इसीलिए mortality बहुत है. I mean, you cannot run away by just showing CRIB score, but at least gives you how many sick patients and what kind of patient profile you are dealing with. So in the end, I'll conclude that scores are good for objective assessment of sick neonates, so keep using them. Follow at least 1 or 2 scores on your unit. Keep reassessing the scores, and the most important thing, train junior doctors and nursing staff. Thank you.
Thank you, Dr. Nita, for so nice presentation. And this scoring helps us in 3 ways. One is for the assessment of the patient and to treat. Second is about the progress, how the baby is progressing with our treatment. And third is for counseling. These 3 things are very important for me and for the new learners and going ahead. Thank you. Thank you a lot, Dr. Nita.
Thank you, ma'am. Thank you, sir. I will request you all to please come for the memento distribution. Next, moving on, we have Dr. Prabhat Kumar. I will request Dr. Prabhat, sir, to please come on dais. And for chairing that session, we have Dr. N.K. Agarwal, sir, and Dr. Arvind Kumar, sir. I will request N.K. Agarwal, sir, and Arvind, sir, to please come on the dais.
Now I welcome Dr. Prabhat Kumar. He needs no introduction. Please start the topic.
Thank you, sir. Good morning, chairpersons, seniors and colleagues. Thank you, organizer, for giving this topic to talk on the burden and screening of the heart disease, rheumatic heart disease especially. The congenital heart defect is a global birth problem, and more number in Southeast Asia, including India and China. The global prevalence of the congenital heart defect is around 8 to 12 per 1,000 live births per year. CHD prevalence in India is presumed globally because there is no CHD registry system in our country, and it varies from 4 to 13% depending on the studies type, and mainly a study done hospital or school based. Some clinical examination screening only had done. So there is bias of the prevalence. If we estimate the total number of the cases is per year in India, we have the 2.4 lakhs per year. If we count in BIHAR, we can have around 12,000 cases per year. So if we distribute the regional wise in India, we can have more than 55% cases in northern and eastern Indias. Out of the total CHD, we can have 25% of cyanotic type of CHD. If we counting the causes of neonatal mortality due to the congenital defect is around 5%, and most of the death in congenital anomalies because of the congenital heart defect, around 28%. Congenital heart defect is around the 7th most common cause of the neonatal mortality in our country. About 1/5 of the patient neonates suffer with critical congenital heart disease, which require early surgical or transcatheter interventions. Why is screening of the congenital heart defect? Because critical congenital heart defect, especially cyanotic, is more fatal if not diagnosed and treated on time. Our motto is to diagnose timely and give the good outcome to the neonate. So ideally all babies should be screened, whether born in hospital or born in the home. Should be done by trained personnel, like nurses or pediatric neonatologist or even cardiologist. Screening tools should be widely available, that is available in our clinics like stethoscopes, pulse oximeters, and occasionally have the portable echocardiography machines. Ideally, there is no single tools available for effect. There are methods by which we can screen the congenital heart defect before discharging any neonates. Like clinical examinations, if you diagnose it only by clinicals, you are able to diagnose only 52% of the congenital heart defect. So around 48% you can miss on basis of our clinical examination. You can support this screening with the pulse oximeter, SpO2 sensors, maybe the pulse oximeter, maybe the monitors, and finally by the echocardiography, particularly portable echocardiography for screening. If you want to confirming the diagnosis, you can have the better machines. We can also infer clinical suspicion of CHD by the NADA's criteria. I am not going to detail of the NADA's criteria. We are aware of this criteria. So clinical examination, how to focus, we'll go to briefly for the congenital heart defect. It should be like a general survey we are doing for other diseases from head to toe examination. So you find out where there is a dysmorphic feature or not. So to look for the syndromic neonates. It's easy to find out the cyanosis, look for the cyanosis. To see the feature of congestive cardiac failures, see the first changes will be the change of breathing pattern. See whether weight gain is losing or the gaining. You must palpate all peripheral pulses, particularly major vessels. And always auscultate the pericardium. If you are fond, you can also auscultate cranium and the liver. So cyanosis is rarely missed by pediatrician. It should be seen in natural lights, not in the artificial lights in the tightly closed NICU. It may be the physiological up to 20 minutes after the birth. Pathological cyanosis also may be like a cyanotic congenital heart disease. So always carefully see the warm or cold and how is the baby. Central cyanosis usually is detectable if having the SpO2 around less than 85%. If baby is anemic, we can miss out the cyanotic cyanosis. There are differential cyanosis. Always check the different sides, upper limb, lower limb, mucous membranes, nail fingers. May have the upper limb cyanose, lower limb not cyanose. May have the lower limb cyanose, upper limb not cyanose. That is called differential cyanosis. And also differentiate cyanosis from other causes of cyanosis, like the respiratory causes of cyanosis, neurological causes of cyanosis, hematological causes of cyanosis. And if you have find a cyanosis or not murmur or without murmur, if you want to confirm it or to further you want to screen, you can do the hyperoxia test by doing the ABG. So I'll go for the pulse examination, so I'd like to discuss on that. We should palpate limb pulses at femoral and brachial arteries. It may be in form of absent, maybe the low hollow, maybe disparity, upper limb palpable, lower limb not palpable. So like this. So preferably use your thumbs, not fingertips. Sometimes you can miss or judge the wrongly. If you have the pulse is absent in all four limbs, maybe because of the severe aortic stenosis. If disparity, then may have the cortex aorta or interrupted aortic arch. If there is volume is high, if think of PDA, small PDA. If low, maybe due to the cardiogenic shock. So murmur, pediatricians usually don't miss the murmurs. Our ear is so sensitive. So most frequent reason to referring to cardiologist is the murmur. It's not, although it's not a very sensitive or specific screen tools in neonate. Why? Because of the high PVR. We can hear murmur in the neonate. That means may have the stenotic lesions like severe aortic stenosis, pulmonary stenosis. Pulmonary stenosis in the case of ferret physiologies, and if there is no ASPS, may have the moderate to severe TR or MR in the case of the PPHN or some. May have a small PD also. So usually VSD murmur is not hard before 5 days of life, and I also have the differential diagnosis of murmur because of the functional murmur, which is found in the severe anemia. So we have the different kind of the monitor. I usually prefer to go for the cardiac monitor, which is available usually in the institutes. Peripherally, you can use the pulse oximeters also. Pulse oximeter, there is some disadvantage of using the pulse oximeter. It's not fitting properly in the neonate. So you read just only give stat values. It doesn't give the waveform, you give the random number. But its good thing is that it's cheaper, a pocket held and widely available. You should apply it on fingers, don't hesitate, don't go jump to the reports. You wait for 30 seconds, then tell what is the number. And always compare with heart rates. If heart rate is normal, then it's good. Okay. So coming to the echocardiography. For screening purpose, we should have the portable echocardiography. And portable echocardiography, new portable machines coming with a single probes like the VA scans came out recently. It goes as standard for diagnosis as well and should be the CSD focused. For that we require the minimum training for the pediatrician and other medical fraternities. It should be widely available and there should not be the P&D restriction for the portable echocardiography. Sometimes it's very good for the teleconferencing also. So in the Amrit Kal, we see the key driver of the infant survival of cyanotic congenital heart disease. I am giving the recent example of salvaging one baby. Day before yesterday, I seen the baby in the Kurji hospital. It's 22 days old only. They are admitted with the having low SpO2 on oxygen, respiratory distress. They have found out murmur of grade 2 by 6, have limb pulses, low volume pulses, on X-ray cardiomegaly. They have diagnosed as a case of congestive cardiac failure. They called me for the echocardiography, diagnosed as a case of severe valvular aortic stenosis with congestive cardiac failure. Quickly, baby shifted to the MAURYA cell on same day. And next day, we did cardiac interventions, balloon aortic valvuloplasties. And baby is doing well. So take home message is that screening not for the only hospital based, it should be all babies. Always focus on auscultating the chest, check femoral pulse before discharging and also see the SpO2 before discharge. Measure SpO2 level in good monitor which have the waveform, particularly cardiac monitors. Confirm your diagnosis by echocardiography by the trained echocardiographer. Timely refer the patients to the pediatric cardiac center where the facility for the treatment is available. And ideally is in utero transfer. If baby is still in the womb, like fetal, you can transfer to pediatric cardiac center. We can avoid so many complications to the neonate. Thank you so much.
थैंक यू प्रभात जी। एक बात मैं कहना चाहूँगा कि हमारे इंदिरा गांधी हृदय रोग संस्थान में बाल हृदय योजना, राष्ट्रीय बाल सुरक्षा योजना के अंतर्गत प्रति वर्ष कम से कम 2-3 हज़ार बच्चों का स्क्रीनिंग होता है। डिवाइस क्लोजर हमारे यहाँ हो जाता है और सर्जरी का केस अहमदाबाद साई अस्पताल को भेजा जाता है। बहुत अच्छा रिजल्ट आ रहा है इसका, आप लोग इसको देखें। और हर जिला से कलेक्ट करके हमारे यहाँ आता है स्क्रीनिंग के लिए। जिले में चिन्हित करके उसको भेज दिया गया हमारे यहाँ और हम लोग इको करके उसको फाइंड आउट कर लिया ये केस डिवाइस क्लोजर का है कि ये सर्जरी का है और बहुत अच्छा रिजल्ट चल रहा है। अभी तक हम लोग 1000 से ज़्यादा केस कर चुके हैं।
प्रभात सर, मैं जानना चाहूँगा ये लर्निंग कर्व जो है इकोकार्डियोग्राफी वेबसाइट, इसमें कितना टाइम डिवोट करे तो कोई मेरा एक पीजी काम लायक सीख ले। लर्निंग कर्व कितने समय में ये वर्किंग इको कर सकता है? अगर मैं अपने पीजी को चाहूँ कि वो, क्योंकि नया ज़माना है बेड साइड अल्ट्रासाउंड बेड साइड इको, तो लर्निंग कर्व कितना समय, क्योंकि अगर गवर्नमेंट से हम रिकमेंड करते हैं जैसे आप महावीर वात्सल्य में कर रहे हैं, तो अगर थोड़े देर के लिए अगर वो भेजना चाहें तो कितना लर्निंग टाइम उनको चाहिए मिनिमम?
थैंक यू सर। थैंक यू सर। बिहार इज नॉट बिहाइंड, वी आर प्रोग्रेसिंग फास्टली, नॉट वॉकिंग, रनिंग in the field of pediatric cardiology. Thank you. And coming to your sir question, minimum 3 months requirement for the focus training. Like if you are going to just screening of CSD, screening of rheumatic heart disease, screening for the heart failure, just like say the functional echocardiography, minimum training required is 3 months. Less than 3 months, I don't think is better for the both.
Sir, can it be in hybrid mode? Can we have a online and offline both? Because government is not going to allow too much time. So can it be hybrid mode? Can you have a online training and then contact program?
Hybrid is of course, but I'll suggest better go for the physical, sir, offline training, because you are learning lot of things. It's not that our teacher is here. They can't be the online teachers. Most of teachers are offline teachers. So learn the things meticulously, take the experience from them, and better to go for the offline, and you can support by the online classes. I not suggest for the only online classes. Hybrid okay, sir. For basic training can.
प्रभात जी की निगरानी में महावीर वात्सल्य अस्पताल में बहुत अच्छा काम हो रहा है, काफी इनका योगदान रहता है।
Thank you, sir. Thank you all the chairpersons. I will request all the chairperson speakers to please come for the memento distribution. I will request Shravan sir to please help in the memento distribution. This is come to the end of rapid rounds. हमने कोशिश किया कि टाइम पे रहे, थोड़ा बहुत डिले है, तो सारे नेक्स्ट स्पीकर से मैं रिक्वेस्ट करूँगा कि कृपया टाइम के साथ चले, हम और ज़्यादा आपकी सेवा कर पाएंगे अगर हम टाइम पे रहेंगे तो। ठीक है, मूविंग ऑन नेक्स्ट, वी हैव सब हॉट टॉपिक्स इन न्यूरोलॉजी। अभी तक हम लोग बाहरी लोगों से लड़ रहे थे, अब आपस में लड़ेंगे। सो विद द डिबेट आई विल आस्क डॉक्टर तनुश्री साहू एंड डॉक्टर श्रेया आकांक्षा फॉर डिबेट, एंड for chairing that session, I will ask Dr. R.K. Sinha sir, Bhagalpur, if sir is here, Dr. Rashmi Agarwal madam, and Dr. Manish Kumar sir, IGMS. I will request Vinod sir to please come for the chairing that session. Rashmi ma'am, Manish sir, and Dr. Tanusri and Dr. Shreya for the debate.
So, good morning to everybody. We are moving to a very interesting session, that is a debate. As Dr. Chandan had already put, it is going to be very interesting because we have two very eminent speakers speaking on a topic that is PDA. So we all know that PDA has various modalities of treatment. Either we have to decide whether we have to treat or we don't have to treat. So that depends on the size of the PDA, and we have two eminent people, one of them being Dr. Tanushree Sabu. So Madam is presently Associate Professor of Pediatrics at AIIMS Bhubaneswar, and she's done her DM Neonatology from AIIMS New Delhi. She has a number of publications to her credit, and she's currently one of the most sought after teachers in Bhubaneswar. The other person who would be countering her is Dr. Shreya Akanksha. So Dr. Shreya, having her post-graduation from Kolkata, NRS Hospital, has done her DM in neonatology from Lady Harding. She is presently working at Rani Children's Hospital and doing very well. So I welcome both of you to please start.
Okay. Thank you all for giving me the opportunity, and let me first have that disclosure. PDA is a well-going debate topic everywhere, most of the conferences. Even after a lot of studies have gone years together, we still are in confused state. So my aim is to decrease the confusion little bit. I am not going to have a word fight with my colleague, but I am going to convince the audience and my audience today that start treatment of PDA not only yearly or late, but when it is required timely. So this is my aim and take home message. I am coming from the reverse side. So I am first telling my take home message, then I will tell why I am telling that one. Okay, so with antenatal steroid coverage is there, and baby is requiring CPAP little bit higher setup. 7 CPAP, PPAP 7, and FiO2 of 50%, and a screening echo is done, which is showing a PDA duct of 3.5 mm. Flow is pulsatile pattern, and left pulmonary artery end diastolic flow is 0.5 meter per second. Left ventricular outflow, we did all PDA parameters basically, is also higher side, 650 ml per kg, and LAO ratio is 2.2, and there is some reversal in the descending aorta. So in that case, most of our audience, what will do? So day 3, okay. So most of them will probably go for treatment because the PDA is hemodynamically significant. Baby is around 26 weeker, and the baby is also requiring higher CPAP support. CPAP support typically 5 or 6 is acceptable, 7 is little bit higher side. So many of will vote here, whoever is sitting here probably will vote to treat PDA. So for treating PDA, it will cause yearly closure, prevent its complication, and some respiratory benefit is also there. So before that, I will just have a little bit understanding what is PDA, and it is like persistence of pulmonary circulation, pulmonary patent ductus arteriosus after birth. Typically 50%, most of the cases in term PDA will close within 96 hours, while preterm PDA, they less likely to close, but however they will gradually close. And less than 28 weeks, around 40% of the PDAs will close, less 60% will gradually close beyond 7, and some of them will require treatment. Most of the PDAs are asymptomatic, we need not treat, while some of them will have hemodynamically significant PDA as defined by echocardiography or clinical parameters. And if not treated, they will have some complications, and why they have complications I will be describing later. So what are the controversies? We are covering only 1 or 2 controversies, first because of the use of pharmacological drugs, but the benefit in terms of translation into decreased reduction of BPD, overall death, overall NEC, feed intolerance, the benefit has not been observed in the group which has been actively treated for PDA. So that is why there is no very convincing evidence whether we should treat PDA, and if expectant management is done, then till what period we should wait and watch, whether we should treat early, late, or we should have some threshold, and which babies are required, which babies are likely to get benefit from PDA. It has been shown the babies more premature is the babies, less likely that PDA will close spontaneously, especially if the babies are less than 28 weeks. And if they have some other comorbid conditions like SGA, sepsis, RDS, they are also less likely to have the PDA will close without any medical intervention. So this one I have already told. So okay, so why we should go for, because I am telling for treating aggressively for PDA, so why we should treat? If we are not treating PDA, as we know, PDA will cause pulmonary overflowing, and if it remains untreated, subsequently it will cause pulmonary hemorrhage, and it will require high persistent pulmonary arterial hypertension, and if still remains untreated, longer duration of ventilation will gradually lead to chronic pulmonary disease or bronchopulmonary dysplasia. And similarly, it causes pulmonary overflowing and systemic hypoperfusion. And because of systemic hypoperfusion, all end organs which are dependent on blood circulation like perfusion, like AKI, IVH, or you will have NEC, and sometimes you might have shock. So these are the side effects if we are not treating PDA. And it is our postulate that if we are treating PDA, baby can be weaned off the respiratory support yearly, so that baby can be discharged well, and some of them has seen that baby can be discharged and they can be made off respiratory support. So some studies have shown that even if we are not treating PDA, and those babies whom we are treating aggressively PDA, the hazard risk for death is almost 8-fold if we are not treating PDA, especially for ELBW babies. So what are the treatment options available? Having said that, classically previously people have used prophylactic therapy, like baby is born, PDA is there, and we are starting treatment. And some of them are gradually from prophylactic therapy, we are gradually moving to yearly targeted pharmacotherapy, and if it fails, we are going for surgical therapy. So evidence-wise, prophylactic therapy is nowadays not given. Previously in 1980s, many trials have shown that prophylactic indomethacin therapy decreases the surgical ligation. One of the classic studies, TIP trial, suggested there is lower risk of IVH in the group which has been treated with prophylactic indomethacin therapy. However, overall, there is no improvement in the survival or neurodevelopmental outcome. That's why nowadays most of the centers are not using prophylactic therapy. So I would also not encourage any of you to start treating prophylactically any PDA. So next, moving to yearly targeted therapy. So recently Cochrane has published a review, Cochrane review ka meta-analysis. Like in 2022, they found 16 Cochrane reviews have already been done in PDA. They have combined the result of all Cochrane reviews and found what is the result. So they found prophylactic indomethacin is decreasing IVH. However, overall composite outcome is not changing. while prophylactic ibuprofen, very less reduction in IVH, and paracetamol, there is no evidence. So if you for treatment of prophylactic therapy, only indomethacin has role, and that is also not getting translated to decrease in IVH or reduction. So now moving to yearly targeted pharmacotherapy. So yearly targeted pharmacotherapy, we have two options. We have three options. We can give either indomethacin, ibuprofen or paracetamol. So these are the three classic trials, like PDA Tolerate trial, another is Beniductus trial, and third one latest published is Baby Oscar trials. So most of the trials, the duration which yearly targeted means baby has started having some symptoms, and yearly. How yearly it is? Some of the trials have shown 6 to 14 days, others have shown around median hour of 66 hours, some of them are showing 72 hours. First trial had any kind of yearly rescue therapy in either ibuprofen, indomethacin or paracetamol. The second trial had used ibuprofen, and third trial Baby Oscar also had used ibuprofen. All trials have included the babies less than 28 weeks, and they found that overall our target of decreasing death and BPD is not very significant. However, if you give there is decrease in the closure of the PDA yearly. So this is one of the trial. This is the Baby Oscar trial, the latest one. Here you can see primary outcome is not significant. It is 69% versus 63%. So with that, prophylactic therapy can be given, and safety wise, most of the drugs are safe, and most of them are effective in treating. And however, what Cochrane meta-analysis is saying, for symptomatic PDA, all three drugs are equally effective: indomethacin, ibuprofen and acetaminophen. The evidence is high quality, moderate quality and low quality for indomethacin, ibuprofen and acetaminophen. And dose wise, if you are treating, give oral ibuprofen better than IV ibuprofen, and higher dose of ibuprofen is better than the standard care. This evidence is mostly from Cochrane. There is a network meta-analysis done by Souvik Mitra et al. So last option for treating is surgical. So recently there is a shift from treating prophylactic surgery because it is an invasive procedure. So nowadays primary criteria after failure of medical therapy of roughly 2 courses of any kind of pharmacotherapy, and adverse outcome, what we are afraid that adverse outcomes like post-PDA ligation syndrome or phrenic nerve palsy, pneumothorax, chylothorax, residual duct, these all complications as hyped is not actually that severe. If it is done in expert hand, the adverse effects of surgical therapy is very severe. So my take-home message, not to treat surgical ligation as the primary option, it should be used as a rescue modality. So last thing I would like to tell of, recently there is a gradual shift from the surgical open thoracotomy and ligation to transcatheter ligation, which is done by a method known as small amplasure device of Piccolo method. So many institutes are gradually using, but however there is head-to-head trials are not there. Most of the evidence is stemming from the case series or retrospective case reports. So they are also saying if the center has expertise, we can use it very safely, and the side effects are even lesser as compared to open surgical therapy. So having said that, so my recommendation or my talk is that prophylactic therapy I should not give. Yearly fluid restriction is useful. We should give yearly symptomatic therapy for medical therapy, and watchful expectancy we can keep up to 2 weeks after medical therapy. If persistent PDA, so we should give medical therapy within 2 weeks, and if after 2 doses there is no response, we can consider going for surgical facility if you have options for surgical facility. So I would go for the middle path. I will vote for the middle path.
Would you close your talk, ma'am?
Yeah. I am just finishing in next 30 seconds. So I will go for a middle path, start treatment, but not yearly symptomatic treatment, but take into account of neonatologist, pediatric cardiologist and parents into account, take their counseling and advice, and reserve surgical treatment in case of medical therapy. So lastly, in medical science, nothing is black and white. These are all shades of grey. So it is up to you. You have to choose which shades of grey you have to take. Okay, thank you.
So is there any, after second speech, some question answers as well.
Yeah, good morning everyone. So Tanushri ma'am has very well demonstrated as to what to do with PDA and what not to do. I shall be trying to say something new what they have given in the articles. Okay. Now, as to why shouldn't we wait and not treat PDA very quickly? So PDA, it is a never-ending saga. Actually, we do not know as to we should treat or we should not treat. So the first rationale as to why I would not like to treat PDA very quickly is that it is a physiological phenomenon and there is a high spontaneous closure rate. मतलब PDA जब होगा तो वो ऐसे ही जो है term बच्चों में तो खुद ही से close हो जाएगा. Even greater than 30 weeker, because it is a matter of concern in preterm babies, no? Greater than 30 weekers में भी 6 दिन में ये close कर जाएगा. And less than 26 weeker में भी लगभग 2-3 महीना में ये close कर जाएगा. So what the trials say, the PDA tolerate trial, it says that 40% PDA patients, they did not have any respiratory distress या कुछ भी symptoms at all नहीं थे. और टिप ट्रायल में भी हमने देखा कि इवन 500 to 900 ग्रामर जो बहुत छोटे बच्चे थे उसमें भी 50% of them never developed any clinical sign despite having a PDA in them. So here we can see that we are concerned with the smaller gestational age regarding PDA. तो less than 26 weeker में भी spontaneous closure जो है 36 weeks में हो जाता है, latest by 2 years. Second rationale of not treating it कि किसी को पता नहीं है कि हेमोडायनेमिकली सिग्निफिकेंट पीडीए एग्जैक्टली कहते किसको है. इसका क्राइटेरिया जो है बहुत क्लियर नहीं है. पीडियाट्रिक कार्डियोलॉजिस्ट हमें बताते हैं कि 11 क्राइटेरिया है और प्लस डक्टल स्टील और पल्मोनरी ओवर सर्कुलेशन जो है वो सब हमें देखना है. बट ऑल ऑफ अस आर नॉट हैविंग सो मच टाइम ना कि 11 क्राइटेरिया हम बैठ के देखें. तो जितनी भी स्टडीज़ हुई हैं उसमें कोई भी क्लियर इको क्राइटेरिया नहीं है कि तुम ये करोगे तो यही हेमोडायनेमिकली सिग्निफिकेंट पीडीए है. मेनी ऑफ द स्टडीज दे हैव यूज्ड साइज ऑफ द पीडीए एंड LAO रेशियो. सम ऑफ देम हैव यूज्ड साइज ऑफ द रेशियो एंड वेदर इट इज पल्सटाइल और नॉट. तो हमें पता ही नहीं है कि एग्जैक्टली हेमोडायनेमिकली सिग्निफिकेंट पीडीए जिसको हम ट्रीट करना चाहते हैं वो है क्या चीज़. एंड व्हेन द डायग्नोस्टिक क्राइटेरिया इज नॉट वेरी क्लियर, so we do not know as to who will benefit from it. Third rationale being that in the recent studies we have seen that there is no patient important benefit from early NSAID therapy. So what the recent studies they say regarding the benefit? The controversy started in 2010. It was the first time when they showed that treating PDA had no evidence of benefits. So the recent trials, that is the Benedictus trial, it was done in less than 26 weeker newborns and they saw that there was no, मतलब NEC में, BPD में and death में कोई significant सुधार नहीं हुआ PDA को treat करने से. On the contrary, BPD का incidence in the treatment group increase कर गया. Similarly, the Baby Oscar trial, they also showed that death में या फिर severe BPD at 36 weeks में कोई भी difference नहीं था. This is the same showing over here. In 2025 also, Indian Academy of Pediatrics उन्होंने कुछ recommendations दिया PDA के treatment को लेके. तो उन्होंने साफ साफ कहा कि prophylactic treatment तो आपको करना ही नहीं है. ये एक physiological phenomenon है, वो जैसा है उसको रहने दो. Symptoms नहीं आएगा, मत treat करो. नंबर 2, conservative management को लेके इन्होंने कहा कि fluid restriction ठीक है, आप consider कर सकते हो. फिर आपका जो ventilator settings है उस पर बहुत research नहीं हुआ है, yet to be studied. लेकिन क्लोजर को लेके इन्होंने बहुत क्लियरली कहा कि लेस देन 2 वीक्स में आपने नहीं क्लोज करना है इसको. मैं आगे बताऊंगी व्हाई आरंट वी क्लोजिंग. एंड ग्रेटर देन 2 वीक्स में अगर सिम्टोमेटिक रहता है और बहुत दिक्कत पैदा करता है देन वी माइट एज वेल कंसिडर टू क्लोज इट. नाउ वी आर वेरी मच कंसर्न्ड कि बच्चे का न्यूरो डेवलपमेंटल आउटकम इससे क्या होगा. मैम टोल्ड कि ब्लड फ्लो जो है CNS में कभी ज़्यादा कम होगा तो IVH PVL वगैरह हो सकता है डक्टल स्टील की वजह से. So this is another trial, that is your TRIOCAPI trial. It was published in the year 2024. इस ट्रायल में जो है लेस देन 28 वीकर्स, आप देख रहे हैं सारे ट्रायल्स जो हैं 26-28 वीकर्स पे ही किए गए थे। ऐसा नहीं है कि हम लोग कोई टर्म बेबीज के बारे में बात कर रहे हैं। सो दे स्टार्टेड क्लोजिंग द PDA एट 6 to 12 आवर्स एंड नंबर्स वर 228। दे सॉ कि अर्ली ट्रीटमेंट से उसके न्यूरोलॉजिकल आउटकम में कोई फायदा नहीं हुआ PVL के रेट में या IVH के रेट में। Similarly, the PDA tolerate trial also, they also showed that कोई बहुत benefit इन्हें PDA ligation या फिर NEC, BPD इन सब में नहीं हुआ। These are some recent RCTs. Now, rationale number 3, क्यों नहीं treat करना चाहेंगे? Definitely जो ibuprofen, indomethacin, जो भी drug हम दे रहे हैं, उसमें बहुत सारा side effects है। So, these have your renal साइड इफेक्ट रहेगा, तुम्हारा इश्केमिया हो के NEC हो सकता है, ओलिग्यूरिया हो सकता है। एंड वी कंसिडर पैरासीटामोल कंपैरेटिवली सेफ, बट इसका भी न्यूरो डेवलपमेंटल आउटकम पे लॉन्ग टर्म में क्या इफेक्ट है वो किसी को पता नहीं है पैरासीटामोल का। सो दिस इज वन आर्टिकल दैट वेरी क्लियरली इलस्ट्रेटेड दैट बहुत सारा साइड इफेक्ट्स इन ड्रग का है, कोई भी दवा खाने से साइड इफेक्ट तो है। And similarly, paracetamol has some relationship or possible association with autistic spectrum disorder, yet not very proven. And secondly, paracetamol जो है वो बहुत ज़्यादा effective भी नहीं है as compared to brufen जब closure rates को लेके हम लोग बातचीत करें। अब बात करते हैं कि क्यों नहीं ट्रीट करना चाहते। भगवान जो भी देते हैं वो भले के लिए ही देते हैं। तो PDA जो है ना वो फिजियोलॉजिकल इन नेचर है, क्योंकि ये इतना चेंज कैसे हो गया 10 साल में, ट्रीट करते करते अचानक से बोलता है तुम ट्रीट मत करो, NEC नहीं होगा, कुछ नहीं होगा। तो भगवान की इच्छा सबसे अच्छी इच्छा है। सो इट इज़ अ फिजियोलॉजिकल फेनोमेनन। होता क्या है कि लोग पहले बोलते थे कि पल्मोनरी ब्लड फ्लो ज़्यादा लेफ्ट टू राइट हो रहा है तो उससे ओवर सर्कुलेशन होके चलो तुमको BPD हो रहा है। अब उल्टा बोलते हैं, लोगों का विचार बहुत चेंज करता है। अब बोलते हैं कि ज़्यादा ब्लड जो जाएगा ना वो एक्चुअली इश्केमिया और एंजियोजेनेसिस में एड करता है। लेफ्ट टू राइट शंटिंग होगी तो इश्केमिया या फिर एंजियोजेनेसिस में उसको आसानी मिलेगी। उसी तरह लेफ्ट वेंट्रिकल का फंक्शन जो है डीकम्प्रेसिव इफेक्ट, मतलब उसका ब्लड जो है लेफ्ट टू राइट जाएगा तो लेफ्ट वेंट्रिकल को फायदा होगा ना डिकम्प्रेस होकर, वो अच्छा कॉन्ट्रैक्ट करेगा। तो ये एक सामान्य फिजियोलॉजिकल फेनोमेनन है, कृपया उसे बहुत ज़्यादा मत टच कीजिए। इट इज़ एन अडेप्टिव रिस्पॉन्स अंग्रेजी में बोले तो। अब मॉडर्न एविडेंस है कि एक मेटा एनालिसिस किया गया था जो लास्ट 15 साल के RCTs को ज्वाइन किया और इसमें भी देखा गया कि फायदा तो छोड़ दो NEC या BPD में, नुकसान हो गया। BPD का व्हाट डिड दे फाइंड कि BPD का नंबर जो है वो और NEC का और डेथ का नंबर ही बढ़ गया PDA को अर्ली ट्रीट करने से। सो दिस वाज इट। नाउ सम फ्रीक्वेंटली आस्क्ड क्वेश्चंस। सो क्लोजर रेट्स ड्रग से बहुत हाई है तो उसको क्यों नहीं क्लोज कर दे? अरे तभी क्लोज करेंगे जब उससे कुछ फायदा होगा ट्रीट करने से। यू वांट कि NEC, BPD, डेथ हमें नहीं हो डक्टल स्टील से, जब उसी में फायदा नहीं हो रहा है तो ट्रीट क्यों करेंगे हम लोग? सेकेंड वन इज कि सब लोग बोलते हैं अरे PDA से लेफ्ट टू राइट शंट बहुत ज़्यादा हो जाएगा, पल्मोनरी ओवर सर्कुलेशन होगा, वेंटिलेटरी रिक्वायरमेंट बढ़ जाएगा, इपनिया हो जाएगा। लेकिन अभी तुरंत एक मेटा एनालिसिस 2025 का मैं दिखाई जिसमें कहा गया कि ये एक फिजियोलॉजिकल फेनोमेनन, सामान्य फेनोमेनन है जिससे लंग को खून मिलता है ताकि उसका डेवलपमेंट अच्छा हो। तो आप PDA वो खून को बंद कर देंगे तो इश्केमिया हो के बाद में BPD हो जाएगा। सो यू आर अगेन नॉट क्लोजिंग। क्वेश्चन नंबर 3, आप बोलेंगे अरे चलो तुम्हें बता रही थी कि ब्रूफेन से बहुत ज़्यादा दिक्कत होता है, साइड इफेक्ट है, ऐसा है वैसा है, तो पैरासीटामोल से हम लोग बंद करेंगे। वी लव पैरासीटामोल। अगेन क्लोजर रेट जो है ब्रूफेन के तुलना में पैरासीटामोल का ELBW में काफ़ी कम है क्लोजर रेट। और सेकेंडली ऑटिस्टिक स्पेक्ट्रम डिसऑर्डर में कुछ तो रिलेशन है, तो हम बच्चे को मानसिक रूप से विकलांग तो नहीं करना चाहेंगे, दैट इज फॉर श्योर। नाउ लेट्स कंटिन्यू। अब बोलते हैं कि तुम बहुत हाई डोज ब्रूफेन का दे दोगे पक्का डक्ट बंद हो जाएगा। ठीक है, डक्ट तो बंद हो जाएगा, फायदा कुछ नहीं होने वाला, उसके अलावा साइड इफेक्ट्स होंगे सो अलग है। थ्रोम्बोसाइटोपिनिया होकर बच्चा ब्लीड करना शुरू करेगा एंड देन AKI हो जाएगा, NAC हो जाएगा, खाना वाना कुछ नहीं पचेगा उसका। द नेक्स्ट वन इज कि इफ ड्रग्स आर नॉट गुड, मैं इतने देर से बोल रही हूँ ड्रग्स आर नॉट एट ऑल गुड, सो व्हाई नॉट डू कैथेटर क्लोजर। मैडम वेरी वेल सेड कि आजकल अच्छा अच्छा कैथेटर क्लोजर का डिवाइसेस आता है, आउटकम्स भी बहुत अच्छे हैं। सो आई टेल यू कि अगर PDA मान लीजिए ड्रग से नहीं क्लोज होता है, यू कैन ऑप्ट इन फॉर कैथेटर क्लोजर अगर प्रोलॉन्ग्ड वेंटिलेशन का रिक्वायरमेंट है एंड यू आर एट्रीब्यूटिंग कि हाँ मेरे PDA के वजह से ही ये सारा है। सो टू कंक्लूड दैट अर्ली रूटीन यूज ऑफ NSAIDs ऑफ PCM तो बिल्कुल नहीं करना है। कंजर्वेटिव मैनेजमेंट करना है, सिलेक्टिव स्ट्रैटेजी, और तुम्हें एस्केलेट तभी करना है जब वो परसिस्टेंटली फिजियोलॉजिकली पेटेंट अगर रहेगा, यानी 2-3 हफ्ता तक भी वो क्लोज नहीं कर रहा और आपको लगता है कि उसी के वजह से बच्चे को सारी दिक्कत है, देन डेफिनेटली थिंक ऑफ क्लोजिंग इट. थैंक यू.
Thank you, both of our doctors. Since there's lack of evidence for this management of PDA, so there's always controversy in this thing. And both of you speak very well, and I think the middle path is the best way to manage the cases, as PDA is not physiological thing, and if any issue with a newborn is there and PDA is there, which is clinically significant, we must do something for that PDA. Sir.
So thank you so much, both of you. एक कहावत है हिंदी में, को बड़ छोट कहत अपराधु. मतलब you both have done extremely well and you have presented your side in a very nice way. But still, we as neonatologists, we are very much fond of closing the PDA if they are significant, and if your LR center is more than 1.5, or if there is associated this thing, congestive heart failure, our ventilator setting is requiring higher PEEP, and so in these conditions we do close, and we always think that paracetamol is a very safe drug. And now we have forgotten to use ibuprofene and ibuprofen. So paracetamol being the safest drug, and the efficacy of both of these three drugs are similar. So that is there. So
सर, कहीं सरस्वती और लक्ष्मी का मामला तो नहीं है? सरस्वती कह रही है कि पैसा मत खर्च करो, लक्ष्मी कह रही है कि खर्च करा दो. अब वहाँ दुर्गा जी बैठी हुई हैं, उनसे पूछ लेते हैं.
And if there is any question from the audience side.
Thank you. Both speakers told about the PDA. I think PDA itself is the pathological, ductus is a physiological, and I agreed the ductus will never close if the PVR is high. So it's physiological. Whenever the PVR is getting slower, getting lower and lower, the PDA, the ductus, getting closer. So we'll never try to close ductus or PDA by any means whenever the PVR is high. Second thing is that PDA think whether the PDA is responsible for congestive cardiac failure or something else. If PDA is symptomatic, whatever the index you said, then you treat. It's gold standard teaching to treat the congestive cardiac failure due to PDA, first with the medical therapy, then failed, then go for the transcatheter or surgical therapy. It's gold standard teaching. So there is, of course, there is if and buts, some in favor of closing, not closing. But I think the PDA is pathological and always needs closure if symptomatic. Thank you.
Sir. Dr. Raja, sir.
That is your perspective of a pediatric cardiologist. But as a neonatologist, we always believe in normal physiology. And PDA, as Shreya told, that it is a physiological thing. So whenever if you are doing echo, if you have any evidence of pulmonary hypertension, anything right to left, a little bit of, even in the bidirectional sun, there is a right blue jet is coming down. So that means PVR is high. You should never close it, first thing. And if it is left to right, try to manage as conservatively as far as possible. If you are failing in conservative management, then you go for therapy, drug therapy. And we are talking about PDA of prematurity, and most of them close by itself. Some may require medicine. Very, very few will require the surgical intervention. Okay, thank you.
So how do you mean by failed pharmacotherapy? 2 doses?
That means two courses or 3 and courses. Still requirement is high. Even after 2 courses, if requirement is not very high, we can wait. Yeah. And if with time it will close. And if it is not getting closed by 4 weeks, 6 weeks, still PDA is creating problem, then you should close it.
Okay, thank you.
Thank you all the chairpersons, and we must congratulate Dr. Tanushree and Dr. Shreya for setting the moments of the, and there is one more question from that Dr. Prachi.
I have one question. In PDA with PPHN, so if the eco findings are still left to right and PDA is significant, when I have been in such situations, PPHN pressures are high, and so that time we did not treat PDA, and slowly the pressures now start falling. However, PDA is still open and it is showing a left to right shunt. So when do you think in PDA with PPHN should we treat or should we leave it? I have been trapped in such a situation many times.
Thank you. Like others have already noted that PPHN or increased pulmonary hypertension in any conditions of SGA or PPHN meconium aspiration, PDA will not close. In fact, PDA is a protective mechanism. First, let the PPHN settle. What is the underlying cause, whether it is meconium aspiration, birth asphyxia, all other things settle. After that, if PDA is persisting and causing symptoms, then we should treat.
So ma'am, if PDA is left to right and PPHN is settled down, that time also we will wait for PPHN to settle down.
First, you give all treatment to PPHN settling, like conservative management, decrease pain, maintaining euglycemia, iron electrolyte imbalance, maintaining high blood pressure around 50th centile. All these conservative management for PPHN. Once it settles, then you feel whether PDA is causing symptoms. Symptomatic, hemodynamically significant PDA, then only you treat.
Okay, thank you, ma'am.
Just a small word regarding PDA. We have talked of when to close, how to close. In certain complex cardiac pathologies, as would be well known to Dr. Prabhat, there is a situation when we would like to keep that PDA patent till we land the patient in surgery. So that should also be kept in mind. That is one situation where this PDA is actually helping the child reach the table where they can be corrected of the complex pathology. So with that, thank you so much and congratulations.
Thank you, sir. Thank you, ma'am. Please come for the memento distribution. And thank you. This is the real topic of debate कि बंद करना है कि नहीं करना है. मैंने तो नहीं समझा क्या करना है. So a big round of applause for all the participants. And moving on next, we have I will ask Dr. Rita Bora ma'am to please come for the next session. And for chairing that session, we have Dr. Sujit Kumar, Dr. Abad Agrawal sir, and Dr. Sandeep. Dr. Rita Bora ma'am. And for chairing such session, Abad Agrawal sir, Sujit sir is here. Dr. Sandeep Kumar from Chapra. I will ask Dr. Nigam sir to please chair this session. कोई बात नहीं सर.
Good morning, everyone. The topic, as is evident, is ethical dilemma to resuscitate or not to resuscitate, peri-viable period and end-of-life considerations. Many a times in the newspaper, it is headlines that a newborn was thrown in the garbage, and later it was found that the child was alive. And the medical team was accused of negligence. So this situation is really very, very common. And when you are resuscitating a newborn, many times you come across that the child is not viable and later on the child was found to be alive. So what is the exact criteria in which we should stop the resuscitation or keep going on? When we were postgraduate students, we were taught that you should resuscitate at least for 30 minutes. Later on, the criterion came to be 10 minutes. So what is the exact situation? Will be deliberated by our esteemed speaker. She is Dr. Rita Bora. She is Professor and Head Department of Pediatrics in Assam Medical College, Dibrugarh. She is Her areas of interest in nutrition, sepsis, and neurodevelopmental. And her major achievements are she's EB member, NNF, and all, you can see it on the screen. And she has a lot of publications, 56 publications and 9 book chapters. So she's really a good speaker and a person of national fame. And we will all be obliged to hear from her.
Thank you, sir. So at the outset, I would like to thank the organizers for giving me this opportunity to talk on the topic of ethical dilemma to resuscitate or not to resuscitate in peri-viable period and end-of-life decision. And I bring greetings to you from Assam Medical College and Hospital, Dibrugarh. So globally, almost 13.4 million babies are born prematurely, of which 4% are labeled extremely preterm babies because they are born before 28 weeks of gestation. India being contributing to almost 20% of these preterm babies, we have a large number of babies who are born before 28 weeks of gestation, and peri-viability has emerged as one of the greatest challenges of bioethics. So in today's discussion, very shortly, we will try to discuss regarding the definition of peri-viability, clinical outcomes and prognosis, ethical principles in peri-viable neonatal care, parental involvement and decision making, guidelines and best practices for management, challenges and controversies in care, end-of-life decision and future directions. So the American Academy of Pediatrics and American College of Obstetrics and Gynecology defined peri-viable birth as those infants who were born between 20 weeks to 25 plus 6 days of gestational age. So 20 weeks has been taken because now the threshold for fetal viability in India is still in the gray zone and no specific dates are known. Practically in most of the tertiary level care centers, it is taken as 24 weeks in where the survivability is there. But for the SCNUs, it is still taken as 28 weeks of gestational age, and it has also been recommended by the medical legal cell of Indian Academy of Pediatrics. However, there is no consensus as of yet. Peri-viability, therefore, is a fluid term for us, and this is the period of technologically assisted potential survival. Since viability is defined as a potentiality rather than a fixed attribute, it is now very difficult to say precisely below which gestational age life is not possible in our scenario, and when life is definitely will be there and NICU care should be the norm. So now looking at the clinical outcomes and prognosis for these peri-viable babies, in 2022, the Vermont-Oxford network reported NICU survival rates of 21%, 46%, and 63% for babies born at 22, 23, and 24 weeks of gestational age. So in the Western countries, the survivability rate has been improving significantly, but we do not have such national data. Historically, the gestational age boundaries of peri-viability have been based on mortality and morbidity data, which is both dependent on birth weight and gestational age. Now, antenatally, mostly we take the gestational age as the cutoff, but there are a lot of challenges in taking that, because if we look at a baby who is at 23 weeks of gestational age, a 23 plus 0 baby would be looking like a baby, would be behaving like a baby who is at 22 weeks, but a baby who is at 23 plus 6 days would be behaving like a 24-weeker. So there are chances that there can be under or overestimate of the effect of gestational age to make prognostication. And also there are other factors like sex, birth weight, whether the baby is singleton or multiple, exposure to antenatal steroid of the mother, and maternal health conditions, as well as where the baby is being born, which will affect the mortality and morbidity. So at present time, care recommendations can be very difficult at times. So in summary, we can say that for us in India, peri-viability is a fluid time period now, and survival rates greatly has improved, and it increases as the gestational age increases. Outcomes are better in high income countries as compared to lower and middle income countries, but this difference may not be only related to the economical condition, but also because of the different cultural and local practices which we have in our hospitals. And also there are high risk of neonatal morbidities like IVH and all, as well as long-term morbidity like neurodevelopmental impairment in these babies who are born at peri-viable period. And the spectrum of survival ranges from near certain death to survival without severe morbidity. Now, what are the ethical principles and variable this peri-viable pregnancy? So these are similar to what we have for other periods of life, like beneficence, that is doing good by optimizing survival and minimizing harm, non-maleficence, avoiding or prolonging suffering with futile interventions, respect of autonomy, that is consideration of parental rights and informed consent, and justice, that is equitable use of resources and fair treatment for the neonates. However, although the principles are similar to other periods of life, there are certain challenges in this peri-viable period, like beneficence and non-maleficence are to be delicately balanced during this period. When we think about this, protecting the sanctity of life, we might go for aggressive management of these babies, but we have to remember that a baby who's been born before 26 weeks of gestational age, aggressive treatment may not be always beneficial, maleficent, or justified, just because we are trying to prolong the life for a certain duration. And also the fetus or the neonate doesn't have autonomy, cannot exercise this autonomy. So at periods when complex scenarios are there, the surrogate has to be the physician or the parents who have to take the moral duty to act in the best interest of the infant. Now, what is the best interest? There is also ambiguity for defining this best interest of the peri-viable infant. Treating a baby just to keep him alive or her alive may again lead to potential disabilities. So balancing these survival chances against the quality of life is important. And there can be at times discrepancies between the health worker provider recommendations with the parental decisions. And also we might have certain dilemmas of resource allocation in the NICU. So in an article which was published in 2021 by Gikoi et al., this is from Greece, so they had mentioned about a prognosis-based framework for decision on resuscitation and intensive care for extremely premature neonates. So they had included the prognosis for average gestational equivalent infant, and this can be useful not only for the tertiary level care centers, but also data can be extrapolated to our SCNUs, where the chances for poor outcome if intensive care is provided is less than or equivalent to 50%, and then we can go for the treatment. If the chances for poor outcome is more than 90%, then we can go for palliative care. And if it is between 50 to 90, decision becomes very difficult. And here comes the option for parental wishes. Now, we can see here that when the outcome is very clear that the baby is going to survive, then we can go for treatment. But if the baby has a chance that baby is going to have poor outcome, the certainty is almost more than 90%, then we are going to go for only palliative care. And in the middle zone, there is difficulty to decide because it will be in a gray zone. And there comes the responsibility of us to involve the parents in the decision making. So parents can act as surrogate decision makers for this neonate when the neonate is lacking autonomy. There is a need for comprehensive counseling during this period for the parents on risk, benefit, and prognosis. The parental goals would be survival focus or minimizing the suffering. And we also need to respect the parental wishes, but within the medical feasibility. And for that, we need to go for a joint counseling, that is counseling by both the obstetrician as well as neonatologist. So joint counseling sessions with the expectant mothers, parents are very important, where initially there should be a multidisciplinary care planning meeting where we would discuss regarding the standardized protocols for antenatal and neonatal management. We will do effective communication to minimize the conflicting information to the parents. The gray zone would be made less gray now, and then subsequently we will debrief after delivery to optimize the care pathways. There are benefits of this collaboration, as has been mentioned in different literatures from the Western countries. So there is improved neonatal survival and reduced complications, better parental counseling and decision-making support, and also streamlined care pathway from delivery to the NICU. Now, what would be the roles of the obstetrician and neonatologist in the collaborative counseling? So obstetrician can counsel regarding the probable prognosis using evidence, and then can outline the various modes of obstetrical management, but at the same time they also have to make the parents understand regarding the maternal risk associated with different management modalities. So here we can say that in a peri-viable pregnancy, the lower section of the mother is not yet well formed, and it has been seen in different studies that cesarean section at this peri-viable period can lead to a lot of complications in the subsequent pregnancies. Now the neonatologist can complement obstetrician's information and can focus on the management plan after the baby is being delivered, and also have to inform about the cost of hospitalization. And if relevant than palliative care also needs to be discussed. Now, the American Academy of Pediatrics has certain recommendations for approach to joint specialty counseling at extreme prematurity. So they have mentioned that pre-counseling huddle should be there between the specialties, and then a joint counseling should be done where we need to incorporate and understand the parental values and priorities. We should also recognize their biases. Then ultimately we need to offer options including comfort care, then develop joint understanding of plan, and also acknowledge the dynamic decision making process. So whatever is true today may not be true tomorrow, so that needs to be kept in mind. And then post-counseling debrief should be done. So there are certain best practices which has been mentioned by the American Academy of Pediatrics while doing counseling with multidisciplinary colleagues. So these are using of similar phrases to avoid confusion for the parents, invite clarification if jargon is being used, avoid biased language and terminology, acknowledge emotional challenges of such conversations, invite participation, politely interrupt when needed, redirect the conversation, and show respect and gratitude to team members to promote trust. So again, there are studies which have shown that although at times we need to go for individualized or sequential counseling because of parental requests or time constraints, but still joint counseling by obstetrician and neonatologists for such periviable pregnancies have shown much weight than the individual sequential counseling. Now this is a systemic review on studies on periviable counseling practices which was published in the Frontiers of Pediatrics in 2025 by Peterson et al. As you can see, most of these studies were from the Western world. So we are lacking in data regarding these counseling processes or periviable neonatal treatment. So the themes which they have noted in these counseling practices was transparency. So there has to be transparency when we counsel the parents. There has to be a will for collaboration with the parents, and we need to empower them. However, even with all this counseling, there can be at times conflicts, and to resolve these conflicts, we might have to take help of the ethical committees of our institutions or ethics consultant if they are there as mediators. So in summary, we can say regarding counseling is that there are complexities in managing periviable pregnancies. Counseling assumes the most significant role in periviable discussions, and involving parents helps for shared decision to help in decision making in the gray zone, and combined counseling of parents and family by the obstetrician and neonatologist, very important, using transparency, collaborating with them and empowering them. And the message which we need to give should be without any fragmentation or should be consistent. Now lastly, the guidelines and management. So as we have made the decision, we have made a shared decision. We have provided the justice to this periviable baby. The antenatal intervention should be provided. We need to again assess the baby at birth, and stepwise evaluation of the resuscitation versus comfort care has to be provided. We also need to keep in our mind institutional policies and legal considerations, and postnatal care should be tailored according to the condition of the baby as well as parental preferences. So this is one article which was published in the Indian Journal of Pediatrics in 2025. This is from South Korea, this study, where the authors tried to investigate the impact of proactive perinatal care on periviable preterm infants before and after its implementation. So they had studied for a period of 10 years, from 2013 to 2022. From 2013 to 2019 was a period where no proactive perinatal interventions were given, and beyond that period, proactive care was taken for these periviable pregnancies. And they had 125 babies included in the phase 1 and 37 babies included in the phase 2. And the mortality which was noticed in the first phase was 68, which was significantly higher than the mortality which was observed in the second phase. And you can see here the survival rate had increased significantly in the period when proactive perinatal care was given, and the survival rate of very preterm babies like 22 weeks were also possible in that period, whereas it was not possible in the initial phase. So they concluded that proactive perinatal care is related to lower mortality rate of these periviable infants. They also concluded that maybe it would also help in better neurodevelopmental outcome because the incidences of intraventricular hemorrhage, periventricular leukomalacia, all these were significantly less in those babies who had received proactive perinatal management. So this is another study which was published again in Frontiers of Pediatrics, including 69 studies from 25 countries, including high and middle income countries. They were trying to look at the survival outcomes among periviable infants, comparing different outcome countries and time period. And what they had noticed was that over the period from before 2010 to 2020 onwards, over the period, the survival rate has increased among babies who were born in the periviable period, but it was more so in the high income countries as compared to the lower and middle income countries. In the lower and middle income countries, we can see that it was almost nil. So what we can conclude from these studies is that if we go for proactive perinatal management, probably many of our periviable babies would survive. So lastly, regarding the end-of-life decision, so if you have decided about end-of-life decision, then it is not that we just keep the baby aside, but palliative care in terms of thermal care, relief of hunger and thirst, focus not on growth, but for comfort and relief from pain and discomfort should be there. This should not be, the care should not be given only in physical terms, but also emotionally to the parents and also spiritually. Now, regarding the periviable period in Indian law context. So there was an article which was published in the BMJ regarding periviable birth legal landscape in Indian jurisprudence by Dijikar et al. Dr. Kartik Nagesh was also in the group. So they had given certain key points. So these key points are, periviability presents several legal challenges in India where extreme premature neonates are conferred personhood and constitutional rights despite lacking a clear viability threshold. So if the baby is born at any gestational age, if the baby is live, this is a person and we are supposed to give care. Indian courts mandate life-saving care for live-born infants post-termination, even if it was a termination of pregnancy. So reinforcing the duty of care under Article 21, making nuanced pragmatic decisions for periviable infants more challenging. Parental consent is necessary but not absolute. In periviable cases, decisions must be prioritized the infant's best interest through shared judgment with legal and ethical oversight. Leave against medical advice protocol offer limited clarity in neonatal context. Current framework works in inadequacy, which is their frameworks, is inadequately addresses consent, liability, and end-of-life decisions for sick neonates. High financial burden and limited infrastructure challenges the equitable neonatal care. So these are some of the key messages which they have given, and they have also given the different case scenarios from which they have found out these legal implications. So this is a free article, so people who are interested can go into the net and then get the article. So lastly, I'll just mention about the future directions. Periviable care in India requires individualized, ethically informed and family-centered approach. We need for improved long-term outcome prediction models. There has to be a collaboration between obstetric and neonatal teams, which is lacking many a times in the institutions, and there is a need for ongoing research and ethical discourse for guidance refinement. So thank you for your patient hearing, and I would like to complete with the quotation from Mother Teresa. She says that be faithful in small things because it is in them that your strength lies. Thank you again.
Thank you, Dr. Itabura, for your nice presentation, but I think the gray area will always remain, and it will be a very challenging situation actually about taking this decision of DNR. It's an extremely difficult situation for anybody, and certainly that in India, you don't have much of studies for that. Most of the studies are from high-income group countries. There was one which was having both high-income group and LMIC countries where you were showing one study, but most of the studies are from the high-income group countries.
Yeah, so we need to do more studies on that.
I think we need to do more workup, more studies before we can arrive at some situation, and it's very difficult, at least for the parents, to take a decision of that side. Yeah. I mean, ethics committee is fine. I totally agree with that. But the parental decision in our country, I mean, of course, you have to place all the facts and figures together before taking decision, but it will be a difficult situation. So the gray area will definitely remain in our country, and I think we need more studies to finally arrive at some some guidelines to do that, Indian.
Yeah, actually NNF has thought about a consensus guideline. Like a committee has already been formed and they are planning to go for it.
That's
to build up a consensus.
I think this is the need of the hour.
Yes.
I think if they are doing, then it's fine.
Yeah, I am also a member of that committee.
Oh,
so
wonderful.
Sir, it is already in the process.
Yeah.
And we, out of like 10-15 people are there in the group. And
Wonderful.
very soon, within 3 to 6 months, we will be coming with the guideline.
Wonderful.
From the NNF side, what to do about the
I'm very happy with
part.
that situation.
And one thing I want to add, we are always talking about the neonatal perspective and the parent perspective. But on the other end, obstetrician and neonatologist also are party. And we have to take care of themselves also, because we do not think that only the parents are aggrieved. When I am carrying a mother for say 6 months or 7 months or term, and suddenly there happen some things that I say that we are have difficult resuscitation or we cannot resuscitate the baby. Even suddenly, last 2 days back, everything was going right. Suddenly the patient developed intrapartum eclampsia and baby born asphyxiated. By chance the baby was survived and in ICU, but there is a one party, obstetrician and the neonatologist. Please take consideration when you are going to frame the guidelines. Thank you.
Thank you, ma'am. Thank you, sir. I request the chairperson to please come for the memento distribution. I will request Shravan sir to please assist, or Om Prakash sir. Moving on, next we have 2 panel discussions. We all know that there is elections going on outside the hall and inside the hall. So going on with the temper of the माहौल के साथ हम लोगों ने 2 पैनल डिस्कशन रखे हैं. The first panel discussion, I will request the moderator, Dr. Rajesh sir, to please come on dash. And for chairing that, I will again request Dr. Rijwan Haider sir, Darbhanga, and Dr. Nigam sir for chair the session. And Rajesh sir, please. Sir, up next minute.
Good morning, everyone. And I'll just call my panelists, Dr. Raju Sharan from Jamshedpur, Dr. Swagata from Kolkata, Dr. Binay from Patna, Anil Patna, Prachi from Begusarai. हाँ एक और चेयर एक माइक है
I'm very happy with this topic actually, and I'm interested since my student days how to improve in our situation the low middle income group. What are the low cost interventions? And this was actually discussed while I was in UK. This was being discussed even there. So in our country I think we need more discussion about it. And I'm sure that a person like Dr. Rajesh will throw actual light about that. And we have got a good team of panelists. I think we should go ahead with that.
फर्स्ट स्लाइड प्लीज ओके. लगता है सर अब हम सीनियर हो गए, क्योंकि अब PPHN, PDA और रेस्पिरेटरी फेलियर से घट के अब DCC, मोर्टेलिटी, इन्फेंट मोर्टेलिटी, न्यूनेटल मोर्टेलिटी, ये सब साइन है कि लोगों ने समझ लिया कि अब हम सीनियर हो गए. तो ऐसे ही टॉपिक लोगों ने देना शुरू किया है. ठीक है, सो विल इज अ वेरी गुड टॉपिक एंड although like young minds will feel that this is a boring topic, but this is a burning topic, and we should have a holistic approach for neonatal care. And if you see under 5 modality in India, you can see post-infant mortality till 5 years, we have come down to 4 only. thanks to immunization and diarrhea treatment, pneumonia treatment, all those things, we have come down to 4 post-infancy below 5 years. Post-neonatal infant mortality, it has come down to 6. We have done very well for last 30-40 years. Even the late neonatal mortality is 6 only now, after 7 days life till 28 days of life. But first 7 days, or I will say rather first 3 days of life, it is really problem now. It is almost 13 per 1,000 live birth. If you see the percentage wise, neonatal mortality is almost close to more than 60%, 2/3 of the under 5 mortality. You can, a few years back, 5-7 years back, it used to be 2/3 of infant mortality. Now it is 2/3 of under 5 mortality. And early neonatal mortality is almost close to half of the under 5 mortality. So we have to focus mostly on the in the labor room and the deliveries, early neonatal care, all these things are there. But we have done remarkably well for last few years. I have taken 89 because 89 I joined the MBBS. I am from the 89 batch. And that time the neonatal mortality in India was 59, you can imagine, 59 per 1,000 live birth. It is data from United Nations Interagency Group on child mortality. Now it has come down to 17 per 1,000 live birth. So you have done remarkably well. Under the Modi government, what has done from 14 to till now, if you see under 5 mortality, sorry, back जाओ, back 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 bas okay, thank you. Under 5 mortality from 45 we have come down to below 30, so almost 47% decrease in 11 years. But neonatal mortality has come down to only 27%. So we have not done that great in the neonatal mortality. And if you see the causes of mortality, like when I was MD, the first cause was birth asphyxia that time, then sepsis, then it used to come prematurity and congenital malformation. If you see data now, the prematurity and low birth weight is the first. Almost 1/3, more than 1/3 of neonatal mortality is prematurity and low birth weight. Second is infections. Next panel discussion is there on infections, the burning issue. And the birth asphyxia has come down to 20%. 10% is the congenital malformation. Slowly and slowly congenital malformation is taking, and the management of, they are more focused on management of congenital heart diseases and other congenital abnormalities. 10% are others. But it is possible to come down to less than 10. And if you see this report, September 6 this year report, Kerala hits neonatal mortality rate below 5. You can imagine. If Kerala can do it, everybody can do it in India. If you see the data of 23, SRS data 23, there are 6 states in India where neonatal mortality is single digit. Kerala, Tamil Nadu, Goa, Sikkim, Manipur, Nagaland. 7 UTs, it is less than 10. So we can also do it. So 11 is taken as an auspicious number in our society. So I have taken 11 interventions that can be taken as can be done easily. So most important is the mid one, early, essential early newborn care. Then we have antenatal steroid, magnesium sulfate, resuscitation, early CPAP, surfactant. Nowadays, it is taken as a low cost, high impact intervention. When I was doing MD, that time surfactant, इतना महंगा सामान, इतना महंगा दवाई कौन यूज करेगा? ऐसा था. There were so many cost analysis, cost benefit analysis about the surfactant. Now it has come down to low cost, high impact intervention. You can imagine surfactant. Then KMC, exclusive breastfeeding, donor milk. Again, pasteurized human donor milk. There is a need for establishing many human milk banks to save the premature babies. Then your infection control and transport. We need to do a lot of things to be done for the transport. The first question from Dr. Rajeev Sharan. What is the impact of antenatal steroid on neonatal mortality and morbidity? What are the indications? What is the regime? What is the current status of use in India?
Yeah, thank you very much. Regarding antenatal steroid, what is most important, when we started our PGs and all those things, at that time it was said, if nothing works, steroid works. Now coming from that era to era where we have an indication, and I can say that yes, this is the most important indication is for the preterm babies. Now when to give, which one to give is the issue. So 24 weeks to 34 weeks. 34 plus 6 is the indication that we need to give. 34 plus 6, if there is a possibility and if you suspect that yes, there is a possibility of RDS, which is seen in 3 to 4% of the cases, you can give. Below 23, as Madam has just suggested, 24, Madam has suggested, you have to see the viability. If viability is there, you can think of giving steroid antenatally to the mother. But yes, obviously, most of the studies that have been done has shown that the drug is wonderful and it's very, very effective. Coming to the controversy between betamethasone versus dexamethasone, as far as both the medicines are equally good, and both the medicines are equally good, can be given. Betamethasone may have some upper hand. Yeah, dexamethasone is cheap and easily available and can be given, and dose it has to be given in 48 hours. That needs to be given, and that is most important. Another question is, can be yeah, most of the recommendations, like WHO recommendation is to give only once, but other RCOG and AGOC, they recommend. Yeah, so can be given in few cases only. Regarding the use, the last question that was there is, what can we do? What is the percentage of use? Now, in corporate sectors, obviously in the private hospitals, it is as good as 80% using antenatal steroid. Government hospitals, and particularly in district hospitals, it is around 30 to 40%. Reason being, and the government is working a lot in this field. I must congratulate the government for that. It's not only availability, but the WHO has come up with a trial, they call it the trial, an Action 1 trial, and there they suggested that the readiness, preparedness should be there, readiness to give the ANC, this antenatal steroid should be there. That means indiscriminate use of antenatal steroid will lead to problems, more of an infection in the mother and the baby, and hence they say that first of all you can give only if there is a possibility of a preterm between 24 to 34 weeks, if the mother is on labor and which is going to deliver in next 7 days, if there is no infection, and if there is a possibility where the baby will be delivered.
But ifs and but doesn't come under the government policies. It has to be very simple. So government guideline is less than 34 weeks. If ASA worker feels that there is a need, the baby is going to be delivered, she is empowered to give dexamethasone in the village itself. You can imagine the government policy.
And then refer. But the baby should be delivered in a place which has
that is there, but
care.
ASA worker is empowered to
yeah.
give dexamethasone now. Government policy is like that. Okay, coming to other antenatal interventions, Swagato. It has not taken place that much not in use as compared to antenatal steroid, but still it is very helpful.
Yes, sir.
Can you elaborate what is the impact of Maxulf? Indications, what is the regime and what is the current status of the use?
So, thank you, sir. So, Maxulf has a definite, the studies are showing that definite impact on reducing the cerebral palsy as well as reducing the IVH. So it has a definite, it has reduced the incidence of cerebral palsy and IVH. Now what is the indications? The indication must be the patient has less than 31 plus 6 weeks and immediate preterm delivery. That is the indication. We cannot give on every mothers. And what is the how can you determine that it is an imminent preterm birth? So it must be active labor or with more than 4 centimeter cervical dilatation with either failure or contraindication to tocolysis or progressive changes in the cervical dilatation, premature rupture of membrane with active labor or planned delivery. So now, what is the dose? Dose that will give the, I think, 4 gram IV over 30 minutes, followed by Maxalt. We give.
All these things are to be done by the obstetricians.
Yes,
As a
sir.
pediatrician and neonatologist, I feel our job is to keep on reminding the obstetrician.
Yes, sir.
Whenever you go to labor room, madam आपने दिया कि नहीं दिया, antenatal steroid दिया कि नहीं दिया, magnesium sulfate दिया कि नहीं दिया. If you keep on hammering to them, see, obstetricians are very difficult to change. Sir लोग senior हैं, सब लोग बताते हैं, very difficult to change them. But our job is to keep on hammering. जहाँ भी आप 30 weeks का हो रहा है, मैडम आपने मैक्सल दिया कि नहीं दिया, antenatal. If you ask 100 times, then she will feel that at least it has to be done. Okay, so our job is like that. Okay?
Along with the continuous fetal heart this surveillance.
वो तो ठीक है, तो उनका काम है, हमारा काम है हैमर करना,
रिमाइंड करना है,
रिमाइंड करते रहना, ठीक है. सर लाइजनिंग कोई काम नहीं करता ऑब्स्टेट्रिशियन के साथ, ऑब्स्टेट्रिशियन को खाली हैमर करना है, समझ गए ना. अपनी बीबी को आप 10 बार बोलिएगा तभी कुछ काम करेगी, एक बार में कभी नहीं सुनेगी. So Vinay, I will come to the what is in our purview, and we need cooperation from obstetrician. Okay. So what do we mean early essential newborn care? What are the components and how does skin to skin contact and early initiation of breastfeeding help in decreasing the mortality and morbidity?
So, early essential newborn care is set of evidence-based intervention to provided to all newborn to better outcome and growth of development of the baby. The factor involved in the essential newborn care is first is immediate and thoroughly dyeing of the baby, skin to skin contact, delayed cord clamping, and early initiation of breastfeeding. The first component start with the early essential newborn care is with first is thoroughly dyeing. The baby born within 30 seconds we have to dye the baby with thorough and give in the skin to skin contact to the mother. So we can initiate breastfeeding as early as possible, as less than 1 hour of the time. Skin to contact prevent the baby from the hypothermia.
I will interrupt. And this should be the norm. And such a beautiful picture. Everybody will love this. Even the mother will love it. Obstetrician needs to be convinced about this, and we have to do it. Continue.
After the born, baby should be placed on the mother and turn the head around and keep the baby with a warm linen. And it prevent from the hypothermia. It stabilizes the baby with bradycardia and stabilizes the heart rate also. It's develop the mother and baby bonding. It also helps in the bacterial prevention to prevent from the infection.
This is very important. The mother flora will get colonized on the baby. If you put the baby on the warmer, hospital flora will get colonized on the baby. So it makes a lot of difference. Okay?
But keep in the mind one thing, during dying, don't remove the vernix also.
हाँ, vernix देखिए vernix लगा हुआ है पूरा.
Yes, sir. So next part is early initiation of breastfeeding. It should be done within the 60 minutes of the birth. It's help in the baby the blood sugar maintain, prevent from the hypoglycemia. It's regulate the baby heart rate and respiration also. It can prevent, the data shows it can prevent the 20% of the neonatal death, which WHO reported.
So I am from JIPMA, and that time we had very broad tables, almost one 1.25 मीटर का टेबल हुआ करता था, लेबर रूम टेबल. We used to wonder कि इतना मोटा बड़ा टेबल का क्या काम है. But in JIPMA that time 89 also, mother has to feed before getting up from the labor table. Even after cesarean, she has to feed the baby, then she is allowed to get up from the table. So Dr. Srinivasan was there, I know who was the senior people, TP Srinivasan, he was very pro for, he was mad for the breastfeeding. Policy was she has to breastfeed, then only she is allowed to get up from the table. That is early initiation of breastfeeding. And Anil? Yeah. And this is also an area, delayed cord clamping. It has got he will tell you what are the impact, but it is not being practiced. We all know this, it is helpful, but it is not being practiced. How it is helpful?
Now the delayed cord clamping has become very important policy just after the delivery. And as we know that if the clamping occurs between the 30 to 60 seconds, it is early. And after the 60 seconds, 1 to 3 minutes, it is the delayed clamping. There are so many advantages of the delayed clamping. You can say here that these are the different guidelines of the different organization, that WHO said that it should be more than 60 seconds in the preterm baby. Term baby more than 60, so 1 to 3 minutes, and it has a strong recommendation from WHO. In the American College of Obs and Gynae, it is 30 to 60 seconds. Term baby 30 to 60 seconds. There will be vigorous infants monitor, and we should monitor for the jaundice also. The Canada Pediatric Society is also recommends the 60 to 120 minutes and 60 seconds. In the Royal College of Obs and Gynae, this is the British organization, it may they recommend up to the 5 minutes. And it is very much that the maternal preference supported and claimed by the 5 minutes. In the FIGO, that is the International Federation of Gynecology, it also goes up to the 3 minutes. So these all are the guidelines given by all the organizations. It is very important because the delayed cord clamping is very important, because the delayed you can say here the different meta-analysis of the randomized trial, that these are the different inclusion criteria. You can say that the mortality is reduced by 42% in the case of baby giving the DCC, and the intraventricular, there is no difference in the intraventricular hemorrhage, and the blood transfer is very much low, at 58%, because it maintains all the hemodynamic indices in the baby. And because you know that the iron is very important for the neurodevelopment, so it also protects, also enhance the stores of the iron in the baby up to 3 to 5 months. Aeration, ABC of the cord management, if there is a good aeration of the lungs, the breathing is established, then we will go for the clamping. If we will do the early clamping, so there may be a chance of potential injury to the heart. And if we will do the cord clamping after the establishment of the aeration and breathing, there will be increased pulmonary blood flow, and that will give the essential necessary preload for the left ventricle to function.
This is called physiological cord clamping. Yes. Means the lung is filled of fluid in utero. Now it has to fill with the air. Blood has to go to the lung, then it has to go to the left heart. So once lung is prepared for the outer world, then only you should cut the clamp. That is the basic idea. Yes, once baby is active, breathing, cut it. There is no hurry to cut the cord. Again we have to keep on hammering the obstetrician. So और क्या करते हैं, cut किया बच्चा को दे दिया. तो again वो बताते रहना है. We have to keep on telling कि madam.
We have to convince the madam for the delayed cord.
हाँ मैडम को बोलते रहना है बार बार. मैडम वही मत काटिएगा, मत काटिएगा, मत काटिएगा. तब वो सुनेंगी, ठीक है? Otherwise,
if you do early cord clamping the preterm baby, then it will be the increase swing in the blood pressure of the baby, and baby also the increase the several blood flow.
उनको बोलना है कि मैडम
harmful to the preterm baby.
बच्चे को शॉक में हो जाएगा, ब्लड ट्रांसफ्यूजन देना पड़ेगा. आप ही बोलिएगा कि ऐसा ब्लड क्यों जरूरत पड़ रहा है? सब मैडम आपने जल्दी काट दिया, है कि नहीं? तो हाँ तो इसके लिए एंड जरूरी है कि कन्विंस करना मदर ऑब्स्टेट्रिशियन को कि इतना ज़्यादा फायदा है डिलेड कॉर्ड क्लैंपिंग, एंड इट इज़ वेरी वेरी हेल्पफुल. इधर अपना इफ यू टॉक टू द फैमिली बिफोर बर्थ, वो ज़्यादा अच्छा है. एंटीनेटल क्लिनिक अगर हो रहा है कभी तो. हाँ प्राची, there's a lot of emphasis on this neonatal resuscitation, but it still needs lots to be done, isn't it?
Yes, sir. Sir, the first discussing the need of NRP. Sir, as far as I know, I have been working in a very rural place for last 3 years, and जो भी data sir बता रहे हैं ना कि 20% birth asphyxia, I am telling you it is much worse in the rural places, and neonatal जो mortality rate बिहार का, sir, there is data 32, but I am sure it is more than that because it is not being reported in the rural areas. बहुत ज़्यादा न्यूट्रल डेथ्स हैं, और सर मैं बता सकती हूँ मेरे सेंटर पे 40 to 50% बर्थ एस्फिक्सिया केसेस है, and death related death is 40 to 50%. It is not 20% in rural parts of Bihar and Jharkhand, because when I shifted from a metro to a rural, and then I saw कि whatever we are discussing, this data is only from metros and not from rural, and rural is different. Birth asphyxia is prominent still in rural places, so the need of NRP is huge. And the problem is even the traditional birth attendants, they are not even don't know how to do EMBO, and उनके लिए कोई program नहीं है. तो sir, this is data, very few neonates will require NRP. 85% will be normal, 10% will breathe in response to drying and stimulation, and 5% will require PPV, 2% will be intubated. Sir, I think the real catch is between this 5%, because most deaths are happening in villages, in small towns, जहाँ पर PPV करना भी अभी भी even traditional birth attendant को नहीं आता, आशा को नहीं आता sir. They are not able to do PPV. So this program is extremely important if we want to change Bihar and Jharkhand area. And sir, 2% intubated तो बहुत advanced NRP वाली जगह पे हो सकता है, at least हम उस 5% को कम कर सकते हैं. And we all know sir, there is during it decreases sir, this is data, stillbirth by 21%, 7-day mortality by 47%, and perinatal mortality by 37%. So it is having huge impact. And sir, this is only one study which I could find where how training of ASHA workers has reduced the death rates in some very interior. So sir, मैंने rural data लिया, Gonda, Aligarh, Raebareli. This is only one study from India. Otherwise rural area से कोई study currently available नहीं है. तो उन्होंने काफ़ी difference 30% तक mortality decrease किया है show में. And this is sir meta-analysis 11 studies, and they have showed neonatal mortality, first day mortality. We all know. But thing is to focus. Sir, I think we are still not focusing on the rural areas.
See, neonatal care, I think we are almost 20 years behind.
Yes sir, we are.
Than the states like Kerala and Tamil Nadu.
Yes sir.
So we have to do lots. As Prachi was saying, कि data जो है skewed है. ऐसा नहीं है, because combination of Kerala and Jharkhand or Bihar. So it is come down like this.
It's a skewed data.
A skewed data. Rajiv, again, this is an intervention which needs to be hammered again and again on the pediatricians.
Yeah.
We know CPAP is helpful. What is the early? I am not talking about CPAP. I am talking about the early CPAP. You tell
or
me.
labor room CPAP. You know, it's very difficult to teach the residents and doctors about FRC. So what I tell them, anecdote, is look, if I have to give money in your pocket, if I have to give 1 lakh, your pocket should be sufficient size to get it. Otherwise it will not go, and that's what happens with the newborn babies. Their capacity is so low, whatever oxygen you'll give will not go. So we need to increase the capacity, and here you have to start CPAP as early as possible, probably start with the labor room. So any baby who's breathing and is in distress, oxygen is not going to work. It's the CPAP, and that is what the early CPAP is all about.
So
that is
guideline is any baby 34 weeks less than 2 kg requiring oxygen needs to be a started CPAP in the labor room.
Yeah. So oxygen will not go to the baby until unless CPAP is given. So, and it's going to reduce obviously mechanical ventilation, intubation, and the role of surfactant also to a great extent. Early CPAP are those babies who come from the labor room to the nursery and they started having distress. Then the early CPAP should be given, and again it is beneficial because the baby will be able to breathe easily and will get the oxygen, the requirement is there. And obviously it helps in reducing mechanical ventilation, intubation, surfactant, and everything. So yes, CPAP and particularly early CPAP has a major role to play.
Also, like when we are shifting the baby from labor room to the NICU, on the way, During transport also CPAP has to be given. It is not a big thing. T-piece device,
resuscitator
you
is
keep
one of the
on
best.
Baby's nose, that's all. Nothing. You have to set down the 6 and put on the baby. And just keep on holding and shift the baby to an ICU. That's all needs to be done. That's all. So, delivery room CPAP, CPAP during transport, and continued CPAP in the NICU. Okay. Sagata?
Yes, sir.
I am from the era like surfactant use hona shuru hua tha. That time used to one vial of survantana used to cost in late 90s 18,000 rupees. 18,000 rupees उस समय.
Yes, sir.
बाद में गवर्नमेंट ने जो DPCC में ले आया essential drug है. Surfactant is considered to be essential drug by the government of India, isn't it? And the cost उसका ceiling है, price का ceiling है by the government DPCC. So why do we feel that it is considered to be a low cost first of all, and what is the impact? First of all, answer me, why do you feel that it is a low cost, high impact intervention?
Yes, sir. So, surfactant, these are, of course, those who are in the CPAP failure, the criteria, not only reduces the incidence and severity of RDS, it reduces the mortality, reduces the need for oxygen, reduces the ventilatory support, as well as the pneumothorax, as well as the BPD. So, ultimately, NICU stay reduced, NICU cost reduced, so ultimately the cost, it is very much cost effective.
So it has again, to go into the minds of all pediatricians. It is usually much more cost effective than not giving the surfactant.
Yes, sir.
Okay, and you have to convince the parents also like this only.
Yes,
कि अगर आप surfactant नहीं दिएगा तो बच्चा वेंटिलेटर पर चला जाएगा, कितने दिन रहेगा वेंटिलेटर पता नहीं, ब्लीडिंग हो जाएगा, मर भी सकता है ज़्यादा. Surfactant दीजिएगा, वो सब आप अवॉइड कर सकते हैं.
Prolonged ventilatory support, prolonged. Again, you have to do the early. The patient who's indicated, it has to with the early, because early surfactant giving is the reduces the mortality, reduces the early chronic lung disease as well as the.
Saugata, one question, like, is X-ray necessary before giving surfactant? Is X-ray necessary before giving surfactant?
It is not mandatory.
Okay. So many times ना सर X-ray कर लेंगे उसके बाद surfactant देंगे.
नहीं सर.
ऐसा नहीं है. ठीक है. So surfactant can be given if you feel clinically it is RDS and oxygen requirement is more than 30% on CPAP of 6 or more, you have to give surfactant. So delivery room CPAP, transport, giving CPAP, CPAP in NICU and early surfactant. This is the crux of management of respiratory distress in premature babies. Binay, again this exclusive breastfeeding, we are talking for last 50-60 years, exclusive breastfeeding. What is the prevalence and what are the factors helpful in promoting the breastfeeding?
Early breastfeeding means you have to initiate the breastfeeding at least.
Not early, it is exclusive breastfeeding.
Yes. Early means less than 1 hour.
No, exclusive, we are talking about the exclusive breastfeeding.
Exclusive breastfeeding for 6 months. The
exclusive breastfeeding, what is the prevalence?
Yeah.
And what are the factors helpful in promoting exclusive breastfeeding?
The prevalence of exclusive breastfeeding, overall the global data is saying around the 40, less than 50%, 46, 49%. If talk about the India, the NFS data 5 shows, we are now on the as of 41.8% data shows we are on the, but still very low. But good news is if we compared with the NFS 4 data to NFS 5 data, NFS 4 data shows the exclusive breastfeeding rate was only 25 to 26%, but we are now reaching to 41.8%. Still the delivery, the NFS 5 data also shows the deliveries of cesarean section hospital delivery is 88%, but the breastfeeding rate is still 41.8%, which is much lower. We have to increase the data.
So, क्या-क्या कर सकते हैं?
Yeah, first factor is 2 factor involved, 3 factor, mother factor, baby factor, and the also society have to play a role in this. The mother, we have to first educate the mother, the benefits of breastfeeding. मदर को हमको कन्विंस करना है कि ये जो दूध है बच्चा का, वो फर्स्ट जो आर में हम लोग देते हैं एक्सक्लूसिव 6 मंथ तक, वो अमृत के समान है, उसका कोई जोड़ नहीं है. तुम्हारा बच्चा मजबूत होने वाला है. तुम्हारा मदर, एटलीस्ट वी हैव टू कंज्यूम द मदर, एजुकेट द मदर and talk about the benefits of breastfeeding.
As a pediatrician, whenever you go to the maternity home or the hospital, first contact with the family and mother, you should emphasize on exclusive breastfeeding. और दूसरा है कि हॉस्पिटल में बॉटल दिखना नहीं चाहिए, है कि नहीं? दिखना ही नहीं चाहिए. और हॉस्पिटल का जो बगल में दुकान होता है, वहाँ भी बॉटल नहीं रहना चाहिए. और बॉटल नहीं दिखना चाहिए. हमारे स्टिल आई रिमेंबर जिपमर ना, आवर सर HOD सर ना, we before he comes to OPD, we used to go and see all the attendant. If anybody has bottle na, if he sees bottle, he will get wild. So our as a resident, we used to get क्या bottle किसी के पास तो नहीं है, वो लेके हटाओ इसको, समझ गए ना. और हॉस्पिटल में ब्रेस्ट फीडिंग, बॉटल फीडिंग तो क्राइम है. आप पता नहीं, मेरा भी OPD में मैंने भाई सी बॉटल ना, आई गेट वाइल्ड. आई डोंट नो. मैं तो बोलता हूँ कि मैं पूछता हूँ कि मदर आती है कि लोड़ी है घर में, तो बोलती हाँ सर है, तो चूर दीजिए जाके उसको. अगर पैसा चाहिए तो हमसे पैसा ले लीजिए, मगर उसको चूर दीजिए जाके, सीधा रखिए मत घर में, नहीं तो कोई ना कोई पिला देगा. सो एक्सक्लूसिव ब्रेस्ट फीडिंग इज, वी हैव टू बी प्रोएक्टिव. कहने का मतलब ये है, वी हैव टू बी प्रोएक्टिव. वेदर यू गो फर्स्ट कॉन्टैक्ट इन द OPDs, आवर जॉब इज टू कीप ऑन रिमाइंडिंग देम कि you have to exclusively breastfeed. नहीं सर, मैं तो हायर फैमिली को बोलता हूँ कि YouTube देखते हो, तो हाँ सर YouTube देखते हैं, तो खाली उसमें देख लो कि हार्मफुल इफेक्ट्स ऑफ बॉटल फीडिंग टाइप करो, ठीक है, टाइप करो कि जाके एक्सक्लूसिव ब्रेस्ट फीडिंग का बेनिफिट क्या है. ये 2 टाइप करके आप YouTube सर्च कर लो, आप कन्विंस हो. मेरे बोलने से नहीं होगा, आप YouTube से ज़्यादा सीख लो, ठीक है. Anil,
thank you, sir.
Again, we are talking about the prematurity. Prematurity is the commonest cause of neonatal mortality nowadays. So, what is kangaroo mother care? Government has done lots. We have done lots. We still practice a lot, but still, in our side, there is a lacuna. Many of us don't use it.
Kangaroo mother care is a method of care to the low premature baby.
And these are the very beautiful pictures. ठीक है. And every mother NICU में जब भी बच्चा तो आपको लगा ठीक है, तो baby should be like this. Baby mother should come to NICU and sitting there.
Premature baby or low birth weight baby for the skin to skin contact to the mother or any other caregivers. There are 4 components of this KMC. That is, the first is the skin to skin contact. Second is the early discharge of the patient with the advice to have the home KMC, and also there is a follow-up cases, and there is also reduce the minimizing all the effects of the baby.
So,
and
कहने का मतलब KMC हम लोग पढ़ते हैं लेकिन प्रैक्टिस नहीं करते हैं. इंडिया में वही ना कि नोइंग एंड डूइंग गैप इज काफ़ी ब्रॉड है, ठीक है. हम लोग सबको जानते हैं KMC हेल्पफुल, लेकिन करते नहीं है. अगेन KMC का चेयर खरीद लेना ज़्यादा कॉस्टली आता नहीं है चेयर, ठीक है. प्लास्टिक का ही मिलेगा, 400-500 रुपये में मिल जाता है, बस काफ़ी है. उससे भी ज़्यादा सस्ता पड़ता होगा.
As we know that KMC has been started in the Columbia, Bogota, and there is a very characteristic advantage of the KMC, because it will reduce the hospital stay, and also for the good care for the baby both in the hospital and in the home also. It also minimizes the hospital infections that may occur in the hospital, because we advise for the home KMC.
Next question, I will go fast. Prachi, what is PHDM and what are the benefits?
Sir, PHDM is pasteurized human donor milk. MOM is mother's own milk. And PHDM is vital in saving preterm babies because it reduces necrotizing enterocolitis by up to 79%. And rest ROP, there is good developmental delay. Infections and chronic lung disease are reduced by it. So,
what are the challenges?
सर फर्स्ट बिहार झारखंड में कोई ह्यूमन
झारखंड में हमारे पास है
आपके पास है
1.5 year
हाँ ओके सर
झारखंड बिहार में तो कुछ
बिहार में नहीं है सर सर मेन इशू फंडिंग है सर इट इज वेरी कॉस्टली
नहीं कुछ कॉस्टली नहीं है दैट्स व्हाई आई एम पुट दिस थिंग मिल्क बैंक सेटिंग द मिल्क बैंक विल कॉस्ट यू लेस देन 10 lakhs less than 10 lakhs
ओके सर
ठीक है इट इज लेस देन 10 lakhs it will cost you not much
ओके सर
ठीक है और हम जब हमने स्टार्ट किया वी हैड लॉट ऑफ इनहिबिशंस कि पता नहीं हमारा आउटबोर्न बेबी का यूनिट है होगा मिल्क कहाँ से आएगा नहीं आएगा बट टू आवर सरप्राइज अभी हमारे पास 3 डीप फ्रीज हैं परमानेंट स्टोरेज के लिए सो वी हैव टू बाय रिसेंटली अबाउट 3rd बिगर फ्रिज टू स्टोर द डोनर मिल्क और हमारे यहाँ काफ़ी ओवरफ्लो है कि ये ड्यूएबल है कुछ नहीं है और 10 लाख से कम में आप एक अच्छा सा रूम छोटा सा रूम है 15 by 15 उतना में हो जाएगा आपको अपना आराम से 10 लाख का खाली एक डेडिकेशन चाहिए आपको एक डेडिकेटेड नर्स आपको रखना है और एक डॉक्टर भी डेडिकेटेड होना चाहिए और कि मदर्स को रिमाइंड करते रहना चाहिए बस 10 लाख से कम में हो जाता है सर ठीक है सो ओनली वी हैव टू कन्विंस देम ठीक है राजीव इन्फेक्शंस व्हाट इज द इम्पैक्ट
very high morbidity and mortality rate. But I would just like to show you this study. It's a wonderful study, 7-year period की study है, 2017 से 2014 का है, mostly from India, around...
Mostly नहीं, India से ही है.
It's from India only, 54 hospitals of India, 200 ICUs. But what is most important over here is you can see the mortality rate among this CLAPSI cases, newborn में सबसे ज़्यादा है. And this study that they have done, they have identified that around 40% died of CLAPSI. And another, just see the discharge rate, 6.6. So there is a huge gap over here. So most of the babies will somewhere land up. So this 40% will be 50-60 because वो लामा है, डामा है, referred है, and all those things will be around 60-70%. So this is very important that we have to take care of.
Almost 75% carbapenem resistant है. अगला final discussion उस पे है. ठीक है. Sogato, what are the interventions to reduce?
One simple thing here. Before becoming a doctor, be an administration, look for the things that is there in your hospital. आपके यहाँ soap and water का use बढ़ा है कि नहीं बढ़ा है, glutaraldehyde का use बढ़ा है कि नहीं बढ़ा है, Lysol का use बढ़ा है कि नहीं बढ़ा है, अगर बढ़ा है, be happy.
What are the interventions to reduce healthcare?
So, again and again, there's good housekeeping. We must be good housekeeping and hand washing. Again and again, we have to hammer the hand washing. And of course, the early enteral feeding with the breast milk, always the early feeding, we have to the pro feeding. And if the baby required the IV fluid, we have to encourage laminar flow, especially not only for TPN, also for
all the
IV
medicine
fluid.
making, fluid making, laminar flow भी costly, laminar flow भी costly नहीं आता है, 50-60 हज़ार में हो जाता है, अच्छा laminar flow, वो खरीदना बहुत जरूरी है, कोई भी mixing of the medicine, preparing the IV fluid, ठीक है, TPN, सब laminar flow में होना चाहिए. Every NICU should have a laminar flow. This is not a costly instrument.
There should be the adequate disposals and also antibiotic stewardship. And last but not the least, KMC.
Binay, what is the bundle care approach to reduce healthcare associated infections?
Bundle care start with first with hand hygiene. Because we do lots of intervention, baby is not going to survive if your sepsis is not maintained. So first start with hand hygiene. Then we put a center line, so we have to care about the center line bundling before and after care of the center line you have to done. If baby is ventilated, baby is treated with the ventilation, the ventilator is pneumonia.
कहने का मतलब कि ये बंडल केयर अप्रोच है. एवरी NICU शुड हैव ए चेकलिस्ट. एक सीट होना चाहिए कि सेंट्रल लाइन बंडल 1 2 3 4 5 6 7 8 पॉइंट, वैप रिडक्शन बंडल 1 2 3 4 5, IV कैनुला का क्या स्टेप्स हो, न्यूट्रिशन में क्या स्टेप्स हो. सर के आप स्टिक कर दीजिए या फिर आप शीट के जैसा रखिए. ओके. And Anil, what is antibiotic stewardship?
Antibiotic stewardship is very important things nowadays, because the main of this antibiotic stewardship is to optimize the use of the antimicrobial agent. There are so many components in it. We should have the good the clinical outcome and treatment outcome after using the appropriate antibiotics. We should minimize the toxicity and the side effects. We will minimize the emergence of the resistance, and we also this therapy will also be the cost effective.
So right drug, right dose, right de-escalation duration. कभी भी आप एंटीबायोटिक लिख रहे हो तो आप लिखो व्हाट इज द इंडिकेशन ऑफ स्टार्टिंग एंटीबायोटिक, डोज चेक कर लो और उसके बाद आप लिख दो कि व्हेन विल यू स्टॉप द एंटीबायोटिक, कि आवर प्लान व्हेन विल यू स्टॉप, कि कल्चर आ गया तब बंद करेंगे, 7 डेज देंगे, 5 डेज देंगे, 14 डेज देंगे, कब आप बंद करोगे. ठीक है, वो भी आपके माइंड में रहना चाहिए.
राजेश, बी प्रिसाइज नाउ, वी हैव टू क्लोज. राजेश,
लास्ट वन. प्राची, ट्रांसपोर्ट, safe transport. Last day.
Yes. Safe transport, sir, there are two components important: hypothermia, maintaining the temperature, maintaining sugar, and maintaining mainly the respiratory status of the baby. So तो अभी जितना poor है, maximum oxygen पे transport होता है baby.
हाँ, तो यही है कि आपको ट्रांसपोर्ट करने के लिए कोऑपरेशन की जरूरत है.
Yes,
We need to establish the effective transport. कहीं आप शिफ्ट कर रहे हो, कहीं शिफ्ट कर रहे हो तो कम्युनिकेट कर लो, बच्चा शिफ्ट कर रहे हैं, और we need to develop the transport system.
Sir, I think TP's resuscitator can be used very much. 70,000 का है, 70,000.
We need to do
with cheaper alternative.
We need to do. तो ये सारे interventions हैं, and I'll invite comments from the sir.
Yeah, I think it was a scintillating actually discussion about the most important points, which is extremely essential for our essential newborn care. And I am sure that every point has been well explained. About early initiation of feeding, I think still we are still behind the expected demand. And the most important point which I want to highlight actually, कभी-कभी हम लोग देखते हैं कि बच्चा जो है यूजुअली दूसरों की गोद में रहता है. तो मेरा पहला जो है, मेरा कहना होता है कि आप सिर्फ दादी और नानी से थोड़ी देर उसको 24 घंटे के लिए सिर्फ माँ के गोद में रख दीजिए बच्चे को, एंड द मदर विल स्टार्ट इजेक्टिंग द मिल्क लाइक एनीथिंग. तो ये एक बहुत इंपॉर्टेंट चीज़ है कि यूजुअली ग्रैंड पेरेंट्स दे ग्रैब द चाइल्ड एंड ब्रेस्ट फीडिंग इज डिलेड. So breastfeeding is always essential with the immediate contact of the child with the mother, baby of the mother. This is very very important. About वो जो है, जो दिखलाया था अभी स्लाइड, बड़ा अच्छा है. वर्निक्स को पहले का अभी भी कई जगह जो है लोग सरसों तेल लगा के उसको साफ करने की कोशिश करते हैं. So it is extremely essential that vernix should be preserved, and this is the most important element which actually benefits. And about this antibiotic stewardship, I think we are still much behind the norms which actually is desired. It is the reason being in our country the problem is the exact investigation is not being done. The blood culture facilities are not being exercised, and that's why you are always hitting like anything, you see. And most of the pediatric and neonatologists who are here, they will agree with me that in periphery especially, there is a rampant use of antibiotics for no reason. Very adverse effects are being actually promulgated by this kind of and you see, most of the time it is prophylactic sort of. सिजेरियन हुआ तो दे दिया, ये कोई मतलब नहीं है जिसका. वैसे प्रोफिलेक्टिक एंटीबायोटिक चलते हैं, और एंटीबायोटिक भी एकदम हाई ग्रेड के एंटीबायोटिक जिसका कि कोई रैशनली नहीं है. You don't even discuss, you see, even you don't discuss, you should have an antibiotic policy in each and every center, And you should have a discussion, you see, at the end of 1 week, what you did, how much you faltered. So there is no such introspection, and that's why I think antibiotic overuse, irrational use, is always being done in our country. And we are much behind that schedule. And about that, you see, delayed cord clamping, I would like to just know, is there any role of surface of the baby and mother in one place, or the baby should be little down?
नहीं sir, क्या है ना, the studies
is
है,
it,
if you prolong it for more than 3 minutes, there is no difference.
There is no difference. That's what I wanted to know.
अलग चीज है, वो
Yeah,
discuss
the
नहीं
milking
करेंगे.
the cord is also not essential.
ठीक है.
It is just a simple thing. You just help by 1 to 3 minutes delay. That is sufficient. Yeah, I think these are the points.
हाँ sir. अच्छा है सर.
Okay, I think we'll have to stop because we are delayed. We are quite delayed.
So family-centered care. Our family-centered care.
Dr. Om Prakash, we'll discuss later. And I think there is one question from the floor, the last one. Yeah, last one, please, because we have to just wind up. No?
Sir, I will not ask any question, just to reiterate what was discussed in the last 40 minutes. What Dr. Rajesh was saying, these are all game changers, but the problem is the implementation of this intervention. Some of the intervention that we could do in our setup in West Bengal, in Kolkata, like skin to contact and the delivery room. We had done some QI. As he has rightly said, if you do not go to the delivery room, as a policy every day, it is my duty to go to the delivery point, labor room, postnatal ward and OT.
Okay.
If you go regularly, and also we did a QI by taking into consideration and confidence all the
quality initiative. Yes,
Second,
that's right.
another important is he was telling the KMC and the breastfeeding.
Okay.
Now we have made a policy of counseling the mother. All the mothers who are admitted in the unit, they are called in one day, all the mothers, 50, 60 mothers, they are 1 hour that counseling session is done.
Wonderful.
And after that we did another QI that has shown that the milk output has increased, KMC rate and duration has also increased. So whatever intervention we have spoken in the last 1 hour, everybody knows it. But the thing is that how to implement this, that is more important.
Okay, thank you. Thank you. And the last question, please. Last question. Be precise.
Just 1
Be
minute.
precise.
So, according to me, it is the most vital things, and all things are doable, except one thing we don't have in our BIHAR. Sir, as Dr. Prachi said, and sir also answered, the milk bank. Milk bank, to get the equipment is not costly. But, sir, my question is very precise. How difficult to get the license of milk bank?
There is no license required.
No license?
No license is required.
We can set in our setup.
Yeah. महावीर में तो आराम से कर सकते हैं.
No, sir. Without getting sir. For that we need some infrastructure. We have guidelines.
Guidelines. Government of India guidelines is there.
Yes. We have guidelines.
But there is no license required for starting a milk bank.
Okay.
What I thought also. Okay, sir.
Thank you. Thank you so much for.
Okay. Thank you everyone for the
very heated discussion. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. I will request all the panelists, chairpersons and the moderator to come for the memento distribution. Please come. Moving on next, we have another panel discussion. I will request Dr. Bijan Saha sir to please come on the dais. And for chairing that session, we have Dr. Sheila Sinha ma'am and Dr. Neelam Verma ma'am. Dr. Sheila Sinha ma'am and Dr. Neelam Verma ma'am, please come on the dais.
Dr. Bijan Saha, who is the moderator and the design professor and head of the Department of Neonatology, Dr. Bijan Saha. He is working in IPG, ME, MNR Research and SSKM Hospital, Kolkata. Qualification is his MD, DNB, DM Neonatology from AIMS. Area of interest is non-invasive ventilation, LISA infection control. Major achievements are publications, more than 60 research publications, and contributed to several books. He is going to moderate the session, and the panelists are yet to come.
So, good afternoon, everybody. Before I start, let me thank the organizer for giving us the opportunity to speak in front of all of you. So, I will call my panelists, Dr. Ashok Talapatra sir, Dr. Naresh sir, Dr. Manshini, Dr. Dipender, and Dr. Diraj. So, we have got 5 panelists, Dr. Ashok Talapatra, Dr. Manshini Shahu, Dr. Dipendra Kumar Jadhav, Dr. Naresh Prasad, and Dr. Niraj Mishra. So, before we start, let me tell you our panel discussion on antibiotic. I think, can we stop the audience a little bit?
Request to all, please be settled. नम्र निवेदन है, आप लोग प्लीज बैठ जाइए. अगला पैनल डिस्कशन भी उतना ही जरूरी है. सब लोग बैठ जाइए, प्लीज. सर.
So before we start, let me start with a famous statement of Alexander Fleming. Way back in 1945, what he said, the microbes are educated to resist penicillin, and a host of penicillin-fast organism is bred out. In such cases, a thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with penicillin-resistant organisms. I hope this evil can be averted. This was a statement given in 1945. If we were really careful, definitely this discussion would not have been there today. As it was told in our earlier lecture, one of the most important or common drug that we use in our NICU is the antibiotics. And over the years, it has been found that antibiotic reduces the incidence of infection-related mortality, but at the same time, it is increased the incidence of antibiotic resistant. That means at one point, we have reduced some amount of infection, but at the same time, the antimicrobial resistance is increasing. So it is a global threat and global crisis. WHO has declared antimicrobial resistance one of the 10 top global public health threat facility facing humanity. And AMR is the cause of death globally with low risk settings bearing the bond. So I think this is the epidemiology. If you go around in any NICU, in the morning you will find a baby. After 12 hours or 15 hours, you see the baby suddenly is in shock. Baby is scleromatous, and you get a blood picture. It is found that it is pan resistant or resistant to many antibiotics. So that is a problem. That means there is some reduction in the incidence of infection, but at the same time, the antimicrobial resistance is increasing day by day. So I will start with a case scenario. If you see the case scenario carefully, it is a case of 23-year-old infant presented in our hospital with abdominal distension, poor feeding on day 23 of life. Baby was shifted in view of suspected perforation. He was admitted with neonatal jaundice on 20 hours of life in the primary hospital. He had abdominal distension, GI bleed, convulsion during the stay in the hospital. He was treated with different combination of antibiotics in the hospital. If you carefully see the choice of antibiotics, there are different antibiotics was used at different times. And baby was not thought as a case of surgical emergency. Ultimately, baby came to us, and this was the scenario. So this is not the scenario very uncommon. It is the scenario what is commonly happening. And if you see the blood culture, blood picture, can I ask the audience just keep little bit of silence, otherwise nobody will be able to listen. So if the blood culture shows that there is a multi-drug resistant organism. So first we will start with suppose in a case like this, of sick neonate like this infant, but the blood culture is negative.
and how the infant or clinician should balance the antibiotic stewardship. Ashok sir.
Thank you and good afternoon everybody. When we suspect sepsis, this is we are going to start antibiotics and suspected sepsis. It's not proven yet. So what we should choose from the access group of WHO formulated regime. So access group is a lower class of antibiotics, and it should cover both gram positive and gram negative bacteria, and that also should depend on the antibiogram of the units, what initial regime what you are starting, that it should be based on that, and also based on the culture positivity rate of the unit. If the cultures are routinely sent and culture sending is more than 15%, and it should cover, already it has been discussed. So we'll start with the access group of WHO, which contains, everybody knows that it is ampicillin and aminoglycoside. Either it is gentamicin or amikacin.
So thank you sir. Actually what sir is telling, suppose if you start empirical antibiotic, then you should know whether you are treating more resistant organism or less resistant organism. Suppose you think that in your case you are not likely to get resistant organism, then you start with very lower spectrum like ampicillin or gentamicin, or you should have your own data, because if you start with lower spectrum, there is a less likelihood that there is less antimicrobial resistance. So what sir is telling, if you want to give empirical antibiotic, that is the case in most of the cases, you have to see your data, you have to see the culture positivity report, and also start with the lower spectra so that antimicrobial resistance is less. Thank you sir. So before we start, how reliable sepsis screen and biomarker compared to blood culture in decision making? Manshini.
Thank you, sir. Thank you for the question. Good afternoon, everyone. So I would emphasize that blood culture is our only answer, because blood culture is the diagnostic gold standard. And what we normally think that blood culture may not come positive where the culture rates or the number of organisms are low. Actually, blood culture can detect 1 to 3 microorganisms per microliter of blood, where the median positivity, median infection rate in babies are more than 100. So blood culture, if taken 1 ml, if you take 1 ml of blood culture, you should trust your report, because 1 ml of blood culture is having 100% sensitivity of giving the correct report. And if I compare with it the sepsis screen, which composes of some blood parameters and some serum markers, these are very non-specific, because they can elevate in other non-inflammatory stress, pain conditions also, hypoxia condition, which may mask actually it is a sepsis or not. Their sensitivity and specificity are very low, and CRP, which usually we tend to take CRP values, this is actually in early time, that is the CRP rise is late. Usually when the infection is more, it will go to the liver, then it will perform CRP. So CRP in early hours, it is having a very low sensitivity. But yes, if you do beyond 48 hours, it is more helpful in ruling out sepsis. And also immature to total neutrophil ratio, if it is more than 0.2, it is actually also a marker to rule out sepsis. So sepsis screen is mostly, if you do it beyond 24 to 48 hours, it is usually helps us to rule out sepsis. But in ruling in sepsis, the sensitivity or specificity is very low for a sepsis screen. So it is not definitive and it cannot replace cultures. So my message would be, take 1 ml of blood culture and trust your report.
So the first thing is that suppose you see a patient, that you may start antibiotic based on symptoms or based on risk factors. If you find, or if you are not in doubt whether to start antibiotic or not, that is the case many of times. Like the baby is having little bit of vomiting, 1 episode of apnea, not looking great. In that case, you have to rule out sepsis or they rule in sepsis. So if you want to rule out sepsis, the sepsis kit has a role. But if you want to rule in, then the blood culture will be better. Suppose baby is having mild infection, your sepsis skin is negative, then you can confidently say that there is no infection. But even the sepsis skin is positive, then you cannot say it may be an infection, there may not be infection. Second important thing is that suppose a baby is presenting with some severe symptom like scleroma, septic shock. In that case, sepsis skin does not have any role. In that case, you can do a blood count. So what she has rightly said that There is a role of blood culture that before starting antibiotic we have to. So the blood culture positivity rate is very less, but if you want to rule out sepsis in some mild cases, then definitely there is a sepsis, role of sepsis screen. Thank you. Dr. Neeraj. So why blood culture always be performed before starting antibiotics in neonates with suspected sepsis?
Thank you, sir. Actually, blood culture, as the Dr. Manuswini told, that it is a gold standard for the diagnosis of sepsis. Sepsis screen are non-specific markers. And if you are performing blood culture before the start of antibiotic, the yield is quite good. But problem with the blood culture is, if you have given antibiotic before the start taking the blood culture sample, then your yield of the blood culture will be affected. Microbial load in the blood will be less, and you may get false negative blood culture. So if the dictum is, if you are sending blood culture, take the blood culture before the start of antibiotic and rely on the reports. It will help you in so many ways that we will see in the subsequent slides.
So what is said that before starting antibiotic we have to take blood culture, and 1 ml blood should be taken for better yield. Second important thing, if you give antibiotics before taking blood culture, then the yield will be low. And our job is not to treat the sepsis, but also reduce the duration of antibiotics.
Yeah.
Because if I am not wrong, in our clinical practice, more than 20 or 50% cases, babies are given antibiotic on empirical ground. In that case, you have to rule out sepsis rather than ruling in sepsis. If you see the total duration of antibiotic in any unit, the culture positivity rate is not that high, but the number of babies getting antibiotic will be more than that. So if you want to reduce that, you need sepsis screen, you need blood culture, you need a very good index of suspicion, and you have to follow up these infants.
Yeah. So simple thing, if you are starting empirical antibiotics and sending blood culture report will be available in around 48 hours. So if the blood culture baby has symptomatically improved and blood culture came negative, you can early stop the antibiotic after 48 hours.
Thank you. Sir, what is the role of rapid? Nowadays there is facility for rapid blood culture like BIHAR, BACTEC in NSO, and what is MIC?
The BACTEC and BIHAR culture system is actually revolutionized the system of blood culture system. The previous one of the blood culture system was there. That was time taking, not that accurate, and the BACTEC system and BIHAR system is an automatic system of the blood culture. First of all, we have to take 1 ml blood and inoculate in the broth of the vial and then put it into the machine. And within 24 to 48 hours, it gives the reading.
So what sir is telling, if you take the newer diagnostic, the BACTEC system, as I was telling you, suppose you want to stop antibiotic. How can you stop antibiotic if you do not have the blood culture report? In this BACTEC system, you can get the report if the baby is having sepsis culture. You may get report even within 12 hours. So if I know within 12 hours culture is negative, baby is symptomatically normal, in that case you can easily stop the antibiotic rather than continuing in the antibiotic. Second important thing is a minimal inhibitory concentration. Why it is required? Because many a times we will get report with culture positivity rate positive or negative along with the resistance pattern. And based on the resistance pattern, you will diagnose whether it is a multi-drug resistance or not. That's why whenever you take a sample, you have to identify the organism as well as you have to identify whether the organisms are resistant or not. Thank you, sir. Dr. Dipendra, how often should units review the antibiogram data and how should we guide empiric therapy? Suppose you are working in a unit, we want to actually have a policy of antibiogram, how it should be done?
Good morning, sir. Most of the NICU review her antibiogram every 6 to 12 months, depending upon her policy. But unit-specific data, it is crucial for neonatal unit have their own unit-specific data because the organism like E. coli, Staph aureus, may be different resistance profile in NICU compared to other hospital unit. And general principle are for antibiogram, first collect 6 to 12 month data, then tabulate frequency and sensitivity pattern, then determine sensitivity to antibiotic combination, then decide our first line, second line, third line of reserve antibiotic.
So,
yes, continue. And principle, and these are our blood culture profile, our outward NICU. The culture positivity rate is 8.5%, and most common organ are gram-negative sepsis. In gram-negative, Klebsiella is most common.
So what he is telling, suppose you want to have antibiogram, what we have to do, you have to collect data of the last 6 or 12 months. You have to separate it both for gram-negative and gram-positive. Then you have to see their resistant pattern and sensitivity pattern. Then you have to choose antibiotic as a monotherapy as well as combination therapy. And based on that, you have to choose your empirical therapy. Suppose you do not have data on your own unit, then what is the next step?
And this is our antibiogram, like Klebsiella is most common.
So what is saying that if you do not have your own data, then you can have the data of other unit or the country data. And based on that, you can choose your antibiogram.
60
and so, at least 30 isolates should be there.
Yes, yes, sir.
Okay, thank you. So so what we have learned, sepsis screen to rule out and not to rule in. Blood culture is the gold standard. And if you actually want to reduce the duration of empirical antibiotic, then you need to have the facility for sepsis screen as well as the blood culture. And you should carefully observe the baby for 40 to 72 hours to see the clinical course of the disease. If the clinical course is good, baby is not having any evidence of infection, then you can stop. But if the clinical course is not good, culture shows some positivity, then you can see the organism and you can see whether the organisms are resistant or sensitive to the commonly available antibiotics. So there is a case history of 28-week preterm infant, birth weight 1 kg, delivered after prolonged rupture of membrane, develops respiratory distress at 12 hours of birth. Baby was started on piperacillin, tazobactam and gentamicin. On day 3 of life, baby worsens with apnea, shock, abdominal distension, blood culture shows Acinetobacter boehmeni and resistant to all antibiotic except colistin. Manshini, how common is MDR organism? Just speak in 2 or 3 sentences.
Yes, if I speak in 2 or 3 sentences, so nowadays like Klebsiella and Acinetobacter are highly resistant to almost all drugs, and the resistance is varying. Some reports is 20-35%, but it's actually 70 to 100%. If you see our own Indian data, it is a global data which shows that MDR pathogen account for 30% of global neonatal sepsis. But if you see the next slide in Indian data, which like the Dennis trial was done, and another trial which shows 5 patients used in India, actually the rate of Acinetobacter and Klebsiella resistance varies from 75 to 80%. Here is the Dennis study, which was taken some hospitals in Delhi and done the study. Here we can see the MDR rates in Acinetobacter are almost more than 80%, and Klebsiella and E. coli accounted for further MDR pathogens, and the case fatality is higher with the MDR pathogens, that is already known. And another study which shows in 5 SNCUs of India, actually the rates of MDR pathogens are varied from 75 to 85%. So it is very high, and MDR pathogens are causing more mortality than other area. And if we see for the global data, there is a study which is seeing what we will see in the future, like future up to 2050 prediction model, which here this study will show the MDR pathogen for Klebsiella, and for each drug it is shown in the bar diagram. Like in 2050 we may not be having any antibiotics to give the organism. So we have to be very careful in choosing our antibiotics and starting our antibiotics whenever required.
What is the magnitude of the problem is that over the years, because of the antibiotic, you may reduce little bit of infection, but the antimicrobial resistance is increasing day by day. All the studies have shown whatever culture positivity report we get in our clinical settings, 70 to 75% will be there of multi-drug resistant organisms. Yesterday we had a perinatal stat. We thought that only 5 infants had culture positive, 7 infants. And out of 7 infants, 5 infants had multi-drug resistant organism. That means even it is happening in the peripheral SNCUs. That means our sepsis related mortality, there may be little bit of reduction, but at the cost of increasing the multi-drug resistance antibiotics. So my next question will be to again Manshini. Then what is MDR? How can you define MDR? Okay. The case what we have defined, it is falls under the definition of MDR or not?
Yes. Multi-drug resistance. Multi-drug resistance means if the almost nearly 5 classes of antibiotics we are using, if a organism is resistant to one of each class, and it includes 3 or more classes, then it is multi-drug resistance organism, MDR. One antibiotic from each class, and that should include 3 or more classes like extended spectrum cephalosporin, carbapenem, aminoglycoside, fluoroquinolones, and piperacillin tazobactam, which we commonly use this class of drugs. These are for gram-negative organism, and for gram-positive MDR will be said if it is resistance only to methicillin. So this is the definition of multi-drug resistance organism. If you go to further like extensively drug resistance or XDR organisms, that means the organism is resistance to each from one class, the two, but it should be resistance to 2 or lesser classes, but all antibiotics from the same class. So that will be XDR, and pan drug is resistance to all the antibiotics from all the classes of the drugs. This pan drug resistance organism is now becoming a global problem. And now further that we were discussing, we may not be having an antibiotic to give when a pan drug resistance is coming, because our antibiotic generation or new antibiotics coming up is very low.
So what she is telling, out of the 5 classes of antibiotic, if there are 3 or more than 3 antibiotic classes are resistant, then we call it multi-drug resistant. I think all of you who are here, many times you will find you are getting some culture positivity report, and when you see the sensitivity pattern, you are disappointed. You find sometimes it is sensitive to one drug, and sometimes it is not sensitive to any drug. Second important thing, when you send a culture, along with the culture, you just ask for MIC value. Unless the MIC value is given, then it will be very difficult to actually define whether it is MDR or not. Sometimes definition report is given intermediate or intermediate sensitive or resistance. Intermediate means this organism is resistant to the conventional doses, but if you increase the higher doses, then it may be sensitive. So actually if you want to define MDR, that's why I think all of you who are here, now it is time to see your MDR pattern. And I am sure most of us who are working in level 3 NICU, where you are getting most resistant strain, and they are getting report like this. So MDR is a concern. Now we will discuss in next 20 minutes how to deal with these MDR organisms. Dr. Niraj, the multi-drug resistance may be found in gram-negative organism, basically Enterobacteriaceae, that is, how should empiric antibiotic may be chosen in units high prevalence of extended spectrum beta-lactamase, Enterobacteriaceae, carbapenem resistant enterobacterial, carbapenem resistant Acinetobacter baumannii. See, when in any clinical situation, these are the commonly found organisms in most of the village. Like either it may be Klebsiella, E. coli, or Proteus, or sometimes Acinetobacter baumannii. And suppose if you want to treat those infants, actually you should know whether these infants are extended spectrum beta-lactamase positive organisms or not, or carbapenem resistant organism or not, or carbapenem resistant Acinetobacter baumannii or not. But unfortunate part is that in our clinical setting, we are not regularly performing this test. If you are not performing that, how do you decide the antibiotic for this?
So this is the need of the hour. We are, if you are working in level 3 NICU and getting referrals from the periphery, where and you are sending the culture and getting these type of, we are frequently getting these type of reports where MDR, XDR, and sometimes PDR are also there. So dictum is, if ESBLE enterobacterials are there, you should not treat with piptaz amica and cefepime. Problem with the, you should choose carbapenem. Problem with the piperacillin tazobactam is, once actually in vitro sensitivity may be there, but in vivo sensitivity may be lacking. Second thing, the antibiogram, the MIC AST value you are getting in MIC may not be reliable. Same problem with cefepime. Actually, there is no data or no study comparing directly cefepime with carbapenems. One thing. Second thing, this again the AST MIC value you are getting with cefepime may not be reliable. So primarily we should not treat these organisms with piperacillin tazobactam and cefepime.
So what he is telling, if it is extended spectrum beta-lactamase enterobacterial like Klebsiella, E. coli, Proteus, in clinical setting we do not estimate this, but what we can do, if the MIC value of ceftriaxone more than 2 per ml, then you can define it is extended spectrum beta-lactamase. This is a proxy of diagnosing extended spectrum beta-lactamase enterobacteriaceae. One important point from what he is saying, Here you should not use piperacillin tazobactam, because if you use piperacillin tazobactam, it will not work. It may be there is some resistance, or it may be working in some mild infection, but in moderate or severe infection it won't. The main drug is meropenem. Can we use combination in these cases? Only meropenem or combination?
So only we can go with meropenem.
Only meropenem, because it has been seen that as you are more concerned about antimicrobial resistance, when you find this kind of scenario, start with single antibiotic. If you give 2 antibiotics, then there is a risk of dysbiosis, fungal sepsis, and death. Second is carbapenem resistant, not producing carbapenemase.
Yeah.
What is the...
Here you can give with ceftazidime and that beta-lactamase inhibitor avibactam, because this avibactam will prevent hemolysis of ceftazidime from the enzyme.
And also the carbapenem resistant yes, enterobacterial or other...
Again, sir, we can give this combination ceftazidime avibactam in combination with H2NAM.
So what he is saying that Enterobacteriaceae may be extended spectrum beta-lactamase producing, or Enterobacteriaceae may be carbapenem resistant or carbapenem sensitive. If it is carbapenem resistant, it is very difficult to treat. What he has said that we can treat with meropenem with ceftazidime with avibactam, but this combination actually mostly used in the adult.
Yeah.
And whatever data is available here is most for that. In newborn we do not use. That means when you are getting Enterobacteriaceae like E. coli, Klebsiella, if it is extended spectrum beta-lactamase producing organism, then the problem is not mass. You can give meropenem. But if it is carbapenem resistant, then the problem arises. If I am not wrong, in our clinical scenario, you are getting carbapenem resistant Enterobacteriaceae. In that case, it will be very difficult task to dose these infants. So this is the ideal combination, but in newborn we usually do not use. Is there any role of colistin in this case?
No, sir.
Actually, there is not. We think that if all pan resistant, colistin is the panacea. It is not like that. It has been seen if you give colistin, that may work in case of pseudomonas. And if I am not wrong, pseudomonas we have not added. Some difficult to treat pseudomonas can be treated with prolonged infusion of piperacillin tazobactam or colistin combination, but not in Enterobacteriaceae. That is a concern. So, Ashok the sir.
Crab left, sir. One thing left, crab.
Oh yes. Oh, the second is the carbapenem resistant Acinetobacter baumannii. How to treat?
Sir, if you are this group of organism very difficult to treat, and if you want to treat with monotherapy, the new drug is there, that's cefidroxil. This you can treat with monotherapy. Otherwise, the preferred drug combination are high dose penicillin infusion, prolonged infusion of these piperacillin tazobactam with a combination of other drugs.
See, so what he has said, carbapenem resistant Enterobacteriaceae, you can see that other organisms like oxa and metallobacter lactamase, beta-lactamase, there you can give this combination. But if it is Acinetobacter baumannii, then there is role of combination, as it has been shown here. Yeah. There you can give sulbactam along with carbapenem, or alternative regime is ampicillin sulbactam in at least one other agent. That means if it is Acinetobacter baumannii, then there is a role of combination drug. If you do not give combination, in that case, you will not get the optimum result. So we have got 3 scenarios. One is Enterobacteriaceae, extended spectrum beta-lactamase producing organism, drug is meropenem. Enterobacteriaceae, carbapenem resistant, either it may be OXA48 or maybe KPC or maybe MBL. There the combination will be ceftazidime with avibactam. If it is Enterobacteriaceae, if it is Acinetobacter baumannii and carbapenem resistant, then the task is more difficult. In that case, you go for combination. Sir, I think we have already answered this thing, again reiterate. So this is the WHO.
Yes. The WHO, to make it easier for us, it's a guide for us. It is divided into 3 groups. One is the access group, which is used as an empirical therapy. Next, there is the watch group and the reserve group. And the first group has already been discussed. It was aminoglycoside with ampicillin, cloxacillin, and metronidazole. These are the first line of drug. And then we can go for cefotaxime, ciprofloxacin, meropenem, and piperacillin tazobactam, and vancomycin. But one thing I would like to mention that we should never go for the cefotaxime fast because the bacteria develop resistance very fast and it will not be effective later on.
So,
And,
so what sir is telling, these are the drugs that we shout as an empirical treatment. But for empirical treatment, always start with the lower spectra. If you start with higher spectra, then we will not be any reserve drug at our hand. That's why in a unit policy, the reserve drug should be given after consulting with the lead consultant. The resident should not start reserve drug as an empirical therapy. Second important thing was sir is telling, unless there is definite meningitis, do not start cephalosporin as a empirical drug because cephalosporin and fluoroquinolone are very notorious to cause antimicrobial resistance. So these are the few things we should keep in mind. And empirical therapy, we should start with penicillin group of drugs with an aminoglycoside. Because penicillin or semi-synthetic penicillin, aminoglycoside has got least resistance amongst the all antibiotics. Thank you, sir.
one more point I would like to comment, Dr. Shah.
Yes, sir.
These reserve drugs, I have come to know in CMC Vellore, if you want to use that reserve drugs, aztreonam, colistin, polymyxin and linezolide, you have to take the permission of the head of the Department of Infectious Disease.
Yes, sir.
You cannot use it like that.
What, sir, is what that is thing that it is said that if there is resistance to colistin, it will be remain there for life. Unless you burn the unit, it will not disappear. That is the reason in many centers, in our center specifically, we have stopped using colistin. With using colistin, you may save 1 or 2 infants, but at the cost of high antimicrobial resistance. That's why in CMC Vellore, Dr. Balaji was also telling like this in one of meetings.
He was telling it.
He was telling the same thing. So if there is resistance to colistin, it will be resistant for lifelong in that particular unit. Unless you burn the unit or you ship the unit, it will not go. Thank you, sir, for remembering. Dipendra, suppose we get carbapenem resistant enterobacteriaceous sepsis, when do we escalate the reserve drug like colistin? Because initially we told that carbapenem resistant enterobacteriaceous may be extended spectrum or carbapenem resistant. Suppose we want to escalate, then can we use this colistin?
I am going through the ICMR guideline.
Yes.
In ICMR guideline, there are 2 treatment options depending upon the carbapenemase test available or not. In carbapenemase test, there are 2 types of tests, phenotypic test and genetic test.
Okay.
In phenotypic test, some of the NIC use carba-5. In genotypic test, some of the NIC use PCR, multiplex PCR like BIHAR.
Right.
And next, this is carba-5 test. Like as well kit, it contains C4 control lesion and other 5 are the most common carbapenemase gene. And depending upon the which gene are positive, you are decide the antibiotics.
Right.
Next. And this is deciding of the antibiotic. If metallo-beta-lactamase, that is NDM or NDM plus OXA48 are positive, then first choice of antibiotic are prolonged infusion of ceftazine avibactam plus azithromycin, and other option are polymyxin, tigecycline, aminoglycoside, and IV phosphomycin. And other, if OXA48 or KP gene are positive, then you are using first line drug, prolonged infusion of ceftazine avibactam. And other are polymyxin, tigecycline, aminoglycoside, and IV phosphomycin. If treatment option is not available, then you are using ceftazine, polymyxin B along with the tigecycline, aminoglycoside, and phosphomycin, or high dose imipenem if MIC level is less than 16.
So another important thing in clinical practice, we do not usually estimate this OXA48 or KPC or MBL. But what is said that if any of the carbapenem resistant is there out of 3 like meropenem, imipenem or whatever, doripenem, if one is resistant, then you can say carbapenem resistant enterobacteriaceous. Because in clinical setting, we usually cannot estimate all these things. It is not commonly done. So I think we can go to the last part. So what we have seen, it is not very easy to treat or manage infants with multi-drug resistant organisms. Whatever data is available, what we have discussed till now, these are the data available given by the Infectious Disease Society of America, and these are actually taken from the adult population. In newborn, we do not have much data, so our main focus will be to prevent infection rather than treating all these MDR organisms. So prevention, So what is the evidence that hand hygiene induces resistant sepsis in the NICU? I think
See,
one or two lines.
We used to know that hands are the worst killer.
Hands are the worst.
And thorough hand washing and good housekeeping can prevent most of the infection.
So what he said that ultimately it is a hand hygiene, that 5 moments of hand hygiene given by the WHO that we should follow. But unfortunately in clinical practice, many a times it is not practiced. When the baby is very sick, then the washing of the hand is very less. People think that if I do not touch the infant, if we do not aggressively manage the infant, baby will die. Rather, baby will die because of infection, not following hand hygiene. And second is there is a term called the scrub the hub. Before giving injection, you have to clean the hub of the ear. And many a times we even repeatedly tell to the staffs, but many a times it is not practiced. But these are the very good intervention that can reduce infection. I think this CLAPSI bundle already been discussed, that you can little bit highlight 1 or 2 points. Tell.
International Society of Infectious Disease, they clearly show care application of care bundle is evidence-based practice that improve patient outcome when implemented. And these are the evidence. They clearly show after implementing the CLAPSI bundle, you reduce CLAPSI rate from approximately 10.5 to 3.6 or 15.34 to 2.23. And also meta-analysis. Next, sir. And this is meta-analysis, systemic review meta-analysis published in Lancet. They clearly show after application of CLAPSI bundle, reduced CLAPSI rate approximately 50% in all overall ICU, adult ICU, NICU, and PICU.
So that what he is saying that if you want to practice any intervention, it has got its own side effects. Like uses of lines and tubes are dangerous. Many times you will find in unit, suppose antibiotic is stopped, still the IV line is there. So there is a saying, if any line or tubes are not in use, then you should remove it immediately. Second important thing is the CLAPSI bundle. These are the set of intervention that we should practice. Another important thing in our clinical setting, what we see, if you start using these long lines and tubes, your infection rate will increase. So our main aim will be to remove the lines and tubes if are not in use. Suppose if you use lines and tubes in our practice in NICU, in our IPGMR, what is our practice? If we intubate a baby, we will try to extubate the baby within 72 hours. If not possible, within 7 days. After 7 days, if you keep a baby on tube, I am saying whatever ventilation you do, many times we will have ventilator-associated pneumonia. Secondly, if any long lines are used, we should try to remove the long lines within 7 days. So these is the thing, some of the things that we can practice in your clinical setting. Then one of the most important part is that equipment maintenance and disinfection, like ventilators, warmer section in braking, resistance, chain. Sir?
It is very important to maintain the ventilators and other equipments in the NICU. The first thing most important is the bacteria. They produce biofilm. And what is a biofilm? It is a three-dimensional slippery metric substance. And what is metric? It is the protein and minerals in it. And it is a device produced by the microorganism against the adverse environment. And what is the adverse environment for them? The use of antibiotics, use of the disinfectant and sterilizing substances, and third is our immunological system of the body.
Sir, what sir is telling, good housekeeping, sterilization and disinfection of the equipment plays a great role. Many times you will find in public sector hospital, staffs are not there, protocol is not there. What they are doing you do not know. Suppose we want to, there is a saying that you have to clean the floor at least once in each shift. But with what reagent? Suppose here is 1% hypochlorite. How this hypochlorite is mixed? Whether the group D or whoever cleaning that is whether it being taken into consideration or not. Because it is said that hand hygiene and instrument sterilization and disinfection will reduce the infection rate by 80%. Cross infection is very common in NICU or SNCU. And if you want to actually reduce cross infection, then you have to practice hand hygiene, 5 moments of hand hygiene, and also disinfection and sterilization of the equipment. and good housekeeping, just like you are following in your, your rooms or your store, whatever. So you should be very much obsessed with housekeeping, otherwise you cannot prevent it. The last question is that what role does the housekeeping that we have
one more line, sir. And what is the example of the biofilm? The biofilm example, the greatest example is the formation of plaques over the dental region. And these dental region plaques are formed. Plaques are nothing but the bacteria and the food particles. And once they are left as such, it will form a tartar and needs to be removed manually, and that is there. So it is the same thing is here with the antimicrobial resistance which is growing over the instruments. And unless it is not removed by the disinfectants or by the various sterilization technique, it will never improve our setup. Second thing, most important is what is the soap doing here? The soap actually dissolves the lipid layers of the various bacteria, viruses and the other microorganisms.
Sir, our time is less. Let me thank you very much. And just quick answer.
After dissolve, it will destroy.
Yes, sir. Actually, every unit should have their fixed housekeeping protocols, and it will help in preventing the spread of bacteria, because bacteria has the tendency to stick to all the surfaces, not only the incubators and the table we are using, computer we are using in the NICU. All these can be contaminated with the bacteria. So at least between once in a day, between 24-hourly cleaning of all the surfaces should be there. In short, I can say that all the surfaces should be cleaned every day, at least 24-hourly, mopping of the floor with the phenyl at least in each shift, at least twice or thrice.
Can you project the last slide? Last and before the go on.
And this will help in eradicating the bacteria from the NICU, because these bacteria get attached to the surfaces, and when you are touching the surface, after that you are touching the baby, and that will spread the bacteria in the NICU, and the baby will be...
And again. The previous one. So this is what we have discussed till now. First you have to prevent infection by hand hygiene, infection control, stop treatment. You should know when to stop and you should stop treatment if it is not required. Do not treat colonization. You should treat infection. Use local data that we have discussed. Practice antimicrobial control. Access the expert if you cannot find any solution. Target the pathogens. That's why culture is very, very essential. Use proper diagnostic methods. As in the previous panel, it was discussed that in many places, the blood culture facility is not there. If the blood culture facility is there, all this MDR is meaningless. You don't know what is MDR, what organisms is there. So we should have the facility for blood culture. If the blood culture facility is not there, then we will beating in the bush only. Then use proper diagnostic methods, get the catheters out, vaccinate, and the last not but the least, less is more. जितना ज़्यादा करोगे उतना ही खराब होगा. जितना कम कर सकते उतना ही बच्चे के लिए अच्छा है. Thank you very much. Thank you for your patient hearing. If you have got any query or question.
Sir, one of my doubts. How to treat these pan-resistant bacteria?
That is heat and trial method. Everybody knows it. There is no clear-cut answer. It's a heat and trial method. You should know that.
Thank you, Dr. Vijayan, for such a vibrant and interesting discussion of a very difficult subject, and participation by such knowledgeable and academically oriented panelists.
One minute.
The participants were very forthcoming with some their own experience, as well as what to do, when to do, from simple things like hand washing to the multi-drug resistant infection treatment. It is an international problem actually, now that multi-drug resistance is coming up in a big way, especially in India. As there was a slide shown that in foreign countries it is about less than 30%, here it is in some cases about 80%. So we have to be very careful about it, and I think people who are making that's NNF criteria, they should be aware that what is happening in Bihar at least, that the newborns are admitted, they get treated with higher antibiotics, then they go back home. Now the doctors, the pediatrician may be a general physician who sees all these treatment sheets from here, they see that, oh, this was the last antibiotic that was used and it was what made the child better. So they start that as the first line treatment. And that is a very, very big problem here. And I think that should be, noted, and it should be accessed somehow so that this problem is solved. Then only the multi-drug resistance will be solved. Sepsis is a very important and a very dangerous problem of neonates, which should be handled properly, cautiously, but with enthusiasm, so that it saves lives and it saves the newborn in a proper, intact way. Thank you.
I just wanted to make a comment. Like carbapenemase testing results according to ICMR guideline. Like NG-Carba 5 is easily available. Like in our hospital, we routinely do it. It costs only 1400, not much. Okay, so we do it because NDM positive is there or not there is very important, because this drug come only cholesterol to cholesterol sensitive. Then you have to do ND-Carba. That we use Jovicepta-Aztreonam combination or not. It is very, very helpful in routine practice. So start doing NG-Carba.
No, that is done many places. In our place, we have got a culture. We get all the things. In fact, in our study, if you see the literature, we have got many. Now there is another problem. Now the hypervirulent Klebsiella is there. And hypervirulent Klebsiella, one of the dreaded organism. It will affect the healthy neonate.
Yeah,
not
that is there.
And that is very difficult to treat.
Okay.
Hypervirulent Klebsiella is another.
Sir, thank you for such a nice presentation. Already Dr. Neeraj has asked and you have answered just heat and trial method for the pen resistant. You know, sir, some prescription I have seen, they have given in pen resistant oral rifampicin. So you have any idea about what is the role of, either is it any role of oral rifampicin? Because I have seen by the, that was by the infectious disease specialist in that have written ki you can try oral rifampicin. What is role of that?
See, Dr. Rupesh, honestly speaking, I do not have any experience on oral rifampicin, but whatever oral rifampicin they are telling, that is for the adult population. If you see the IDA they say that you can give oral drug or switch over to oral drugs, provided the absorption is good. But we know that we never give oral drug to treat infection because absorption will be erratic. But we don't have any data, and whatever data is available, that is in the adult actually. I don't think there is any role of oral rifampicin, because in newborn sepsis, we do not give any oral drug. Suppose it is severe infection. So there they are saying you may switch over to oral drug provided the absorption is good. That is in adult, but not in neonate. That much I can say.
Okay, sir. Thank you.
Thank you very much. Thank you all the panelists for your crisp answer. Thank you. Thank you for your patient hearing. Thank you very much.
Thank you, sir. Thank you, ma'am. All the panelists and chairperson, please come for the memento distribution. Please assist in memento distribution. Next we have next I will ask Dr. Binod Kumar Singh, sir, to come for the talk. And for chairing that session, I will request Dr. S.B.P. Singh, sir, Dr. S.A. Krishna, sir, Dr. A.K. Asu, sir, and Dr. Satyendra Shankar, sir. S.B.P. Singh, sir, Krishna, sir, A.K. Asu, sir, and Satyendra Shankar, sir. And Binod, sir, as a speaker, please.
And Dr. Professor Binod Singh does not need any introduction, but however I have to say that he is the professor, Department of Pediatrics, NMCH, now retired, ex-medical superintendent, NMCH, Patna, ex-HOD and professor, Department of Pediatrics, NMCH, IAP State President, IAP State Vice President, BIHAR 2018, CIAP Executive Board Member 2015, NNF State President 2014,
IAP State Secretary, Bihar, 2010 to 2011, NNF State Secretary, Bihar, 2008 to 2009, and Fellow of Indian Academy of Pediatrics, that is FIAP, and Chief Consultant at Shiva Shishu Hospital and Shubham Maternity Center, that is in the Kankarabagh. So I request that we are running late to begin with Dr. Binod Kumar Singh, please.
So, thank you, Chairperson sir, for your good words. And I see my teachers and many seniors and few very learned persons like they are my students like Dr. Kesav Pathak, Dr. Namrata, who have done DM neonatology, the young dynamic DMs like Dr. Neeraj, Dr. Rupesh, Dr. Bhavesh Kant. So all are doing so extremely well, and every day we are learning. And I think that whatever I am going to discuss, most of you are practicing, but this will be an overview to how to approach to a patient of very ELBW, extremely low birth weight babies. So we all know that the ELBWs are the babies less than 1000 grammars, and very small changes in respiratory management, fluid administration, nutrition, and virtually all aspect of the management is going to affect a lot so far as survival, morbidity and mortality of the newborn is concerned. And for that we need to have optimal perinatal care. So the care of a ELBW starts from the womb itself, and then what is the perinatal consideration? The very, very important thing is that the baby should be delivered at a place where there is level 3 care or level 4 care of NICU with very advanced obstetric care. The prenatal administration of steroid has to be given to all the babies who are born less than 34 weeks, between 22 to 34 weeks of gestation, because we know that this antenatal steroid is going to reduce the incidence of necrotizing enterocolitis, intraventricular hemorrhage and BPD. And we know also that antenatal magnesium sulfate has to be given once you think of that the baby is going to be delivered within 24 hours, and if the gestation of the baby is less than 32 weeks. So that has to be the standard practice. So in all the ELBW babies, antenatal steroid and magnesium sulfate have to be administered to the mother. And so far as parental education and counseling has to be done before the delivery of the patient, and this is the very, very important part. Suppose the baby is going to born at 24 weeks of gestation, or 23 weeks of gestation, 26 weeks of gestation. So in these conditions, whatever is the likely outcome, what will be your planning in the labor room and during transport and in your NICU, that has to be well discussed with the parents of the baby, and you should also explain about the outcome of the baby. So whatever is your NICU survival rate in a 25 weeker or 26 weeker, 28 weekers or so. So that has to be well explained to the patient. They should not be confident that this baby is going to survive in any way. So this has already been antenatal steroid talked by dexamethasone or betamethasone. Both have got the equal efficacy almost. And we must say that if we are expecting this delivery of the baby before 34 weeks of gestation, so may I request the audience to be silent. So silence please. So that has to be given liberally to all the mothers, and the absolute contraindication to the use of antenatal steroid is chorioamnionitis. Means if you are finding that the mother is having evidence of chorioamnionitis in the form of foul smelling liquor and she is febrile, of course we should avoid. Otherwise diabetes gestational diabetes and hypertension, they are not the contraindication for use of antenatal steroid. So that has to be considered. And we always talk of intact survival, means survival free from neurodevelopmental disability. That has to be focused or planned, or that has to be done. And this depends not only on the gestational age of the baby, but also on sex, the birth weight, exposure to antenatal steroid, whether the baby is a singleton or there is multiparity. Sorry, the multiple gestation is there, twin or triplet, quadruplet, if they are, then the mortality will be affected. So the very important thing is that delivery room care. So there must be a neonatologist or pediatrician who is skilled in resuscitating the newborn with a T-piece resuscitator. We know that AMBU bag is delivering 0 CPAP or 0 PEEP. And in prematures like ELBW, you will find that the HMD is there, respiratory distress is there, the lungs are collapsing during the period of expiration. So we have to give consistent or continuous CPAP to the baby or PEEP to the baby while you are resuscitating. So T-piece resuscitation has to be done, and it has to be planned. And immediate wrapping of the baby is very, very essential, because a lot of water loss is there. And for that, you have got some plastic wrap, or the baby should be put inside the plastic bag, and very quickly. And we should never forget to cover the head, because a lot of heat is going to be lost from the head of the baby. And usually, previously, we used to ensure the temperature of the labor room by 25 degrees Celsius. We say that you keep 26, 27 degrees Celsius if you are delivering a very ELBW baby. Cord clamping has already been discussed, that delayed cord clamping means more than 60 seconds to be practiced, or this reduces the incidence of incidence of the repeated blood transfusion to the baby subsequently. And resuscitation should be started with a T-piece resuscitator, I said, with a oxygen concentration of 21 to 30%. So ideally not room air, rather you will start from 30% in ELBWs. And delivery room CPAP should be started. So initial early CPAP, as Dr. Rajesh has already talked, that you need not to have a proper CPAP machine for that. A T-piece resuscitator, you put the mask over the face and nose of the baby, and you have already set the PEEP. So you 6 is all right for the, and you keep it there. So it should be started from the labor room itself, and the target saturation should be achieved. You see, at 1 minute of time, the target saturation is only 65 to 70%. So we should not hurry in attaining more than 90% of saturation, more than 85% of saturation within 5 minutes of delivery. You see, at 1 minute it may be 65, 70 is all right, or 2 minutes maybe 70, 75% is. So if you are attaining target saturation, you need not to increase the FiO2 or the oxygen concentration to be increased while resuscitating the baby. And we should always target 90 to 95%, not more than 95. I will say 90 to 94 you target, and if it is more than 95 or more, then you reduce the FiO2. So this is the cellophane sheet which has been given to prevent the heat loss from the baby. Then there should be a pre-warmed transport incubator. So from the labor room, you have to transfer the baby to the NICU. So during that period, you should have a pre-warmed incubator, so that the baby can be transferred very easily with a continuous CPAP. So CPAP has to be started from the labor room itself, and while transferring the baby from the labor room to the NICU, the CPAP should be continued. And then in NICU care, we know that ELBW, they require initial respiratory support, and for that CPAP you have already started from the birth, from the labor room itself. And the other things which are very important, like fluid volume assessment and administration, then blood sugar, blood gases, and electrolytes should be monitored very frequently. And optimal nutrition should be started right from birth, means minimal internutrition should be started as soon as possible, and a very high dose parental nutrition means from day one you can start 2 to 3 gram per kg of protein and 2 grams of lipid, and this glucose infusion rate something between 4 to 6 milligram per kg per hour. So that has to be started, and the early lab test requires significant percentage of the blood to be taken from the baby. So sampling should be restricted as much as possible, and then minimum adhesive should be used while you are applying the IV lines, because once you are peeling off the adhesive, this will peel off some part of the skin of the baby as well, and that works as a port of infection. And types of respiratory support like CPAP, conventional CPAP, surfactant therapy may be required in many cases, and high frequency HFO ventilation may be required. Caffeine citrate is required by most of the babies. So far as CPAP is concerned, we usually start at 6 centimeter water, and then it should be increased 1 centimeter to a maximum of 8 centimeter up to a FiO2 of 30 to 40%. And if your baby is requiring more than 30% of FiO2 with a CPAP of 7 or 8, then you should give surfactant therapy as soon as possible. And if the baby is getting this recurrent apnea, or if the oxygen requirement is increasing, you see more than 40% oxygen requirement at a CPAP of 7, we usually intubate and put the patient on conventional ventilator. So that should be the practice we should do. Then early use of CPAP with selective subsequent surfactant therapy should be practiced with the indication we have already talked. And while we are using this CPAP, this one thing we have to know, that while you have already administering CPAP, better is by Ram's cannula or so, very easy to deliver CPAP. And while the baby is already on CPAP, you do administer surfactant. The best way of using surfactant is LISA, least invasive surfactant therapy. LISA catheter now is available and through Vigon, and for last 2 years we are not using this insure method. Rather, while the baby is on CPAP, you just put the LISA catheter in the larynx of the baby, and then you give surfactant, and this works very nicely. So your baby is not disconnected from CPAP even for a second. You see, and in that condition, if you are using other cannula like this one, it will be difficult to intubate. So, but if you are using Ram's cannula, it is very easy, and it will give you proper space for this LISA catheterization and administration of the surfactant. And we know that surfactant reduces BPD and a lot of death. Hospital stays reduced, and ventilatory requirement is very much reduced. So if we are using this ventilation, then what we should do? Pressure limited SIMV mode is the best one, but this should have a volume guarantee. So many a times this pressure limited volume guarantee mode should be the practice, and the lowest volume should be used like 4 to 5 ml per kg body weight, and inspiratory time should be short, 0.3 to 0.35 seconds, and we should avoid hyperoxia. I will say that we should never go beyond 94%, because this is going to have increased incidence of chronic lung disease. And we should use right PEEP. So that is the art, that you should achieve, give more PEEP so that FRC is achieved. You see, functional residual capacity, the alveoli are partially inflated even during expiration. That is the idea of giving right PEEP. In the beginning, you may require 6 or 7 centimeter water pressure of this CPAP or PEEP. And the surfactant therapy should be given. Surfactant should be given when there is when you think that your baby is requiring more FiO2 at a CPAP of 7 or so, more than 30%. And Lisa, I said that this is a preferred method now, and it gives you less trauma to the baby. And many treated infants can be rapidly transitioned to CPAP shortly after surfactant administration. I said that CPAP should not be disconnected even for a second while you are administering surfactant. So that has to be the practice, and you use Lisa catheter. If you don't have Lisa catheter, you use only feeding tube. Okay, so that feeding tube can also be, but then you have to use that forceps, so angular forceps, what the ENT people are just using for removing the foreign body from the throat. So that should be the practice. But Lisa is available. And HFO should be used, high frequency oscillatory ventilation should be used only when you find air leak syndrome. But many centers, they are using this HFO as a primary mode of ventilation. If you are very much tuned in using HFO, you can use it. And we are using it for last 15 years or so, but not as a routine practice in this ELBW. Rather, if conventional ventilation, if fails, then only we are using HFO. So far as caffeine citrate is concerned, the early initiation of caffeine is better in ELBW patients. Early initiation means less than 2 hours or so. 2 hours to 3 days or so. So, and it reduces the incidence of CPAP failure. It facilitates extubation as well. Means early extubation can be done if you have put the patient on ventilator. And the dose we all know, and we will not go in that. And we know that this should be used up to 34 weeks of postmenstrual age or for 7 days apnea-free period. And fluid requirement increases as gestational age decreases. Means in lower weight, lower gestational age, more fluid is required. And we know that there is renal immaturity, and so a lot of fluid loss is there in ELBWs, and so we have to maintain the input-output chart. So many a times you will find that you are giving, suppose 120 ml of fluid to the baby, and the baby is passing 180 ml of fluid in last 24 hours. Then you have to adjust it. Urinary output with plus insensible loss 40 ml or 50 ml per kg, like that, and you have to calculate that. So input and output chart for last 24 hours, I will say that in last 8 hours sometimes you have to calculate, because these babies are having a lot of diuresis after 3 days, and so it will be very difficult to maintain even hydration if you will go by traditional calculation. And route of administration should be by double lumen umbilical venous catheterization. So arterial catheterization, umbilical arterial catheterization should also be done in ELBW babies if they are not stable at birth. And the dwell time of UVC is usually 7 to 10 days. So, but you try to keep it only for first 4 days. A lot of CLAPSI is reported after this. And after 4 days or even after 7 or 10 days, you should keep your antecubital veins or great saphenous veins safe for this PICC line. So this is very, very important that in first 4 days or 7 days you give the things through the UBC and subsequently through PICC line. So this is the picture of PICC line. So this is the fluid requirement on day, depending upon the gestational weight of the baby. Lesser the weight, more fluid requirement is there. Fluid composition is, we should target more than this 45 milligram per DL of glucose, and the dextrose solution should be started from 5% only. You may go up to 7.5. Our target of GIR should be 4 to 8 milligram per kg per minute. Hyperosmolar should be, hypoosmolar solution should be avoided. You see, that should be the point. And if there is hyperglycemia, more than 180 or so, then we should, and with glycosuria, we should give glucose infusion, insulin infusion at a dose what we give in DKA, like 0.05 to 0.1 milligram per kg per hour. But you do not omit this glucose. So at the place of suppose 5%, you don't give normal saline. Rather you give insulin from outside so that the glucose can be utilized. Nutritional support, we talked that parental nutrition should be started from day 1 itself, 2 to 3 gram protein, and you can increase up to 3 to 4 gram. Parental lipids should be started maybe 1 to 2 gram per day from day 1 of life, and then you should increase up to 3 gram per kg per day. Then safe initiation of enteral feed should be given as soon as possible, 10 to 20 mil. So from day 1 of life, at least you can give men minimal enteral nutrition. And once successful tolerance of feed is there, we can increase it 20 to 30 mil per kg per day. So in very ELBW, we usually start from 20 and we increase 20 ml per kg per day. And milk fortifiers, previously we used to give human milk fortifiers at a, when the baby used to tolerate 60 to 100 ml of feed per kg per day. But now recommendation is you give HMF once the tolerance is up to 40 to 60 ml per kg per day. So even after 40 ml, 50 ml per kg per day, if the baby is digesting, then we can use human milk fortifier. And even the human milk fortifier is already available here, even in Patna. Cardiovascular support, we should maintain blood pressure, hypertension. We should avoid more than avoid fluid boluses. 1 to 2 it's all right, but not more than 2 in the ELBW, because they are very prone to develop congestive heart failure. And dopamine should be the drug of choice. Delayed cramping we have already talked, because this also prevents hypotension in the newborn. And we can use this corticosteroid 1 milligram per kg BD for first 2 days if there is unresponsive hypotension with catecholamine. So that should be there. PDA ligation, a lot has been discussed. I will not talk about that. And these drugs have been talked. Infection control, a lot have been talked. The only thing is that hand hygiene and limiting blood drawing and skin procedures. Protocol for this central venous lines that should be there. And we should always screen for infection. I will always suggest that once you receive a baby in your NICU, you always send a blood culture while before starting your antibiotic. And so far as fluconazole prophylaxis is there, it is recommended when baseline incidence of fungal infection is very high in your NICU. So then you can use fluconazole prophylaxis. Follow-up screening should be done by ultrasound, audiology screening, ophthalmological exams and vaccination, and neurodevelopmental follow-up programs should be practiced in our neonatal practice. We know that USG should be done in all infants if the gestational age is less than 32 weeks at day 7 and to 10 of life. Audiology screening, we should examine a minute only. Examine at 34 weeks of gestation or greater. And then BIHAR test must be completed before 3 months of age. ROPA screening is very, very essential. It has to be done by all the babies who are born less than 32 weeks or less than 1200 grams. In India, this is more liberal, less than 34 weeks or less than even 1.5 kg baby, we should go for this. And the one thing is very important for in LBW babies, the screening should be done between 2 to 3 weeks of life. You see, after 14 days only you should go for ROPA screening in ELBW babies. In bigger babies, 1.5 kg or more, you can go for a screening at 28 days of life. So that should be noted. And the baby should receive their routine immunization according to same schedule as term infants except hepatitis B. So hepatitis B vaccine should be given at 1 month of age or 30 days of age in cases of ELBW. So thank you very much for your patient hearing.
Thank you, Dr. Vinod. Your discussion is very niceful to save the life of the pre-established newborn babies. Thanks. No, there is no time, so the questions are not allowed.
Thank you, sir. Thank you, all the chairpersons and the speaker. Please come for the memento distribution. I will ask them to assist. Next, moving on, we have another session by Dr. Gaurav Gupta. I will request Dr. Gaurav Gupta. And for chairing that session, I will request Dr. Ramji Gupta, sir, Dr. Akhilesh, sir, NMCH, डॉक्टर सुनील कुमार बिहार शरीफ, डॉक्टर सुजीत सर NMCH और डॉक्टर विपिन वर्मा सर पावापुरी। डॉक्टर विपिन वर्मा सर पावापुरी, सुजीत सर, रामजी गुप्ता सर, डॉक्टर सुप्रभात सर, हाँ सर इंट्रोडक्शन।
Hello. Very
Good afternoon to all the delegates. The speaker is none other than Dr. Gaurav Gupta. He is the Associate Professor, Department of Pediatrics, AIMS Guwahati. He is DM in Neonatology and areas of interest, NRP, National Ventilations, Neonatal Ventilation, Nutrition. And major achievement is he is the EB member, East Zone, IIP, Neonatology, Chapter and Associate Fellow, NMS, NRP Instructor, and there are so many publications. Now over to Gaurav.
Thank you. Thank you, Chairperson sir, for kindly introducing me to this audience. And I welcome you for this E-Zone Neocon. And I am humbled to be invited by the organizers, actually. And very good afternoon to all of you. And today we'll be discussing the very much important topic, which is actually a need of our, which is the dilemma in diagnosis and treatment of meningitis in neonates. As we know, like we are always talking about sepsis and other things. But here one thing arises, like if the baby is having meningitis, then what are those diagnostic things and what are the diagnostic dilemma which prevent us from making not only the diagnosis but treating baby also. So right now I will just have a introduction and background, what is the background behind it, and there are many therapeutic and diagnostic uncertainties behind the neonatal meningitis. I will be discussing this in the later on slides. And it's remained the global highest issue with the high rate of mortality, and the important issue, it has a long-term morbidity despite the advent of good antimicrobial therapy. So basically it's the inflammation of the meninges, which is more common in the neonatal period because of their immature immune system, and which is deficient both in humoral and cellular based immunity. Incidence is around 0.1 to 0.4 per 1,000 live birth, but it is actually very much higher in preterm and chronic hospitalized infants. Mortality is around 10%, as you can see, but the overall mortality rate can be increased around 30 to 40% in developing nations. And the important aspect is the neuromorbidity or neurological sequelae. It is around 50%, around even more than that actually in some settings. So we have to treat those complications also. We have to properly treat meningitis. So what are those diagnostic lacunae behind in which prevent us in treating the meningitis of those neonates? And one more thing is that one data has been found that meningitis has been occur in around 20% of the newborn or the infants which has occult bacteremia or which have proven sepsis, like culture positive sepsis. So these are the one babies which we have to look for definitely to see for meningitis in them. Now coming on to the some etiology and risk factors. What are the etiology? As we define early onset neonatal sepsis, and we usually defined as early onset neonatal meningitis also, which occurs less than 72 hours. Although it is very less common, it is mostly caused by group B streptococci, Escherichia coli and Listeria. But late onset, which is the more common and more devastating complication, which is, so basically it is caused by the gram-negative bacteria like E. coli, Klebsiella, Staphylococcus. So these are the main culprit behind the late onset, and it is the one which we are actually more concerned about, late onset sepsis, which is giving rise to the meningitis. Mainly it is culprits are gram-negative bacteria. So other risk factors, what are those? They are actually prematurity, low birth weight, premature rupture of membranes greater than 24 hours, maternal chorioamnitis, one of the risk factor, maternal colonization with group B streptococci, although it is less common in our country, but it is much more common in the Western world. And invasive procedure like central venous access, ventilation of the newborn, presence of any shunt, these are the associated some risk factors which give rise to the meningitis in newborn. So what is the dilemma in the clinical manifestation? The main important thing, they have a overlapping clinical features. There is no specific clinical feature or clinical signs which can manifest like it is meningitis or it is sepsis. So they have a lower non-specific signs like poor feeding, temperature instability, which is found in more or less other condition also. So that's why we have to be very strictly monitor those babies to look for the meningitis. But the only method to see is for the lumbar puncture, and which is followed by the CSF examination, which we have to do. There was one recent meta-analysis and systematic review which is done and which is published in Journal of Neonatology, and they have found that neurological signs have a pooled prevalence of around 23% only. They are only with the child with the meningitis, with proven meningitis, they have only 23% of those finds. And seizures comprises of around 21%. So they have found this in the recent meta-analysis. And so basically it has one thing which has to be kept in mind. It's not merely the presence of neurological signs which we have to look in the babies with the meningitis. We should have a high suspicion of the meningitis, because absence of neurological signs does not rule out meningitis. This recent meta-analysis has found that it has been found to be around pooled prevalence of 23%. And they have also found the neurological complication which are more common in the meningitis, which is that they found that ventriculitis was the most common. Ventriculitis was the main culprit which has become a most common complication of neonatal meningitis, followed by seizures, epilepsy in later on in life, ICH, cerebral palsy, and post-ventricular hydrocephalus actually. So these are the things they have looked, and they have found that based on the intensity, based on the severity, based on the frequency, they have labeled that ventriculitis was the most common complication. Now what we have to do, these are the common clinical signs which may find in bacterial sepsis, early onset neonatal sepsis, late onset neonatal sepsis, and even with the meningitis. So that's why this has become a diagnostic dilemma when we have to see based on merely on the basis of clinical feature, we are not able to identify which are baby with the which are babies with the meningitis, or which are the babies which are actually only having the culture proven or only sepsis. So these are like tense bulging fontanelle, refusal feed or vomiting, unusual cry, moaning, drowsiness, and convulsions, seizures, which may occur around 20 to 21% cases of even with the meningitis, rapid breathing, fever, cold hand, and poor feeding, lethargy. So we have to look about one thing, okay, what is that? Then first dilemma, then when to do a lumbar puncture for those babies and whom to do. So we know that LP is the gold standard for making a diagnosis of a meningitis in any baby which is either a culture positive or even a culture negative. But the important aspect is there, we are most of the time stuck up in doing LP because of the cardiorespiratory compromise, okay, because of the coagulopathy, because sometimes babies are on bubble CPAP support, so because of the technical difficulty, we are not able to do. And American Academy of Pediatrics recommends that all symptomatic neonates for mainly with the who are presenting with the late onset sepsis should always be evaluated for the meningitis. We should always do LP in those babies. And for early onset neonatal sepsis, we can do LP for those two only indication. One is the culture positive sepsis, second is the clinical manifestation like seizures, any symptom pertaining to the CNS, then we can go for those babies LP for early onset neonatal sepsis. And we should avoid LP in those babies who are asymptomatic but only with maternal risk factor alone. So we can actually withhold those LPs in those babies. So this is the one more thing. And second thing is that we should not, it's not possible like even 1/3 of the babies who have been found culture negative may be having a meningitis. So that is the reason LP should not be missed or deferred in those LONS baby. If we are prudent, we are waiting for the culture report, because 30% of the babies may have meningitis even with the culture negative sepsis. So other thing, one diagnostic dilemma is another thing. कि they are having CSF parameters. So CSF parameters again have poor specificity and they differ in the neonates and preterm as well as the term. We have to use the age reference charting. Now another thing is that we have to do LP antibiotic administration prior to LP, because it has been found that if you give the antibiotics, then there is clearance of organism within 4 to 6 hours of giving antibiotics. So it is prudent to start antibiotics before LP in order to lose the report of having culture positive organism. And second thing is that CSF fluorocytosis and all those raised protein may persist for 48 hours, but they are actually unreliable in the differentiating these if we are doing, because they don't have the specific cutoff values even at 48 hours of life, because we will be having mixed picture. So other factors which influence these values, they include gestational age, postnatal age. We have a separate specific chart for less than 7 days, more than 7 days, and contamination of lumbar puncture during CSF with the blood, like traumatic LP. So these are the certain pitfalls doing LP in those newborns. So when to repeat LP, what is the second thing which has to come in mind? It is recommended for those babies who are having persistent pyrexia and raised acute phase reactant. Now, certain things which I will to tell about this thing, I think most of the audience might not be knowing what are the certain novel diagnostic approaches. First is the PCR based testing. PCR based testing has an advantage, it can detect the nucleus from non-viable, like dead organism also. So it will increase the diagnostic yield as compared to like others CSF culture and other blood biochemistry report. Second thing, even if we give the antibiotics, even that results will come prudent, because it will not have any effect on the antibiotic pre-treatment as compared to the culture report of the CSF. And multiplex PS and PCR panel have been approved by FDA, which can include around 14 pathogens, include E. coli, GBS, Listeria. They have a very good advantage of rapid turnaround time. They can detect the organism even after antibiotic administration. So there is much more usefulness of these parameters over LP-CSF culture. And there is only limitation that the sensitivity and specificity has not been proven for these type of tests, and they need certain validation and they are need for research topic for in the future research. Second thing is the one more important cytokine based evaluation of the CSF. So meningitis elicit a host response system which represents the host signature which is pathognomic of infection. So there has been certain studies which they have been done on the human, certain has been done on the animal model, and they have been found that interleukin 6 and 10 has been raised in the CSF during the with the babies are having active meningitis, and they have proven under the ROC curve that area under curve was much high in those two parameters, which is IL-6 and IL-7. Second thing, certain S100B protein, they have also have an early promise for a biomarker for meningitis because their concentration in the astrocytes and glial cells. So these are the future research topics so that we can move on from the traditional LP to having these cytokines based testing in the CSF. Second thing, what are the other investigation we can do for the like cranial ultrasound to rule out any complication like hemorrhage, infarction, or for hydrocephalus. CT had to be done to rule out any ventriculitis for degree of cerebral edema and site of block. And definitely MRI for any neurological abnormalities, persistent ventriculitis, hydrocephalus, subdural empyema. So these are the things we have to look not only for the meningitis but for the forthcoming complication which are associated with the meningitis. Why these are also needed? Because I will come, NNF has raised a CPG guidelines. They have clearly mentioned the duration of antibiotics. So LP will also guide in duration of antibiotics also if that is a complication, and these investigations will also guide in us in duration of antibiotics. Like for these ventriculitis we have to give minimum 4 to 6 weeks. For uncomplicated meningitis we usually give for 21 days. Now we'll come to the management aspect, like delayed early treatment is very much necessary in order to prevent the complication, which includes cerebral palsy, deafness. Supportive care, fluids are necessary, and antimicrobial or agents become the mainstay of treatment. Although management is critical to promote the more favorable outcome,
But there are two things which most of the people say, how steroids are useful and what is the IVIG and other immunomodulator will do in the babies with the meningitis. Let me tell you, steroid administration has not been beneficial as an adjunct to the antibiotic therapy. It has been only proven if the cases are in fact with the H influenza B, because they have been improved neurological and auditory outcome. But the dictum is that this organism, this culprit is mostly not found in our cases, in our meningitis cases with late onset sepsis. We are having Pseudomonas, we are having Klebsiella, E. coli, and we are having effective vaccination strategies also. So that's why steroids are not recommended as an adjunctive therapy, and even IVIG and other immunomodulator does not have a disappointing role. This is the recent, they have also mentioned in the recent meta-analysis. Now what we have to do, basically first more important thing is that antibiotic should be chosen based on the local antibiogram, based on the local unit policy. But however, they have laid down certain guidelines you can have a mix of ampicillin and gentamicin as the first line of antibiotics for neonatal meningitis, or even with ceftriaxone. And vancomycin can be used if a suspected hospital-acquired infection is used, which is caused by cons or MRSA. In case of viral meningitis, definitely acyclovir becomes a drug of choice. And second thing, these are the empirical choice of antibiotics which I have discussed. Antibiotics should be given at least 3 weeks for all cases of neonatal meningitis. We have to monitor the head circumference, which should be measured twice weekly, and daily neurological examination to be documented to see for any focal neurological deficit. And cranial ultrasound should be done within the first week, and at the end of antibiotic therapy to guide for the ventricular enhancement, ventricular wall enhancement, to look for IVH. So these things we have to do comprehensively to evaluate for a child with meningitis, to treat with the meningitis, to see for any complication associated with the meningitis. Now these are the certain guidelines which I was telling about. This has been laid by NNF in CPG 2021 clinical practice guideline. They clearly show that every unit should implement a facility specific empirical antibiotic therapy based on the antibiogram local. It has to be evaluated by 12 months or even within 6 months also, every 6 months interval. And these guidelines also tell not to use any shorter course of antibiotic like less than 14 days. In children, in the babies with uncomplicated meningitis, we have to give for minimum 21 days actually. And second thing is that why I was asking about the complications, neurological complications which are more common, which include ventriculitis, seizures, and they have strongly associated with not only with the increased mortality, but they have been associated with the poor neurodevelopmental outcome in those babies with the meningitis. So NNF also had laid down certain guidelines which has clearly told that if the baby is having complicated meningitis, which include ventriculitis or abscess, then the standard duration of antibiotic therapy may be extended to 4 to 6 weeks, and that too mainly with the intravenous therapy. So these are the things which we have to see. And even the one more thing, even with the infant with the culture negative show, they have more chances of fungal infection, CLABSI, and prognosis may be also related to virulence. So I will describe the summary of the diagnostic. First thing is the non-specific presentation. Only 23% of the cases show classical symptom, which is the thing which we have to look about. And second thing, the LP timings. LP is risky sometimes in the unstable newborn, and LP administration should be done. LP should be done prior to the antibiotic administration. There are certain things like CSF, protein, glucose. They are actually having overlapping clinical pictures. They are poor marker in actually sick babies as compared to healthy babies. And even negative culture. Almost 1/3 of the babies with proven meningitis will show negative cultures. So there what we have to do, we have to just base the evidence-based approach. We include evaluate the neonate with sepsis signs. If symptomatic, then perform LP, and should be given LP should be done just before the antibiotic administration. If LP is delayed, then we can go for the like CSF panel, and if antibiotics are given, we can go for PCR testing because it does not have any effect administration of antibiotics. Second thing, we have to interpret CSF with the age-assessed norm. And we can consider even in later on, like it's a future research topic also, CSF cytokines as an engine.
So these are the things. So coming on to our take-home message, neonatal meningitis associated with high case fatality rates. LP still remains the golden standard for the diagnosis. Molecular tests are having promising result, but yet they are not replacement for culture. And we have to avoid the prolonged antibiotic usage mainly in the uncomplicated meningitis. And we have to ensure the neurological examination and imaging in the follow-up. Thank you for the patience listening. Thank you very much. These are my references. Thank you.
Thank you, Dr. Gaurav. You cover most of the part of the diagnostic dilemma of neonatal meningitis. One thing I will say only, the in day-to-day practice, in day-to-day practice, your mind should be open. You have,
yes, sir.
Yeah, a high index of clinical suspicion. Any child coming to you, you must see activity. For give 2 minute, 3 minute time to the newborn. Any abnormal limping, any abnormal focal movement, yes, any eye blinking. Second thing, when you are in periphery, when you are in OPD, you must give first course of antibiotic, stabilize the patient, give glucose, give some NS, yes, normal saline. You must stabilize the patient, one thing. Second, when you are doing the LP, you must have mind how much protein is normal for a premature. Sometimes, sir, 80 आ गया protein. Sir, इसको start कर दें antibiotic? No. There is no need unless you must know the normal limits of the CSF.
Yes, sir.
And you very well said that they start the treatment early to prevent the neurological sequelae.
Yes, sir.
Like every child is precious and every newborn is precious. Thank you,
sir. Yes. That's why, sir, I have not covered that age-specific norms because it is written that tabular form and it's there in the. We should always remember the mean value, but the thing is that because it's a topic was there, so I covered these aspects. We have to do the LP prior to just in order because if we give the antibiotics, then organism may disappear within 4 to 6 hours. But however, we have to keep a risk like if the baby is unstable, we should not defer the antibiotic. We should always start antibiotics, and we can always have that. And that's why I have discussed the newer molecular like PCR-based test, which will not affect the antibiotic prior administration. And nowadays like CSF, for the institute who can offer, and it's a prior, it's a like hot research topic nowadays. So this was the thing. Thank you very much, sir.
Okay.
Thank you, Dr. Gaurav. Any question from the audience? No.
Sir, we are not taking any questions. Sorry, we are getting delayed. Please come for the memento distribution. Next, I will call Dr. Shravan sir for the next talk. And for chairing that session, I will request Dr. Gopal Saran sir, Dr. Hima Charan ma'am, Dr. Vivekanand Sinha, and Dr. Rajiv Singh sir. Dr. Rajiv Singh sir, PMCH, Dr. Gopal sir, Dr. Hima Charan ma'am, Dr. Vivekanand Sinha. Shravan sir, please.
Hello. Dr. Shravan sir is well known to all Bihar. He is MD, DCH Fellowship NNF in Neonatology, President NNF Bihar, National Trainer NRP and FBNC. Established the first NICU in Bihar and is popularly called as Father of Neonatology Bihar. पूरा कर दें.
Okay. Thank you, sir. Management of neonatal shock. Earlier, we were also talking about dilemma. I will also start with the dilemma, best practice, what is the future direction, and what is the conclusion. And before I should start, I will say that neonatal shock is a hidden killer, silent in presentation and devastating in outcome. Only early recognition and prompt action can ensure with an intact brain and intact body. So, introduction in the shock we are knowing that failure of circulation. But what is most important? Tissue perfusion. Even if tissue perfusion is not proper, whatever the circulation is there, it is not good. The unique physiology, immature auto-regulation, and this is the early recognition and management remain the challenging. And what is dilemma? We are all reliant on the hypotension. If blood pressure is low, we think that there is shock. But problem is that blood pressure may be normal, but yet tissue perfusion is inadequate. So solely blood pressure driven therapy will delay an inappropriate treatment. So why hypotension alone is a misleading. Immature baroreceptor in newborn, wide variation in normal blood pressure by gestational age, birth weight and age. We all know that if the blood pressure is lower than the gestational age in premature baby, baby is hypotensive. But even there is low blood pressure, but if perfusion is okay, you should wait. And baby with normal blood pressure can have high lactate and poor urine output. So it is a confusing state. So the main what we have to see before blood pressure. The management must depend not only on blood pressure but multimodal assessment is important, in which the CRT, capillary refill time, if more than 3 seconds, this is the earliest sign. And color of the baby, if there is a mottling, a dusky color, we should have a very alert. And pulse volume is very important. Brachial pulse should be palpated, and if the volume is good, we should assure that baby is normotensive. Urine output, biochemical marker like lactate base deficit is important. Advanced tool like echocardiogram, NIRS now is a very good tool by which you can assess the tissue perfusion. Perfusion index is again a simple. See, this is the pulse oximeter, and in this the bar, longitudinal bar will show the perfusion index. It goes ups and down, and if this perfusion index is more than 50% of the total length, then the perfusion index is adequate. And this is the NIRS, near infrared spectroscopy. This is a very recent tool by which we can know the tissue perfusion and brain, whether the brain is well perfused or not, and that will decrease the HIE, hypoxic ischemic encephalopathy. So here the probe is, sensor is on the forehead of the baby, and we can assess the cerebral oxygenation, regional saturation of the oxygen in the brain. And this can be assessed regularly in every baby if your fund allows. And cardiac dysfunction in perinatal asphyxia is again a matter of very problematic because proper history is very important. If you have in perinatal, antenatal, natal are always confusing. Our obstetrician friends are not giving proper history, and what happens is that sudden there is shock after some time. So we have to be very alert. So hypoxic ischemia, myocardial injury, left ventricular dysfunction, pulmonary hypertension, often no clear perinatal history is there. So the clue is that poor perfusion, metabolic acidity, low urine output, and neurological sign. The baby may be unconscious. So this appears suddenly. Biomarker nowadays is gaining ground. That just like in adult, what is happening that in adult, due to after myocardial infection, the troponin I and are being done. But now in newborn also we should do troponin test. That will detect myocardial injury. CK-MB, creatinine kinase MB is less specific, but it is more important in adult. NT-proBNP, ventricular strain. This is the earliest biomarker you can get if there is myocardial dysfunction. Lactate and ABG, metabolic status, you should do. Echocardiogram, everyone are now is very much concerned about the echocardiogram. Targeted echocardiogram, it not only identify dysfunction, but it will guide what type of inotrope you have to give and differentiate hypovolemia. What happens sometimes we are seeing that there is baby is plethoric, but if you are doing echocardiogram, inferior vena cava is collapsed. So you have to first give the bolus and then you have to do another thing. So this is confusing state. So unless you are doing echocardiogram, you cannot manage neonatal shock properly. And vasodilatation and PPHN can only be diagnosed by this echocardiogram. And principle of best practice is that stepwise approach, like oxygenation, correct metabolic acidosis, cautious fluid, physiologically based, physiological guided inotropes, adrenal support. Hydrocortisone should be given if there is resistant shock. Adequate, always integrate with the therapeutic hypothermia protocol when indicated. Inotropes. Inotropes, earlier we were giving dopamine left and right, but nowadays dopamine is not good for newborn. Why? Because dopamine acts on the chronotropic and inotropic blood. Heart will be contract very fast, but the side effect is that it will constrict the vasoconstriction, peripheral vasoconstriction will be there. So peripheral circulation will be affected. And more bad thing that it not only causes vasoconstriction, systemic vasoconstriction, but it will cause pulmonary vasoconstriction that we don't want to have. Because if there is pulmonary vasoconstriction, the circulation will not be proper, the pulmonary circulation will not be proper, and so the oxygenation will be not proper. So in newborn, this dopamine is last drug in only the vasodilatory shock, that is called warm shock, we can give. But dopamine is the first line of treatment, I should say, because it improves the cardiac output and preferred in left ventricular dysfunction, and because it doesn't affect the pulmonary vasoconstriction, so this is a good drug for myocardial dysfunction. Epinephrine is in refractory shock, and Milinon is a very good drug if there is left ventricular dysfunction, and in PPHN, because it decreases the pulmonary resistance, the pulmonary circulation will be improved, and vasopressin and adrenaline should be a reserved inotrope in rescue in refractory vasoplasia. So the practical framework, which inotrope and when the valve is, I have already said. I will get it short. The limitation of current practice is that lack of neonatal randomized control tracks is there. We have not much RCT, variable guidelines across unit, limited availability of ECO and NIRS in many centers. Empirical use of inotrope is still common. So the future research and inotrope, what should be done? The precision therapy. Now the recent medicine is the precision medicine, in which the AI, artificial intelligence, all the advanced tools and are gathered together, and this will guide all the things what you should do, what not to do. And this is the newer advance. And biomarker, as I have said, is a very good drug, very good marker, troponin, BNP, lactate clearance, and newer agent, levosimendan, calcium sensitizer is newer, but it is not available in Patna, but it is a very good drug, inotrope. And sildenafil, as we are using, nitric oxide is also very good drug for PPHN. So our AI decision support and algorithm, early detection and individualized care is a best way to manage and best way. Need neonatal specific safety and efficacy trial. So monitoring follow-up serial echocardiogram. We should not do one echogram. You have to assess what is the progress. And biomarker, perfusion index, I said, and the marker like lactate clearance, urine output. NIRS is a very good tool, long-term follow-up for infant and severe dysfunction should be taken care. So I will cut short and take home message that shock can exist in normal blood pressure. Not all hypotensive are having neonatal shock. Even some normal, there is called, even the low blood pressure, if the perfusion is okay, you should not be worried. Best practice is that multimodal monitoring, physiological guided inotrope, avoid unnecessary fluids, supportive care, and future is the biomarker, AI, and precision medicine. Thank you for patient hearing.
Thank you, Dr. Shravan Kumar, for your nice presentation. And because we are running short of time, perhaps no question will be allowed. Thank you.
Thank you, Shravan sir, and thank you all the chairperson. I will request to come for the memento distribution. I request Vinod sir to please assist in the memento distribution. Moving on next, we have a panel discussion again on neonatal encephalopathy beyond HIE, and the moderator is Dr. Jagdish Prasad Sahu. I will request Dr. Jagdish Sahu to please come on dais, and the chairperson is very honorable from Dr. Vijay Jain sir from the Gaya. I will request Vijay Jain sir, Dr. Vijay Kumar Singh sir. As sir is not there, I will request Dr. Shiv Bachchan sir. Shiv Bachchan sir to please chair the session. Dr. Vijay Jain sir and Dr. Shiv Bachchan sir.
I know we are all having hypoglycemia. So, but this session is one of the most important sessions we are going to discuss. Anyhow, we will try to finish in precise time, 40 minutes. So I would request the moderator and my chairperson, my panelists, please be in time.
100%.
We have to finish in 40 minutes. The moderator is Dr. Sahu, Dr. Jagdish Prasad Sahu. Everything is displayed. It is additional professor neonatology, workplace AIMS, Bhubaneswar, qualification MD pediatrics, DM neonatology, MBA, hospital administration, special training in focus neonatal hemodynamics, areas of interest, NRP, community neonatology, nutrition, major achievements, EB member, NNF, East Zone and IFP, neonatology chapter, state coordinator, advanced NRP, so many publications, 37 books, chapters he has written, neonatology section, editor, pediatric emergency textbook. So with this very small introduction, I request moderator Dr. Jagdish Prasad Sahu, you may introduce your panelists and can start the, this lecture on this neonatal encephalopathy. I think this is one of the most common disorder of the of course of the brain dysfunction, leading to so many mortalities and morbidities.
Good afternoon, sir.
And the cause is not only one. The cause is not only one, HIE, but there are so many causes which include sepsis, shock, toxins, metabolic, trauma, the vascular. There are so many causes of leading to this neonatal encephalopathy, not only one cause. So, Dr. Sahu, please start your deliberation.
Thank you so much, sir. So we'll be discussing in very short time about neonatal encephalopathy. We will not cover the asphyxia, which is one of the most common cause of neonatal encephalopathy. And my panelists are Dr. Vivek Pandey, who is in Mahavir Vatsala Hospital and neonatologist. Dr. Saurabh is a associate professor at AIMS Patna. Dr. Rupesh, Dr. Shyam Bihari sir, and Dr. Rishabh. So, greetings from our NNF Odisha State Branch and from the land of Jagannath. So what I'll do, I'll just give a case scenario, then we'll have some theoretical discussion, how we approach to that case, and finally I'll try to show what was the finding in that case and we can summarize. So this is a day 29 baby who was admitted on day 29 of life. It was a home delivery. Baby presented to us with history of abnormal movement, being given a dose of phenobarbital in outside hospital. The baby was delivered at home. Baby was birth weight of 2,700 grams, cried after birth. But mother noticed on day 5, day 6, the baby is not able to swallow. He was having that gurgling sounds. So commonly he has shown a local, the hospital doctors, and they have advised nasal saline drop, but the symptoms were gradually worsening and the baby was not able to swallow. So what mother noticed that she was not gaining weight, baby was not gaining weight properly. But as the symptoms were worsening on day 20 and there was a convulsion, she actually presented to a hospital, to a pediatrician. That is the first interaction with a pediatrician on day 27, when he has advised a phenobarbital and was referred with suspicion of some things. Okay, so the antenatal history were mostly uneventful, no risk factors. So the baby had excessive crying from day 7, but no history of fast breathing. On day 27, less active, poor feeding. Day 29, convulsion. Weight at admission was 2.45, where on day 30, whereas the birth weight was 2700 grams. So we expect the birth weight to be regaining by day 10 of life, and then we should expect the baby should gain at least 30 grams per day. So here there is a weight loss. And on examination, the baby was stuporous. There was no eye contact, bilateral pupils are normal, but there are a lot of pooling of secretions, movements were decreased, and there was a hypotonia. And obviously the baby was looking malnourished, other symptoms were normal. So our provisional diagnosis at the time of admission was definitely neonatal encephalopathy, and we tried to localize the lesion to the brainstem because there was difficulty in swallowing with pooling of secretions. And believe me, in a peripheral hospital, somebody has tried a bronchoscopy for this baby also. I'll show that bronchoscopy picture also. And there was another differential diagnosis of sepsis, meningitis, ventriculitis or complications. So neonatal encephalopathy is a clinical syndrome of disturbed neurological function in the first week after birth in an infant beyond 35 weeks of gestation, manifested by abnormal consciousness, seizures associated with difficulty with initiating and maintaining respiration, and depression of the tone and reflexes. It is the leading cause of neonatal death. With us are described, there are a lot of causes. It's not only HI. So this is the clinical signs of moderate or severe encephalopathy. What has been defined is altered state of consciousness, that is either lethargy, stupor or coma, and at least one of hypotonia or abnormal reflexes or abnormal shock or seizures. So this is the definition. So my baby fits into the definition of neonatal encephalopathy. So now coming to the approach, so just we'll discuss this about this case and this scenario with my panelists. Dr. Rishabh, can you just tell me, is neonatal encephalopathy and HI both are same? Can they be used interchangeably?
Yes, sir. To this question, definitely these two terms, hypoxic ischemic encephalopathy and neonatal encephalopathy, they are related, but they cannot be used interchangeably. The reason being, neonatal encephalopathy, as you just now said, it is a broad spectrum of diseases with many causes, and among them, hypoxic ischemic encephalopathy is one of the causes which results from a hypoxic ischemic insult, either caused during antepartum, during intrapartum, any time it can be caused.
Yeah, so it is one of the most important cause of neonatal encephalopathy. So another term, as I told you in the definition, so more than 35 weeks we mostly classify as neonatal encephalopathy. So there is another term about neonatal encephalopathy of prematurity. Can you just tell me what is about that, just in short?
Yes, sir, definitely. Encephalopathy of prematurity is another encephalopathy, but it belongs to babies typically less than equal to 32 weeks of gestation. But the main difference is it combines a number of things like hypoxic ischemic encephalopathy and immature cerebrovascular autoregulation. It can be postnatal insult like sepsis or ventilation, and these factors, they damage the axons, oligodendrocytes, neurons, and ultimately leading to periventricular leukomalacia. So this is encephalopathy of prematurity.
Okay. So can you tell us, Dr. Vivek, what may be the other causes, the non-HI, the encephalopathy?
Other causes are most common infectious causes, other are vascular causes, metabolic causes, and some structural, genetic and maternal causes also. In infectious causes, sepsis and meningitis are most common. In metabolic, hypoglycemia, hyperbilirubinemia, inborn error of metabolism, some drug-induced encephalopathy also there. In vascular causes, thrombophilia, stroke, and coagulation defect like things are there. In structural malformations are there, genetic Prader-Willi and other syndrome, neurologically related, and maternal causes, maternal hypotension, maternal hypoglycemia or placental abnormality. These are common
so
causes.
basically, once you rule out asphyxia as the cause, the major cause of neonatal encephalopathy is mostly sepsis or metabolic major cause, and those are treatable and sometimes preventable. But other causes like the metabolic causes, vascular causes, genetic causes, so it is very difficult to handle this baby, and there is no definite treatment. Because the supportive care is the most important management. So what are the features that can distinguish HI from the other causes of encephalopathy, Dr. Shyam sir?
We do get a lot of cases of neonatal encephalopathy, but in the labor room itself, most of the cases is HIE. So first we have to identify what is HIE. In HIE, there is some sentinel events like placenta previa, abscess placenta, cord prolapse, meconium stent, amniotic fluid, or a double or triple round of cord in normal delivery. Intrapartum monitoring do have some findings like fetal HR changes, abnormal Doppler study. There may be history of difficult delivery, prolonged labor, low Apgar scoring, cord blood abnormality in the form of low pH, and multi-organ dysfunctions. If there, it is more in favor of HIE. And HIE do have a distinct pattern. So you can find out what are the cases of HIE. Others, if these are not there, you must look for the non-HIE causes of HIE. We shall differentiate from history, from clinical examinations in the labs, in the imaging, and there are other modalities also to identify. History is very important.
So the
If
presence
the history
of, yes sir. So the actually basically what sir has summarized is the baby has to go through there has to be a perinatal insult, that is the sentinel event. Then the baby has not cried after birth, requiring resuscitation at the time of birth, that is poor Apgar score, umbilical blood gas abnormality. Then in the postnatal period in the NICU, clinical monitoring of the Sannat and Sannat score. Why it is very important to differentiate at first point is because of the advent of therapeutic hypothermia. Because we need to decide to give the treatment within the first 6 hours of life if you are defining it as a HI as the cause of neonatal encephalopathy. So that's why we need to know differentiate whether it is HI or non-HI. So for any baby with suspected encephalopathy, review the history and examine in detail. Then we have to go for the investigations, look for the EEG, monitor for that, whether the baby has a seizure or not. And if we are not able to get the cause in the first line investigation, then we have to go for the second line investigation, imaging. So we'll be discussing one by one. So Dr. Saurabh, can you tell me just specifically how you clinically approach? We'll discuss about the lab findings later. How you clinically approach such a baby?
So, thank you, sir. First of all, I would like to say that the age of presentation of the neonatal encephalopathy is very important. We should see when the baby has presented.
Dr. Saurabh, just mic.
So first of all, we should see when the baby has presented with neonatal encephalopathy, whether the encephalopathy was starting from the birth or whether it has presented after some time. So if it is starting from birth, we should see whether the baby has HIE or whether there was intrapartum drug administration. If it was later on, then the causes may be metabolic causes, so hypoglycemia and bilirubin induced neurological dysfunction can be the causes. However, if the neonatal encephalopathy develops after establishment of the feed, the mother gives a typical picture that the baby was well, was feeding well, and then the baby became encephalopathic, then the causes might be IM. So first of all, you should take a detailed history. Sometimes the practitioners say that the history is not available, the mother is not available, then stabilize the patient and again come back to take history.
Ask for all the reports. Take detailed antenatal history, obstetric complications of the mother, what medications mother was taking. Review all the details of the investigations. Take the maternal obstetric history, whether there was any previous sibling death or whether there was history of recurrent abortions. And take the history of the neonate's birth, that what were the sentinel event, were there any sentinel event present during the birth of the baby, whether the mother has maternal help, which can be a case with, of intrapartum presentation of some IEMs, and take the delivery details and check for the sentinel event. However, if these are not there, sentinel events are not there, you should strongly suspect causes apart from HIE. And take the detailed history of the neonate. First of all, the history of decreased feeding or lethargy, which may point to some septic causes. History of jaundice or anemia, which may point to bind. History of vomiting, lethargy, or abnormal body urine odor, which may point to IEM. History of dehydration or cardiac disease, which may be the causes in CSVT, that is cerebrosinus venous thrombosis. So all these history you should take in detail. And most of the time, when a baby is encephalopathic, we omit the examination. We focus on the investigation. So rather than jumping onto the investigation, do a detailed examination of the baby. A head-to-toe examination will give you pointers like whether the anterior fontanelle is bulging, which will be the case in intracerebral bleed and subdural hematomas. Whether the baby has dysmorphic facies. So dysmorphic facies one can get in IEMs or genetic syndromes. Pupillary size. Pupillary size is very important because meiosis and mydriasis can be in HIE. But if it is persistently non-reacting, then one should think of the brainstem insult. And fundus examination for IEMs, rashes, joint contractures and hypotonia, which may point to muscular disorders. And a detailed CNS examination. CNS examination, level of consciousness, Sarnath and Sarnath scoring, and cranial nerve examination. As Sir told in his case, cranial nerve examination was very important in that case. Whether there was bulbar or pseudobulbar palsy, movement asymmetry, abnormal movement, and semiology of the seizures is also important. Look for organomegaly because most of the IEMs, they will have some kind of organomegaly and cardiomyopathy picture which can get...
So always there has to be a clinical suspicion, then followed by detailed history taking, detailed examination. So presence of midline defects, any dysmorphic features, even if it is a minor malformation, just think of whether there is an underlying genetic you are dealing with. So Dr. Rupesh, can you tell us about the lab investigations in evaluation? So how you stepwise approach by laboratory parameters?
So till now, thank you, sir. So till now, what we discussed, encephalopathy, then HI encephalopathy, non-HI encephalopathy, as we discussed earlier. So HI, we have certain marker, lab investigation also, but non-HI is a big umbrella, and because already Dr. Isaf told us. So how we will by tier approach, all investigation, we can't put all investigation in one baby. As Dr. Saurav said, first HI, non-HI, we discuss non-HI mein, we have so many things. So first tier, second tier investigation we have just just simple basic CVC. So by CVC what we can get leukopenia that will point out the sepsis, that have the thrombocytopenia, that so many IAM will have the thrombocytopenia. Sepsis screen have so many things, so we will do sepsis screen. Clotting study, abnormal coagulation profile, DIC, shock, sepsis, that will come. DCT again for the for the hyperbilirubinemia, that is also one of the common cause for the encephalopathy. LFT, all the metabolic problem. So LFT, blood glucose, we know the hypoglycemia is the poor very great prognosis. We have the hypoglycemia, lactate again for the metabolic disease, CSF study for the meningitis, CSF study for the glycine and all the things. So these will come under the first investigation. Again, if we are not able to diagnose under the first, then we will go for the metabolic and genetic disease. Again, the urinary ketone for the metabolic creatinine kinase, any muscle myopathy, plasma amino acid profile, we know. So based on the CSF and the blood plasma protein profile, profile according to that. Urine organic acidemia, then EEG for the other
So you have to go
baby
for a stepwise approach.
Stepwise
so whenever
approach.
such a baby comes with features
So, you know,
of neonatal encephalopathy.
So, you know, vast number of investigation we have
so
for the non-HIE.
stepwise manner, what you can do is, after stabilizing the baby, first thing check the RBS, put a IV line, send the sample for calcium, blood gas, so sepsis evaluation, stepwise you think. If it is corrected, then go to the next step.
One by one,
One
from
by
simpler,
one you
from
go for.
simpler
So
to
it's
the
not that battery of tests you do it
commoner
at a
to
point of time. So
rarer.
you should know which investigations you need to send. Okay. So Dr. Vivek, he's a trained hemodynamic specialist. Dr. Vivek, can you tell me what is the role of bedside ultrasound? You have the ultrasound machine now.
Yes,
in these babies, how it is going to help you?
Yeah, point of care ultrasound is very much needed nowadays for neonates, and it's helpful, very helpful to diagnose, differentiate between HI and non-HI cases. It is very convenient to do bedside and safe, and it's prevent transport of baby to do MRI. It is important to assess cerebral edema when intraventricular or intraparenchymal hemorrhage, periventricular leukomalacia, cystic changes, and any kind of malformation. And hemodynamic assessment of cerebral fluid is important in this neonatal encephalopathy. We can check for RI, recessive index, that is important to check for cerebral flow.
So basically when we go for a rapid focus, so we rule out any structural malformation in the brain. Most of the structural malformation can be detected with focus with good, but white matter disease may not be known by a very, unless you are an expert in focus, the white matter may be difficult, white matter disease. So another most important what Sir has told is the Doppler changes of the blood vessels in the anterior cerebral artery and the middle cerebral artery. If the value is less than 0.5, so definitely the outcome is going to be affected for this baby, because there is a indirect marker, it is a cerebral vasoconstriction, decrease CNS perfusion is happening. Okay.
But
so,
some advantage and some limitations
yeah,
are also there.
So it is all bedside.
It needs expertise and experience
but definitely,
also.
MRI is the gold standard, but most of the time it may not be practicable, because shifting the baby who is very sick, doing a MRI, and it takes almost 30 minutes, it is difficult. But suppose you are not able to reach, then probably you have to go for MRI. So Dr. Saurav, can you just specifically tell me what are the things you want to look for in the MRI picture?
So first of all, I would like to say MRI is the imaging modality of choice. It will help in diagnosis as well as in prognosis. And it will be very important to differentiate HI from non-HI causes. To clinch the diagnosis in non-HI causes, it will be a tool. And always use the appropriate imaging technique, that is T1, T2. Sometimes we just do the T1, T2 weighted images. So whenever indicated, do a diffusion weighted imaging, and the timing is crucial, that when to do the MRI in neonatal encephalopathy, even in HI cases, it is very important. And it will also help in prognosticating the case.
Yeah.
So
we are not going into the details of MRI in individual conditions. We have it, but because of lack of time. But at least when we go for a MRI, so the white matter, basal ganglia lesions can be clearly picked up, or the deep lesions can be clearly picked up, and every disease have a specific pattern. Even the IMs also, they have a specific pattern of involvement, and we can get a clue from there. So the changes may be different in infection, but most important is this one actually.
The most important thing is that it will explain you where the exact lesion is. Even if it is in the posterior fossa subdural hematomas are most of the cases missed. But if you have a suspicion that there was instrumental delivery, then go for a MRI. It will clinch the diagnosis and it will differentiate the diagnosis from HIE cases.
Yes.
So this is very important.
Particularly the vascular causes.
Particularly the
cerebral
vascular
venous
causes, cerebrovenous thrombosis, arterial ischemic stroke, or whether it is subdural hematoma, posterior fossa subdural hematoma.
Even other malformations like this, tuberous sclerosis.
If there is a history of intractable seizures, always go for doing a MRI, because in cases of intractable seizures, IEM and cerebral malformation. These two are the most common causes, and MRI will help you to catch the diagnosis. If the baby has a dysmorphic facies, has neonatal encephalopathy, then the MRI will tell you whether it is some genetic syndrome. And however, I would like to reiterate, if you are not finding any HI finding, then also it is going to tell you a diagnosis. This will tell you that the cause of encephalopathy is maternal drug exposure.
Yeah.
Most of the cases, lignocaine injection, accidental lignocaine injection in the fetal scalp, this is also a cause of neonatal encephalopathy. So you will not find an MRI picture, you will just get a
But there will be encephalopathy with a fixed dilated pupil, that is
exactly
clinching point.
dilated
means to
pupil,
diagnosis.
non-reacting pupil.
Yeah, Dr. Rishabh, so can you specifically tell, so which group of babies you want to send for genetic evaluation and what genetic test you want to send?
Yes, sir, definitely.
So these are all step 1, step 2 we have covered. Then we have to go for this step 3 and step 3, the genetic test. What
Yes,
you want to send?
Sir, first we should see which babies we want to send for genetic evaluation.
Yeah.
We need to suspect first. So suspecting is there are few indications like any baby having neonatal encephalopathy and not having history of perinatal asphyxia or HI. Any baby having dysmorphic features, having congenital anomalies, having multi-organ involvement, we need to send step-wise genetic evaluations like first step can be lactate, ammonia, glucose, and any baby with intractable seizure with high lactate, it can be Leigh syndrome.
No, that sir has already covered.
Yes,
so
sir.
for the genetic testing, as you told, we have to send for the babies where we are suspecting there is a dysmorphizing features are there.
Yes, sir.
So any other conditions where we can send genetic evaluation?
Yes, sir. Intractable seizures, any
Yeah.
baby having, we must
On a-
send genetic
You are not
testing.
able to get a diagnosis.
Yes,
or
like
you are
Dravet
suspecting
syndrome.
some cerebral syndrome, genetic syndromes.
Yes.
Then you can send it.
Yes,
So
sir.
what test you send? Whole exome sequencing.
Whole exome
Whole
sequencing and then genetic counseling at the last.
You have to do it. Okay. So, Dr. Syam sir, can you tell me in just in gist, because it's a very broad, management is a broad topic, just principles of management for a baby where you are suspecting neonatal encephalopathy. Just the principles I want to know.
In any case, first few things in the form of temperature should be maintained, ventilation should be looked for. If not maintaining, should be supported. Oxygenation should be normal oxia. Glucose should be within normal range, and blood pressure should be within normal area. So all these are the basics. Neonatal incompatibility, if due to HI, managed with therapeutic hypothermia, which is the standard of care along with intensive supportive care in neonatal and intensive care unit. Supportive care involves stabilizing cardiovascular function, treating seizures with medications, correcting metabolic derangements and electrolyte imbalances, and maintaining normal blood sugars. Cardiovascular support, seizure management, metabolic and electrolyte balance, blood pressure support, nutrition, importance of early and multifaceted care, timing is very important. Management is complex and requires constant monitoring and intervention of organ dysfunction. And in spite of these, long-term prognosis may be not very satisfactory even with proper treatment. So we have to be very vigilant. We have to be very careful
So
in
mostly,
each and every
if
step.
after delivery, if HI is the cause, then just go for whether it fits into the criteria for therapeutic hypothermia, and if it is available, then go for therapeutic hypothermia. If it is not available, then supportive care is the primary management and seizure control. And for seizure control, you need to know clinical detection of seizure is not that important. Even the electrographic seizures has to be treated for a better neurodevelopmental outcome. So, Dr. Rupesh, so how you feel, how EEG monitoring is essential for such babies?
So already you said, when I was PG student, we used to read classification like, clinical. Subtle seizure is the most common type of the seizure. But recently, 2021 or 22, that
21,
21, that ILE has, completely, whenever we want to diagnosing seizure, so we must have the EEG machine. So core component in the encephalopathic patient, again, we have the two type of this conventional and the AEG, because conventional we have put the, although AE is conventional,
conventional is the best
is
and
better.
as per the latest guidelines, the International League Against Epilepsy, they told neonatal seizures there are three classifications: possible seizures, probable seizures, and confirmed seizures. So confirmed seizures are only when it is proved by conventional EEG.
Yes.
Even amplitude integrated proven seizures or the tonic type of seizures are part of the probable sepsis, probable
seizure.
And what we are treating, it is clinical seizures or
Yes,
subtle
so
seizures,
that is
cycling
no-
movements, that is very low.
Yes.
So that is one. EEG is a must to know whether the baby is having seizures or not. And second also, what is the type of EEG? That is important.
Yes.
The low voltage EEG, pulse suppression pattern, then these are what? Prognostic significance.
So there's so many things, the when to implement as soon as we have to go for the seizure. Again, the CEEG, conventional EEG, the gold standard for the accuracy. Again, you have, because it's very difficult, different. But for the neonatology, so we have 5-6 pattern of the EEG. How much the voltage, how is the duration? Based on that, we have the picture. I have not put, because so we have, so EEG is the must. Take home message is the EEG must for the diagnosis of the seizure. If we are treating the clinical seizure, so the outcome will be low, and how many false positive cases we are treating and how many cases we are not treating, and that will lead to the poor outcome later on.
So Dr. Rishabh, so what's the role of anti-seizure medications? Do you want to treat or?
Yes, sir. Definitely, there is a role of anti-seizure medications in these kind of babies because it has got several advantages. Like we need to terminate the clinical as well as electrographic
for
seizures.
better outcome.
Just now what you said, and we need to reduce the seizure burden as well as it allows to do the neuroimaging as well as improve the supportive care which we want to give.
Which seizure medication you want to prefer?
Sir,
First
I
line,
would like,
second line. Do you
first
have
line
any?
I would like to go with phenobarbital and as well as levetiracetam is
So
one
there
of
are
the
a lot
agents.
of controversies and debates now. So still the gold standard is phenobarbital.
Phenobarbital.
And levetiracetam may be used as a second line drug because the literatures have got varying results for the seizure efficacy with levetiracetam. One group where EEG they have not taken as a criteria, they told seizure control efficacy is almost 80%. There was a published literature from the Indian study. But when they combined, so they told the levetiracetam efficacy is only 28% in another study.
Yes, sir.
So the standard what we follow is definitely first line is phenobarbital, then second line is levetiracetam, phenytoin as a third line, midazolam third line.
Yes.
Okay, good.
Thank you.
So what may be the long-term consequences, Dr. Vivek? Can you just rapidly tell us?
It is
Why
very
you are worried for these babies?
Because now we are saving more teeny babies, and this problem is going to be increased day by
Cerebral
day,
palsy, I know.
day by day. So we have so many problems in neonates, neurodevelopmental, cognitive problems, motor and neuromotor problem, sensory and epilepsy related problems, and behavior like ADHD or hyperactivity.
So most important is actually the epilepsy also.
Yes,
That is another. So these babies may have later onset of epilepsy, you may have, and for a long-term anti-seizure medications. Okay. So Dr. Saurabh, can you just tell me just in gist how you prognosticate such cases?
So this is very
Outcome.
important because most of the pediatricians, they give a negative image that this baby is going to be survive but with a disability. So first of all, we should know that the prognosis will depend heavily on the etiology. So etiology, clinching the etiology is important. Then do a detailed examination and everything you have in hand, clinical presentation and grading, neurological examination, neuroimaging, neonatal seizures, EEG, everything is there which will help you in prognosticating. But most important that the babies have a neuroplasticity. The neonates have a neuroplasticity which will allow them to curb any insult that has occurred to their brain. So the NICU outcome will heavily be reliant on the developmentally supportive care you give to the patient, the early stimulation and physiotherapy, and nutritional support that you give to the baby. So these are must. And regular neurodevelopmental follow-up and early intervention will make sure that the baby have a fruitful life. And family and peer group support is also required because these parents are very frustrated. So this is very important.
Yeah.
So coming back to...
So simply I can tell, suppose with encephalopathy, one neuron is got damaged, one neuronal cell is got damaged. That function is permanently lost. But if you go for a yearly intervention, then there will be lot of dendritic and axonic connections. So the area which is damaged, that function is being taken care of by another neuronal cell through the connections what will be developed when you go for a repeated physiotherapy or a yearly intervention. And the yearly intervention and the developmental supportive care should start in the NICU. These are very simple techniques. It's not very high tech or to be done by only the physiotherapists. The oromotor stimulation, everything you have to start from the beginning. At least then only you can help the baby to swallow breast milk or to get the tone for the hypotonia babies. And if you lose that time, probably lot of time is getting wasted. So most of the time, when early identification is at 6 months, but by the time you have actually lost these 6 months of time. So coming back to our case, I have got 3 slides more. Coming back to our case, what I have described, day 29 presented to us with difficulty swallowing. What we clinically suspected, it's a neonatal encephalopathy, porous sepsis, and maybe the localizing sign is in the brain stem. What investigation that we have done, Dr. Rupesh, sepsis screening we have done, it is negative, thyroid function was normal, CSF study was done, that was also normal, urea creatine normal, blood gas was normal, RBS, ketone body, everything was negative. So what I was discussing here regarding, sorry, this is not playing. So just to show that actually this happens, the baby was not swallowing, so somebody was asked for a upper GI endoscopy plus and it has done, but it was not needed actually for that group of babies. And the MRI has done, that has shown hypersensitivity with diffuse restriction. But when we suspected, we didn't get any diagnosis, then we sent a sample for the TMS, and in the TMS we got very high level of amino acids, leucine, valine, isoleucine, we got very high level, so, and we suspected maybe a maple syrup urine disease, and then it was confirmed by whole exome sequencing. Then we got the diagnosis, and we have put the baby on the special diet for the maple syrup urine disease, and stepwise. So initially we have given 25% EBM along with 75% MSUD, but believe me, the cost of this formula is so high, the parents were not able to afford. So we could follow this baby for up to 6 months. After that, he was lost to follow up, and suddenly I called the parents, what has happened, because I told them for genetic counseling so that we can at least save the next baby. But unfortunately, by that time, we lost the baby. So these are all the challenges. So finally, what I want to tell, so any baby with presenting with clinical features of neonatal encephalopathy, just 1 minute more. First thing, if it is presented within 6 hours of life, think the possibility whether there is a perinatal insult, there is a perinatal asphyxia, and whether there is an option of therapeutic hypothermia, because that is going to change the outcome of the baby. If there is no indication of therapeutic hypothermia, then detailedly evaluate. So which we can treat is sepsis, metabolic thing like hypoglycemia, hypoglycemia. These are the common thing. If it is not there, then stepwise approach. You go for that urine glucose, urine ketone bodies, ABG study to look for any whether you are suspecting IEM, look for dysphoric features. Then think of sending a TMS sample, genetic workup. In the meantime, MRI and ultrasound bedside if possible. So what is the last thing is the strategy for protecting the neonatal brain. There are a lot of antenatal, perinatal and postnatal, because nobody till now we are not able to explore the neonatal brain. What is there? It is a developing phase. So, but what is already proven is about the neuroplasticity. So if we do the early intervention early, probably then we can get a better outcome. So definitely we have discussed about antenatal corticosteroid, magnesium sulfate, delayed cord clamping that stabilizes the newborn's blood pressure, decreases the risk of IVS, kangaroo mother care, all caffeine in the premature babies, that can protect the neonatal brain. But another which is most important is the early intervention. So the take-home message, all cases of encephalopathy are not HI, careful history, investigation and neuroimaging will differentiate HI from non-HI cases, but just don't set a blanket investigation for each one. So just go a stepwise approach what Dr. Rupesh was telling, and prognosis is always dependent upon the underlying cause, and even if what may be the diagnosis, start early intervention early from the NICU stage so that we can have a better outcome for this newborn baby. Thank you so much for your present hearing.
So, thank you, Dr. Sahu, and the learned panelists, Dr. Saurabh, Dr. Shyam Bihari, Dr. Rishabh, Dr. Vivek Pandey, Dr. Rupesh Kumar. Now, only one thing, I think nobody has told, the incidences of neonatal encephalopathy. How incidences of neonatal encephalopathies in India, they are 20 per thousand. Kitna? 20 per thousand. That is one thing. Second, साहिर लुधियानवी की एक लाइन है, दुश्मन तुम अकेले नहीं, हम भी हैं. So HI is not the only cause of neonatal encephalopathy. There are so many other causes also, which have been described in detail, and it's a very good, it was a superb presentation and superb this subject to be discussed. So, over to my Dr. Sivajan Singh.
Thank you, sir. Thank you, all the panelists and moderator. So one thing I want to ask one question. In HI incompletely or non-HI, after seizure control in the NICU, and after discharge, how long to continue this phenobarbital? Is there any protocol?
Sir, there is a protocol. So, in most of the cases, if the neurological examination is normal at the time of discharge, we discontinue the anti-seizure medication. However, if the neurological examination is not normal at the time of discharge, we keep the baby in follow-up. We do an EEG. EEG will show you whether the seizures are going on. So, why we want to stop the anti-epileptic drugs now is they had seen that whether epilepsy happens in cases of all neonatal seizures. So they found that no, the risk of epilepsy in cases where anti-epileptics were stopped early or whether it was continued, the cases were same. The chances of epilepsy was same. So we stop the anti-epileptic drugs as early as possible because many of these medications will lead to depression of the baby, and the baby will have many challenges in early intervention, in physiotherapy. So we want to stop these medications.
Thank you, Dr. Saurabh. So I think time is short, so no question. We close the session here. Thank you.
There are so many sessions after lunch to be covered. So thank you so much.
Thank you all the panelists.
जो लोग खाना नहीं खाए हैं, हम लोग चलते हैं for the lunch.
There is announcement. There is no lunch break because we are running behind the time. So moving on next, we have a session by Dr. Sandeep Jhajra. Dr. Sandeep is here. And for chairing that session, we have Dr. Avinash Sahai, Dr. Vibhas Ranjan, Dr. Silpi Golwara ma'am, Dr. Kranti, and Dr. Manoj Kumar. Silpi ma'am, Dr. Kranti, Dr. Manoj. Avinash Sahai sir and Vibhas Ranjan is there.
A very good afternoon to one and all present here. I take this opportunity to thank the organizers for giving me this opportunity. So moving on to the next session, The topic is role of nebulized surfactant in RDS, whether it is still experimental or it is just a false hope. So to present this, I invite Dr. Sandeep Jhajra. He is consultant in charge in ICU, associate professor, Manipal Tata Medical College, and he is MD and FNNF and DM neonatology, and his areas of interest is non-invasive ventilation, POCUS and ELBW. And he has many publications under her cap. So I would like to invite Dr. Sandeep to start his presentation.
Thank you, ma'am. First of all, I take this opportunity to thank the organizer for inviting me to such a prestigious event. Now, my topic is nebulized surfactant in RDS. The surfactant, we all know, is a wonder drug for the management of respiratory distress syndrome in preterm neonates. As far as the recommendation is concerned, the surfactant can be given in any preterm neonate with respiratory distress syndrome with requirement of FiO2 more than 30% on any non-invasive or invasive ventilation. Two types of surfactant we all know, one is natural and another one is synthetic. The natural one is Surventa, Neosurf and Curosurf. And there are three generations, first generation, second generation and third generation synthetic surfactant are there. Surfactant administration leads to the reduction of surface tension, improvement in lung compliance, it decreases the work of breathing, and it leads to the prevention of alveolar collapse at end expiration. All of these functions ultimately leads to decrease in the incidence of neonatal mortality and morbidity. Now, there are three modes of administration. First, we all know using in our institutes like Inshore and Rexshore. Another method is LISA, and the third one which we are going to discuss is nebulized surfactant. Inshore, as described by the Werder et al., involve intubation, giving surfactant, and then extubate the baby on non-invasive mode of ventilation, whether it is CPAP or NIPPV, within 1 hour after establishment of satisfactory respiratory efforts. But for Inshore, we have to intubate the child, and it requires expertise, and the failure rate to intubate in first attempt for Inshore is as high as 70%, and it is associated with various adverse effects like oral or airway bleeding, pneumothorax, esophageal intubation, and hypotension. So the most common method of surfactant administration, that is Inshore, is associated with various side effects. The next method, the recent one used by various institutes in our country, is LISA, which is administration of surfactant using a thin catheter. This method also has its own side effects like coughing, gagging, desaturation, bradycardia, and surfactant reflux. Now comes the nebulized surfactant. Initially, in the year like 2018 to 2022, various institutes started pilot studies giving nebulized surfactant. Then WHO came with the recommendations. What are the eligibility criteria for the neonate to receive the nebulized surfactant? First of all, who are not responding to non-invasive respiratory support, and those whose birth weight is more than 1 kg or gestation more than 28 weeks of gestation with RDS. You cannot give nebulized surfactant below 1 kg or below less than 28 weeks of gestation. Type of surfactant, we can use both synthetic as well as animal derived. The aerolized surfactant should preferably need only 1 dose for maximum effect. Could be administered up to 48 to 72 hours after birth, and maximum effect should be at least equivalent to with the current surfactant preparation. The minimum requirement is that 3 doses of fuel would be needed for maximum effect, and that administration could be started up to 12 hours after birth. Clinical impact, as far as recommendation is concerned, a measurable clinical improvement, that is improved oxygenation, reduced oxygen requirement, reduced breathing rate, should be apparent within 15 minutes of treatment completion. Minimum requirement is an improvement at least within 60 minutes, and maximum benefit should be achieved within 2 hours of treatment completion. and it can be up to 6 hours. So recommendations were given, but the question which was still unanswered, like for giving the nebulized surfactant, you need a nebulizer. Different type of studies use 3 type of nebulizer. One is jet nebulizer, then the recent one which we are using, vibrating membrane mesh nebulizer. Type of dilution which we have to use to generate the aerosolized nebulized surfactant. Different studies, somebody in one study they have used 1:1 dilution with normal saline, in another one they have used 1:2 dilution. Dose of surfactant, different studies, some studies have used 100 mg per kg, another one has used 200 mg per kg. And type of interface which we have to use. Advantages of nebulized surfactant. For nebulized surfactant, intubation is not required, catheter insertion is not required. So all the side effects associated with the INSURE or the LEASE are bypassed. No technical expertise or sedation is required. We can give nebulized surfactant while baby is on the non-invasive respiratory support. Now the problem during the administration. As far as the studies are concerned in the piglets, it has been shown that when we give the surfactant using the nebulized technique, the amount which reached at the piglet lung was only around 11 to 45%. So the dose which we have to use is the double the dose which we use in the INSURE method or LEASE method. In my institute, there is an RCT going on in which we are using 200 mg per kg dose of Surventa Neocon. Another problem is that after the dilution, we are using 1:1 dilution. Even a 5 ml per kg dose roughly require around 20 to 40 minutes for the administration. So if you are giving the nebulized dose of surfactant to a 1.5 or 1.6 kg baby, it will require around 2 hours. And during that time, a nurse has to keep the head in the midline position to prevent the leak from the mask or the prongs and to suction the secretion which are dribbling from the mouth or the nose during the procedure. These are the various studies. One was done by the Cumming et al. In the 2020, which shows the 50% reduction in the CPAP failure rate in the nebulized surfactant group. Another by the Sood et al., then Dani et al. Meta-analysis by the Gardner et al. In the 2021, which will involve all these studies, and around 1,095 neonates shows that the nebulized surfactant reduced the intubation, but there was no effect on the mortality or the morbidity. But the quality of evidence was low due to the bias. The type of surfactant which was used in all these studies were different in different studies. Some have used face mask, another one has used nasal prongs. Failure criteria were all different in these studies. At present, this is the Neo-Inspire trial. This trial is still undergoing. It is a multi-center trial in South Africa with the enrollment criteria from 900 gram to 2 kg. Gestation is from 27 weeks to 34 weeks of gestation. This trial is using synthetic surfactant, and mostly all the problems which I have just shown you people are going to be answered after this trial. This is the video I have introduced from my institute. We are using the erogen nebulizer. We are using the surfactant along with the 1:1 dilution. You can see the fine fumes which are being generated by the nebulizer. We have to keep the head in the midline, but there is a frothing from the mouth of this baby. That's the problem with the leakage of the surfactant during the administration using the surfactant technology. Thank you.
Thank you. It was a very nice and promising topics, which is the future of treatment of mild to moderate RDS. If we succeed in the nebulizer surfactant therapy, it will be the great help in the NICU where the intubation facility is not available, or sometimes we are avoiding is due to the complications of barotrauma and other lung injuries. Thank you.
as you said that you are doing RCT in your institute on this nebulization.
Yes, sir.
So do you face any problem commonly during this process?
Sir, problem is the duration of the procedure. In INSURE, you hardly require 5 to 10 minutes, as well in the LISA method, sir. But for the nebulized surfactant, we require around 30 minutes to 45 minutes, sir. We have to do the regular suction of the amount due to the leakage. And another one is that, sir, we are unsure about the deposition in the lungs. That's why we are using double the dose, sir. The cost that is increasing for the patient, sir.
This suction is not the best. Is it not the wastage of this?
That is, sir, but
surfactant?
there are the multiple side effects like bradycardia, pneumothorax, airway injuries, sir. There is some problem, obviously, with this method, sir. But with the improvement in the nebulization technique in the coming years, sir, might be we will be generate the we will be able to give the better doses to the neonatal lungs, sir.
Thank you.
Thank you.
Thank you so much. I think it's a promising approach, and if it works out as in the trials, still trials are going on, then it would be a major milestone in managing RDS babies.
Thank you.
Thank you so much.
Thank you, Dr. Sandeep, for finishing before time. I really appreciate from the organizing team. Thank you, sir. And big clap for the... Next we have, I will request all the chairperson speakers and Bhavesh sir to please. Moving on next, we have next debate, debate. हम फिर से लड़ेंगे और for therapeutic hypothermia in India, yes and no, on Dr. Narmata and Dr. Richi Dalai. I will request both to come on the stage. And इस लड़ाई को बहुत करीब से देखने के लिए डॉक्टर राकेश सर PMCH एज ए चेयरपर्सन, डॉक्टर ऋषिकेश, डॉक्टर रीना, डॉक्टर अखिलेश NMCH, डॉक्टर पुनीता मैम, डॉक्टर पुनीता, first I will Dr. Namrata first.
A very good afternoon, everybody. I am going to present my debate in favor of therapeutic hypothermia in India. A vital evidence-based intervention for neonatal encephalopathy. Coming to burden of HIE in India. HIE is the leading cause of neonatal brain injury and neonatal morbidity like cerebral palsy, intellectual disability and seizures. Incidence is 1 to 2 per 1,000 live births in developed countries, but the incidence is much higher in developing world, around 20 times higher in developing world. Brain injury secondary to hypoxia ischemia during labor has been noted in up to 14.5% of term neonates with CP. This is the diagram depicting the pathophysiology of hypoxic ischemic encephalopathy. With hypoxia ischemia, there is perfusion deficit leading to depletion of ATP, resulting in failure of cell membrane ion function, leading to accumulation of sodium and chloride and intracellular water, leading to cytotoxic edema, which promotes necrosis of the brain cells. This is evident within 6 hours. After 6 hours, there is secondary energy failure due to release of excitatory amino acids like glutamate, which excites the NMDA receptors, leading to accumulation of intracellular calcium, which activates lipases, endonucleases and phospholipase C, leading to apoptosis of the cells. So therapeutic hypothermia is to be started within this therapeutic window within 6 hours, because after 6 hours there is secondary energy failure which must not initiate before the institution of therapeutic hypothermia. This is a diagram showing the phases of hypoxic ischemic encephalopathy. The phase 1 is the initial 0 to 6 hours and the phase 2 is the 6 to 48 hours and the phase 3 is the consequences after 48 hours, that is increased inflammation and there is epigenomic changes also, which leads to irreversible injury. Now coming to therapeutic hypothermia. Modes of action of therapeutic hypothermia, this slide demonstrates. It leads to decreased energy consumption because of decrease in the basal metabolic rate, decreased accumulation of extracellular glutamate, which is the major excitotoxic amino acid, decreased generation of reactive oxygen and nitrogen, inhibits inflammation, inhibition of platelet activating factor inflammatory cascade, suppression of free radical activity, attenuation of secondary energy failure, which is very important. Before the initiation, we should institute an inhibition of apoptosis. This slide is showing the eligibility criteria for therapeutic hypothermia. Everyone is enamored with this. Coming to the devices. There are two types of devices, servo-control devices which are costly and are usually used in developed world, and the phase-changing devices, which is an Indian innovation. This is a low-cost device, and WHO has recommended its use in resource-limited settings. Now, monitoring on therapeutic hypothermia. This is very important. Whatever babies we have recruited for therapeutic hypothermia, they must be monitored in a tertiary care center with all the advanced abilities like cardiorespiratory monitoring, monitoring of fluid balance, hematological monitoring because therapeutic hypothermia will result in thrombocytopenia, skin monitoring because it may result in fat necrosis, and neurological monitoring. Now, my debate is in favor of this. And so, in favor, global evidence is currently, it is an established global standard of care. Therapeutic hypothermia is the standard of care for moderate to severe HI in high-income countries, backed by numerous large RCTs and Cochrane reviews. Now, RCTs showing definite benefit are NICHD trial, that is National Institute of Child and Health and Human Development trial conducted in 2005, Cool Cap trial conducted in 2009, TOBY trial in 2011, and ICE trial in 2012. Coming to the Cochrane review, which is the basis of the recommendation of therapeutic hypothermia in developed world. This review was conducted in 2013, and it has reviewed 11 RCTs. Therapeutic hypothermia decreases the combined outcome of death or major neurodevelopmental disability at 18 months of age with risk ratio of 0.75 and number needed to treat of 7. Decreased mortality with therapeutic hypothermia with relative risk of 0.75 and number needed to treat of 11, and decreases neurodevelopmental disability in surviving infants 26% versus 39% with number needed to treat 8. Now coming to this topic, why studies in India were necessary? Before its adoption in India, therapeutic hypothermia was already a standard of care in high-income countries based on large trials. However, crucial questions remained for its application in the Indian context because there are different patient population in developing world. The incidence of sentinel events like abruptio placenta, uterine rupture are more as compared to developing world, and there is later presentation also. In India, even in this 2025 also, home deliveries are quite common as compared to developed world. So the babies are coming to the facilities mostly after the therapeutic window of 6 hours. And there are resource limitations and safety concerns are important. Coming to key studies in favor of therapeutic hypothermia in India. Whole body hypothermia for neonatal encephalopathy was a pilot study which was first done in 2009 in the Sir Gangaram Hospital, New Delhi. This study demonstrated that therapeutic hypothermia is feasible and safe in an Indian tertiary care setting. Second study is cooling in a resource-restricted environment, a feasibility study from India. And the third study is infant cooling evaluation trial, that is ICE trial. There is whole body hypothermia for neonatal encephalopathy in low and middle income countries, a randomized control trial from India. Now coming to the controversy. I have already discussed all the trials are in favor of therapeutic hypothermia. But the controversy is the HELIX trial, which was conducted, the result was published in 2021. The HELIX trial, that is whole body hypothermia for the treatment of neonatal encephalopathy in low and middle income countries, RCT, was conducted to define whether therapeutic hypothermia is an effective treatment for newborns with birth asphyxia in resource limited settings like India. The trial was conducted at multiple tertiary care centers across India, Bangladesh and Sri Lanka. The critical findings, the results of the HELIX trial published in the New England Journal of Medicine in 2021, the primary result at 18 months, the primary outcome, that is death or severe disability, occurred in 52% of the hypothermia group versus 47% of the control group. and the rate of death alone was significantly higher in the hypothermia group compared to the control group. But the controversy is there because the key reasons regarding the controversies are, it is contradictory the local evidence. All trials which were conducted before were in favor, while it was against, and there were methodological concerns also, and there was exclusion of experienced centers from India, like some centers who are performing good, who were included in previous trials also, were not included in this trial, resulting in biasing of the results. Now coming to innovation and adaptation for India. In India, low-cost cooling devices like Mira Cradle using phase-changing material is a prime example of indigenous innovation. Coming to conclusion, HIE places a significant burden on Indian families and the healthcare system. Therapeutic hypothermia is a proven life-saving and brain-saving therapy. Robust evidence from Indian RCT confirms its benefits. The HELIX trial, while important, do not invalidate the successful experience of many Indian centers. With indigenous innovations and commitment to standardized care, therapeutic hypothermia is essential therapy for Indian newborns. Thank you.
Thank you, Namrata, for explaining the pros of the therapeutic hypothermia so well. And for cons, I will be inviting Dr. Richi Dalai, who is faculty at AIIMS Patna.
Thank you, sir. And thank you for my colleague for telling us regarding the uses of therapeutic hypothermia. So after having heard that, I'll let you know why we are having this debate at all and why is this topic so controversial, especially in low middle income countries like India. So as you know that, as we have already discussed, that there are multiple trials that have already been done, especially the trials in high income countries, have shown that there is a definite benefit of therapeutic hypothermia when given for moderate to severe HIE. However, the main question is, can the results of these trials in high income countries be extrapolated to the LMICs? The answer is no, because the population that we have is heterogeneous. There are pertinent issues regarding antenatal care, inadequate resuscitative measures, availability of personnel in remote areas. There are many resource constraints, especially neonatal transportation, inadequate nurse to patient ratio. And because of all these reasons, there is more chances of a poor outcome even if one uses therapeutic hypothermia, especially for the outborn neonates, because here the admission temperature in these babies is sometimes suboptimal, and that itself increases the morbidity and mortality. Now, my colleague told us about many studies that favored therapeutic hypothermia in LMICs, but let me tell you that these 15 randomized trials were actually of poor quality and were very small studies. These, as you can see from this forest plot, that the event rates were very less in all these studies which were done prior to the HELIX trial. So came the HELIX trial, which was a multi-center randomized controlled trial in various centers in India, Sri Lanka and Bangladesh. Now these 7 centers in these 3 countries were equipped with assisted ventilation, had cardiovascular monitoring, had proper nurse to baby ratio, had 2-tier system of resident doctors and consultants, and had additional help in the form of neonatal nurses. And they admitted both inborns and outborns. So it is wrong to say that these centers were not well equipped. And what they included were a late preterm neonates and term neonates above 1.8 kg birth weight within 6 hours of birth, and those who required continuous resuscitation at 5 minutes and had ABGAs of less than 6 at 5 minutes or did not cry by 5 minutes. They excluded major life-threatening congenital malformations and those who did not have a heart rate beyond 10 minutes. And their primary outcome was death or disability at 18 to 22 months of age. They used Tecotherm at 33.5 degrees Celsius for 72 hours. And what they found was rather a shock for all of us, because we were earlier very much pro for therapeutic hypothermia, but this trial actually made us rethink the situation. What we found was there was no difference in death or disability in the therapeutic hypothermia versus the no hypothermia group. And in fact, what they found was there was an increase in death by almost 35% in the hypothermia group. And in fact, the survivors had increase in disabling CP. Also, there were many secondary outcomes that were analyzed, and they found that there was increase in gastric bleeding, hypotension, pulmonary hemorrhage, coagulopathy, arrhythmia, thrombocytopenia, acidosis, length of hospital stay in days, and death before discharge in the hypothermia group compared to the control group. They did a subgroup analysis, but irrespective of that, they found that hypothermia was uniformly ineffective at all sites. Now, what they found was majority of the babies in this multicentric trial, which had around 400 babies enrolled, they had subacute or partial prolonged hypoxia. And only 13% had any acute sentinel events documented compared to the Western trials where around 60% of the babies had an acute sentinel event. And the quality of antepartum care, like we already discussed, was questionable. So, again, we must ask ourselves the question whether therapeutic hypothermia should be given in all babies with moderate to severe HIE or not. And in order to answer that, we have a systematic review meta-analysis published this year, including the HELIX trial, which shows that comparing both the groups, the primary outcome of death or neurodevelopmental impairment at 18 to 24 months, it actually doesn't show us clearly whether therapeutic hypothermia should be used or not. So they have written that benefit or harm could not be excluded. The same is for death, but for NDI there is a low certainty of evidence for benefit, but the combined outcome of NDI or death, that is what we are concerned about. We cannot rule out harm. Now, till we have a good system for antenatal care, a good proper system for neonatal transportation, which ensures that our outborn baby reaches with a temperature of above 36 degrees Celsius, we really cannot say that therapeutic hypothermia is going to save the baby. So, saying that yes to therapeutic hypothermia is not that simple. Thank you.
Thank you, Dr. Ricci, for explaining the cons so well. So I think after your presentation, most of the audience is confused whether we should go for this thing, this technology or not. As far as I could understand, I think that if we adopt this technology in a state-of-art setup with proper monitoring and all the equipments for monitoring core temperature and vitals properly, with all trained staff available, we can have some advantage as far as care of moderate to severe HI is concerned, mild to moderate HI is concerned. But after going through so many trials, you gave example of HELIX trial, which is having all these prerequisite as have been conducted in very well equipped centers with proper monitoring and trained staffs, and that study is not showing any advantage. Rather, the study is showing some disadvantage in those babies who are undergoing this therapeutic hypothermia. So, if you two together opine, can we have
Actually, the eligibility, first of all, we should recruit the babies on the basis of whether they are eligible or not. First of all, the procurement time of birth. Some centers are opting for therapeutic hypothermia after 6 hours. That is very wrong. And the temperature from where the baby is brought up, as Dr. Ricci has told, the temperature should be more than 36 on receival. We should not recruit the babies with hypothermia on receival and later on they will recruit it on therapeutic hypothermia. And all others, like where the moribund babies, like already she has told that if there is no heart rate after 10 minutes, or if like babies, severe HI babies, like in which there is chances of survival are very less, or the severity is very, baby is not in a well situation, severity is more, then we can exclude those babies and we should recruit, and as you told, the trained staff and the continuous monitoring, availability is very important. We should not include therapeutic hypothermia in such settings where this is not available. Then we will do more harm than the benefit.
agree with my colleague on this, Dr. Namrata's opinion. And as she rightly said, that as the NNF in 2021 gave a position statement giving a stricter criteria for therapeutic hypothermia, they said that it should be used only for more than equal to 36 weekers within 6 hours of life, and having a admission temperature of above 36 till 37.4 degrees, and जिनमें कि आपका कॉर्ड pH is less than 7 or base deficit is more than -16, and जिनमें requirement of resuscitation of PPV is till 10 minutes. And also it's very important that there should be evidence of moderate to severe HIE in order to give therapeutic hypothermia in them. And जैसे सर आपने बताया कि in a center which is actually well equipped to take care of the baby before, during and after therapeutic hypothermia, because during weaning from therapeutic hypothermia also we face many complications. So if a center is well equipped in that to provide support to the baby, only then it should be considered.
Thank you. So I could conclude that the center should be very well equipped, and the eligible babies should fulfill the criteria. They should be in mild to moderate category without any comorbid conditions or sepsis like that. Thank you, the two speakers for explaining the things so well.
Thank you both the all the chairpersons and the faculty. I will request you all to please come for the memento distribution. I think हमारे साथ from the organizing team, some prize should be there for the debate that we missed. Moving on next, we have another session by Dr. Kanu Charan. I will request Dr. Kanu Charan. Photographer who NP Deepak sir, Ruchi ma'am, Reena ma'am, please come on the dais.
Good afternoon, everyone. So the speaker is Dr. Kanu Charan Digal, HOD and Senior Consultant, Utkal Hospital, Bhubaneswar. He has done his DM in neonatology, and area of interest are non-invasive ventilation, neuroprotection, FN echo, and publications are 7 indexed publications and 2 book chapters.
Thank you, sir, for your kind information. So good afternoon to all. So first I would like to express my gratitude to the organizing team for inviting me. And today I will be speaking on a very important topic of preterm care, that is preterm pain management through sensory stimulation. But the sad part is it is often the most neglected part in most of the NICU. So I will be going through the definition and pathophysiology of pain and how pain affects the developing brain in the different sensory stimulation methods and the recent evidences and how we can implement in our NICU. That is the most important part. So what is pain? As per International Association for Study of Pain, it's defined as it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. So when we give some pain to the baby, like any thermal pain or chemical pain or physical pain, what happens? there is plenty of nociceptors in preterm. So if we see, the amount of nociceptors are more in case of preterm as compared to term baby. So it's densely packed. So they are stimulated, and the nociceptive stimuli is converted to the electrical signal as neuronal axonal potential and carried through the fibers like C fibers and A delta fibers, and they reach to the dorsal horn of the spinal cord. There, through the second order neuron, they transmit to the medulla, to the thalamus, and then to the cerebral cortex via the thalamocortical fibers. And in cerebral cortex, as it is disorganized, so the pain is perceived in very deep manner. The pain is highly perceived, and it manifests as increase in heart rate, decrease in saturation, and if we do the NIRS, there will be increase in oxygenated tissue, hemoglobin oxygenation, and there will be baby will cry, there will be so much vital impairment, and the blood pressure will also fall. So the important part is, in preterm infants, there are two, why the pain is more perceived in preterm, because first thing, due to more number of densely packed nociceptors. Second thing is like the descending inhibitory pathways, like the inhibitory neurotransmitters like endorphin, dopamine, norepinephrine, those are less, and the inhibitory pathway is also less developed. That's why pain is more felt. So this is the same thing, first occur transduction, then transmission through the secondary neurons, then perception in the cerebral cortex due to less modulation. So pain modulation is not there due to inhibitory pathways underdeveloped, and the gate closure mechanism is not well developed. So I have already explained this slide why the preterm experience more pain. So what happens when a pain preterm is undergone prolonged or repeated pain? So immediately there will be vital changes. I have already told, baby will cry, baby will have some facial expression changes, and later on there is increased risk of altered brain development. So the cerebral cortical thickness might reduce. There will be loss of volume of both gray and white matters, and there might be chances of cognitive impairment, attention deficit, learning disability, and due to the altered cerebral development, there may be emotional dysregulation as well. And as the inhibitory pathway is less developed and more number of nociceptors are present in preterm, for that reason, even if a simple non-pain stimuli can also cause pain. That is called motor delay, and there is risk of chronic pain syndrome as well. So what are the physiological signs of pain? So increased heart rate and increase in BP, there may be tachypnea, decreased oxygen saturation, facial grimacing, crying like in facial features, the eyeballs, and there is balls between the brows as well, and so broadened nose, bulging, and nasolabial fold may be depend. So there are, so how will you assess pain? So pain assessment is more important, and there should be awareness in every NICU, especially we should teach to our NICU staffs, because they are the person who are handling the babies more frequently. So we should teach them that babies previously, like in late 20th century, there is concept that due to less development of pain pathways in preterm baby, they perceive less pain. Even if they perceive pain, that is not prolonged and that doesn't affect the brain development. But later on, due to so many studies came, we knew that the pain in preterm is more perceived, and it is more as compared to term babies. So there are different types of pain scales like PEEP and revised PEEP in preterms, NIPS scale, NFCS, plaque, cries. So, but in case of preterm babies, mainly we use the PIPP or premature infant pain profile score, or that is recently revised in 2014. So we usually use that revised PIP. So what is the difference between PIPP scale and PIPP revised scale? In PIPP, it was little bit more complex, because if you see the oxygen saturation, the decrease in oxygen saturation was divided in like 0 to 2.4% decrease, 2.5 to 4.9% decrease, which cannot be seen in case of a pulse oximeter, because that is very cumbersome. So revised PIP, there is 0.2%, 3 to 5%, 6 to 8%. How much oxygen saturation is decreased? So it's clear cut mentioned. And in case of facial expression changes also, like there is percent of time, like in 30 seconds block, how many percent time the baby has facial expression changes. So that is also difficult to interpret. So it was make a little bit simpler, like for how long, it's less than 3 seconds or less than 3 to 10 seconds or 11 to 20 seconds or more than 20 seconds, like that. And baseline behavior scale state also, it was simplified, like only 4, 0, 1, 2, 3, like active and awake sleep for 1, quiet and awake, 0, active and awake, 0, 1, calm the baby and decrease the pain perceiveness. So first one, the most important is kangaroo care. So in kangaroo care, there are 3-4 senses are available. Like first is skin to skin contact, that is tactile stimulation. Another thing, there will be, baby will smell the mother's skin, body. So that is, there will be also olfactory sensation. And all these things will lead to decrease pain in the baby. So how it acts? It activates the sensory pathways that compete with nociceptive signals. So there is a pain gate theory. So that touch and temperature, proprioceptions, all these things, they will activate the A beta fibers, which is a large myelinated fibers, that will close the gate. So the pain signals will not be going to the dorsal horn of the thalamus, hence it cannot go to the cerebral cortex. So KMC regulates baby's physiological response, like decreases heart rate, it stabilizes the breathing pattern, it improves the temperature as well. So it can be studies shows, many other studies show, it can be effective in mild to moderate pain like heel pricks, venipuncture and immunization and some intramuscular injections. So this is a study like comparative efficacy of non-pharmacological intervention involving parent on pain during invasive procedure among preterm babies. So this is basically a systematic review and network meta-analysis. So what they conclude is like, while KMC appears to be the most effective non-pharmacological intervention to reduce pain in preterm babies compared to standard care, so there is requirement of high quality studies. More number of RCTs are required. So another study, so this is also a meta-analysis by Hani Sharma in 2024. So they conclude that kangaroo mother care seems to be an effective intervention in alleviating the procedural pain due to routine procedures or medical examination. So these are also two evidence, I will not go into the details. So another is non-nutritive sucking. So what is non-nutritive sucking? It's basically if we will make the baby suck in an empty breast or with some gloved fingers or baby's own finger. So that is called non-nutritive sucking. So that will also give some sensory relief to the baby. It will soothe the baby, and due to this oral sensory stimulation, it will distract the neonate from pain and engage brain pathways that modulate pain perception, and it also releases endorphin that decreases the pain. So there is a study, systematic review regarding non-nutritive sucking with oral sucrose. So it shows the combined effect of non-nutritive sucking and oral sucrose might be superior to the single intervention method. So if we will only give non-nutritive sucking or breastfeeding, so that is not sufficient. So combined methods like non-nutritive sucking along with some sucrose, like it may be 20 to 30% glucose or 24% sucrose, that will be more effective. Another method is swaddling. So swaddling is nothing but just to wrap the baby with, tightly so that baby will feel comfortable. And facilitated talk. In facilitated talk, what do? We just hold the baby with firm hand, one hand with over the head, another hand to hold both the hands and with the leg flexed. So that will calm the baby as well. So that is also tactile stimulation. So this is the study showing, it's a systematic review. Here they conclude that facilitated containment proves to be an effective method to reduce pain in preterm infants with additional benefits in physiological parameters, crying duration, and sleep patterns. So another thing, like only sucrose or dextrose. So if we use sucrose, we should use the 24% sucrose, which is available in market, and or we can also use 25% dextrose. Like in case of study, they use 20 to 30%. So 25% is almost similar. And in many studies, it shows that 25% dextrose is as effective as 24% sucrose and easily available also. So what it does, it just the sweet sensation, it releases the opioids in the brain. So that decreases and modulates neonates' pain response. So it's particularly effective for short procedures like venipuncture or cannulation or like heel prick. So, and the effects last for 5 to 10 minutes. The dose is 0.1 to 2 ml. So it varies basically. So on an average we give 0.5 ml of 24% dextrose before 1 to 2 minutes of the procedure. So as I have already told, like 25% dextrose also can be used in the same dose. But there are some concerns regarding like 25% dextrose or 24% dextrose cause feed intolerance and NEC, and overdoses can cause some neurodevelopmental impairment. Previously there are some concern, but many studies prove that it's effective, and even they have studies like next study, they have studied few around 118 neonates were assessed at 18 months through Bailey 3 scale, and they have found like cumulative sucrose exposure for repeated procedural pain in preterm neonates was neither associated with a delay in neurodevelopmental development or neuroprotective effects at 18 months of corrected age. So any dose can be given, but the consensus is try to give as less as possible, because more dose can associated with neurodevelopmental impairment. So and they have also told like many RCTs are also required for the final comment. So try to use less amount of sucrose and use it along with some other non-pharmacological method, other sensory methods like kangaroo mother care, non-nutritive sucking, all these things. So now the very important thing like breastfeeding. As we know, there are numerous benefits of breastfeeding. It decreases the mortalities and morbidity, but it also effective for pain management. Okay, so it stimulates the endogenous opioids and oxytocin in the brain and called analgesic effect. So Cochrane also proved that its benefits in preterm pain. And what is multisensory stimulation? Multisensory stimulation is nothing but if we will combine at least 2 or more sensory stimuli, including slight like sight, vision, hearing, smell, touch and taste, that acts better than individual sensory stimuli. So KMC is a form of multisensory stimulation. Another thing is sensorial saturation, where like mother is talking to the baby, non-nutritive sucking is going on, and we are giving some sucrose for the taste. So this also decreases the pain, it calms the baby, improves the heart rate, breathing pattern during procedural short procedures. So this is also study proved like multisensory stimulation is effective in controlling pain. And multiple RCTs and systemic reviews demonstrate the efficacy of sensory stimulation reducing procedural pain in preterm infants. And there is no significant adverse effect. If you compare the pharmacological like opioids, they have lot more side effects causing feed intolerance, like the baby may not pass stool. Okay, so ileus will be there. So those effects can be cut short with your sensory methods. And there is consistent, it's evidence based. It's not only theoretical, there is evidence based also. So now how to implement all these things in NICU? Every NICU should develop standard protocols and use validated pain scales. Every time while we are giving some pain to the baby, doing some procedures, we need to see you need to apply, especially in preterm babies, the PEEP or revised PEEP scales, and all the staff should be trained in all these pain scales, and they should be made aware that pain in preterm can cause neurodevelopmental impairment. So this is a part of developmental supportive care in all NICU, and to regulate whether the things are like the nurses are doing these things or not, we should have a regular audit and feedback for that. So now take home message is like sensory stimulation is very safe, it's effective and humane in nature, supported by robust evidence, and it should be integral to every NICU protocol because it improves the neurodevelopmental impairment. Thank you so much. If any questions, I would like.
Thank you, Dr. Kanu, for the very illustrative pain management, and it was a very nice discussion. Any question from the audience?
Actually, sir, studies shows 20 to 30% is effective, 10% not effective, sir. Sorry, sir? 20 to 30%. So 25% is as effective as 24% cruise. Yeah, 25% dextrose is easily available.
So I would like to ask one question to sir. Is there any role of family participatory care in pain management in neonates?
Yeah.
So this is one topic I think should be included.
Yeah, I mean, especially the mother and father should always be involved in pain management. They should be counseled during procedures, like I have already told, like KMC is a integral part of sensory stimulation for pain management. Like during KMC, multisensory stimulation is there, like smell, touch, and that like vision. So multisensory stimulation is always better than a single sensory stimulation. So family participation is important. If mother is not available, father can also do the KMC. During all procedures, they should be encouraged to stay with the baby. But what happened, most of the NICU during procedure, our staffs told, like if they are doing cannulation, they are told, आप लोग बाहर चले जाइए नहीं तो बार बार पीक हो जाएगा, आप खून देख के डर जाओगे वगैरह वगैरह. But that should not be encouraged. Parents should be there during all procedures.
This is how we prepare the parents for maintaining the continuum of care.
Yes. Okay, thank you.
Thank you, sir. Thank you all the chairpersons. I will request you all to please come for the memento distribution. I will request Shravan sir. Shravan sir, please assist in the memento distribution. Photographer, please here. I will also request Krishna sir and SPP Singh sir to please assist. Sir. Sir. Moving on next, we have another session by Dr. Dinesh Tomar sir. I will request Dr. Dinesh Tomar sir to please come on the dais. And for chairing that session, I will call Dr. Mohan Kejriwal sir, Dr. Akhilesh Kumar, Dr. S.P. Jha sir, Dr. S.P. Jha sir, Dr. Vijay Sinha sir, and Dr. Rohit. Sir. Dr. Vijay Sinha sir and Dr. Rohit.
With the permission of chair, should I start the session, sir?
Hello, good evening, everybody. We have a very erudite speaker, Dr. Dinesh Tomar. He has been the Vice President of NNF. He has worked in Astha Hospital, Rohtak. He has MBBS, MD, FIAP, and his area of interest is neonatology and general pediatrics. His major achievements are he is Secretary NNF 21-22, and he has 7 publications to his credit. I hope we all will enjoy the session during this post-lunch. Thank you.
Thank you, sir. The topic that is allotted to me is the use of systemic steroids for BPD prevention. How and when? Now, if you would have discussed this topic, say 2 decades back, it was not relevant for India because we were still at that time fighting for the survival of the newborns. But now, as more and more centers of excellence are coming up, we have more and more smaller gestation babies surviving, and BPD is gradually becoming a bigger problem. So we are trying to find out ways how to tackle this problem of BPD, because we are losing very small neonates now to BPD. So we are using various modalities, but one of the things which are tried now are the systemic steroids in BPD prevention. So we'll be discussing, our objectives today will be to understand why we are talking about the use of corticosteroids in BPD prevention, number 1. 2 main steroids have been used in prevention of BPD. One is the hydrocortisone and dexamethasone. So we'll see where to use and how we are going to, in what doses we have to use it. The optimal regimen and timings, when to start these steroids, and the benefit risk ratios, and how, if we are putting these babies, small tiny neonates on steroids, so how we'll monitor these babies. So these are the main learning objectives of today's talk. So before we go further, we must understand the underlying cause of BPD, how BPD occurs. Now BPD mainly occurs in the very small for gestation babies, like those who are less than 28 weeks, who have been exposed to oxytrauma, barotrauma, volume trauma, especially those babies who have been ventilated for a long time. They are very prone to develop BPD. And the underlying cause of this is thought to be the inflammation which occurs in the lungs. But there is another thought which is getting more and more momentum nowadays, which says that these babies are born extremely premature. These lungs are in the canicular stage, and when the baby come out, there is arrest of the development of lungs. So like typically alveolus is grape-like structure, but in this they are round structures in alveolus, and there is a great reduction in the surface area of the lungs. So the amount of surface area which is actually available decreases drastically. Another thing happens is that the vessels are also developing which are immature. So the vascular pathology also plays a role, and ultimately there is a VQ mismatch which occurs in these babies. But understand that the key thing which happens is the inflammation which happens in the lungs of these babies. So it is here that the steroids come into play, because steroids, have we all know, are anti-inflammatory drugs. They improve lung compliance. They are also anti-fibrotic, because ultimately there is a fibrosis which develops in these lungs, babies of these lungs. And like we saw in COVID, there was cytokine storm, and there the steroids were used. So similarly, they reduce the cytokine and oxidative damage to the lungs of these babies. And they are also found to improve the surfactant production and lung compliance. Now, this is not the topic of today's thing, but we also use these steroids antenatally in the mother. Now, this indirectly decreases the incidence of BPD, because if the mother is given antenatal corticosteroids, then there will be less chances of respiratory distress syndrome developing in the newborn. And ultimately, this will then reduce the BPD. But we will not be discussing much. We know 2 steroids which have been used in mother. One is betamethasone, the other dexamethasone. Another way which has been tried in the babies is a nebulized steroids which have been given, like betamethasone and budesonide. But they have a controversial role in preventing BPD. So we will be mainly restricting ourselves to the postnatal IV corticosteroids. Now these have been used to reduce the lung inflammation in preterm babies, and we put them into early and late. Early are the steroids when you are using steroids in the first 7 days of the life of the baby, and late are the one when you use it more than 2 weeks, and in between is the moderate time when we use the steroids. So talking of the early stage, when you are using very early on day 1, day 2, you are starting the steroids. Now these early systemic steroids, how they act is that they reduce the BPD incidence by they are found to reduce, but another apprehension is that suppose a 800 gram baby is there, and we are putting that baby on steroids, it appears to be risky, and we know it's very difficult to digest that we are putting a baby who is already compromised on steroids. So there is a benefit risk ratio we have to see. The risk, as we know, that exposing a child to early steroids may increase the risk of GI bleed, hypertension, hyperglycemia, and on follow-up we are also scary that there may be some neurodevelopmental issues in the baby. Till now they were not routinely recommended, but there is one study which we will see that which recommends now the use of these steroids. The other is a late use of steroids. This we have all been doing for last 2-3 decades. Whenever we put a baby on mechanical ventilation, so the time when we are trying to extubate the baby, we usually cover them up with some sort of steroids for some days. So that is something which is established. So they are mainly used in ventilator dependent babies, and the one drug which we have been commonly using for a long time is the low dose dexamethasone, and again a short course is preferred. So now coming specifically to the drugs, one is the hydrocortisone. Now there is a study which was published about 9 years back in Lancet, that is a Primiloc regimen, wherein they recruited less than 28-weeker babies. So very, very tiny neonates were included, and they were put on steroids right from day 1. They gave the steroids for about 10 days. Initial 7 days they gave 0.5 milligram per kilogram, and then they tapered it to from 0.5 twice a day to once a day, and then stopping it on day 10. Now when they followed up these babies, they found that there was increased survival without BPD, and there were minimal neurodevelopmental harm reported, and some increase in early sepsis was there, and some cases of GI, so that GI perforation was there. So we had to monitor these babies very closely for infections and GI perforation if we are electively putting the babies on hydrocortisone. Another drug which was parallelly used in these babies was dexamethasone, but again it was given up because hydrocortisone did not have so much adverse effects, but early dexamethasone, it also decreased the risk of BPD, but it raises the CP and neurodevelopmental risk. So this is not a preferred drug if you are using it as an early drug for preventing BPD. So only hydrocortisone is the one which have been tried for early prophylaxis. Again, I am telling you this is not standard of care. This kind of steroid use, when you are prophylactically putting the baby on steroids, hydrocortisone, it is to be done in centers of excellence where you have everything in place, where you are using non-invasive ventilation, where excellent nursing care is there, and using all other modalities. Only then you can think of putting these. Routinely in any center cannot start using hydrocortisone for prevention of BPD, and it has to be a one-to-one discussion with the parents. You have to tell them that yes, this is one drug we are trying to use, and you have to take their consent also if you are putting the babies on early hydrocortisone. Late dexa, as we know, it is used in children more than 7 days, and it facilitates extubation and reduces the BPD incidence. Again, use it for about 5 to 7 days, and tapering doses, like the day you are trying to extubate, you may use it at 0.15, and then gradually taper it to 0.05 over the next 5 to 7 days. And try to use the lowest possible dose and the overall less cumulative doses of dexamethasone. Again, what we have to monitor whenever putting the babies on steroids is, we have short-term risk and long-term risk. Short-term is, we know that steroids raise the blood glucose levels, so you have to monitor the babies for hyperglycemia. Again, you have to measure the baby's blood pressure for development of hypertension. Infections and GI, these are 4 key things we have to monitor if we are putting the babies on steroids. And long-terms, of course, if you are using steroids, you have to follow them up closely for neurodevelopmental issues. Again, monitoring, we have to do blood BP charting, glucose infection signs, and schedule developmental checkup. So just to put it together all, early hydrocortisone is one which, as per the Primiloc trial, can be given to extremely premature babies which are less than 28 weeks. Late dexa, as we know, is for persistent ventilator dependent patients, and it's usually used beyond 1 to 2 weeks. And again, I'm stressing it has to be a shared decision making. You cannot straight away say we went to a conference and the speaker was recommended you start using steroid. No, it has to be a shared decision making. You have to take the parents into confidence. And there are certain BPD risk prediction tools which are available on the net. You can use those tools and predict the risk of developing BPD, and there, with the discussion with the parents and your team, you can judiciously use early hydrocortisone. But again, you have to remember that before you go do this, you should optimize all the non-pharmacological things like mother's own milk, early KMC, thermoregulation, strict asepsis, using of non-invasive ventilation, minimal use of oxygen. All these things should be should be in place before you are thinking of using the steroids. And if only your center's policy allows you, then only you should start thinking of using early hydrocortisone, and for late, of course, you are using steroids, and a parental consent is a must. So summary of evidence is that, of course, antenatal steroids in the mother, we know that they decrease the RDS and indirectly decrease BPD. Early systemic steroids, you mainly use hydrocortisone, they decrease the BPD, but there is a certain amount of neurological risk which is involved. Late systemic steroids help in extubation, and only short courses are recommended. Inhaled are still experimental. So this is the current recommendation. I'll discuss this. The key thing is use the least effective dosage and for the shortest duration. So this is a summary of evidences from last 10 years. Systemic steroids, they reduce the overall BPD risk. Early hydrocortisone, low dose hydrocortisone improves survival without developing BPD. Early dexamethasone not recommended, but late is reduced in high risk infants who are mechanically ventilated. And it should be a selective individualized use of these steroids. These are some of the references that I consulted, and thank you so much. Now giving to my own, I have never used prophylactic systemic steroids, I can say that. I'm very scared of using it, but maybe some centers are talking to Dr. Ashwini just now before this talk. He is working in Ludhiana, and he said that they are selectively started using in few infants. But still he also was of the view that everything should be a high quality, excellent NICU. Only there you can think of using steroids prophylactically. But as of now, I think most centers will be scared to use the steroids. Maybe somebody from you, if you have been using, you can share your experience. I personally haven't used the systemic steroids for prevention prophylactically. Yes, we have been using, from my PG days, we are using it when we are extubating the babies, we are using DEXA, but not, personally I have not used it. Anybody wants to share their own view?
So like as per your slide, I mean it was like above 7 days hydrocortisone you can give based on the risk.
Yes, only
so my point is, what is the protocol? Because again the audience, even myself, I'll get confused.
Sir, if you are using hydrocortisone, number one, you should start using it from day one, before the inflammation sets in. And the dose I have told that use it 0.5 BD and then 0.5 OD. For 7 days you give 0.5 milligram per kilogram BD dose, then OD, and then stop on day 10. Like your aim is that you're reducing the inflammation in the lungs early stage only, so that the chances of developing all those markers, oxidative markers and inflammatory markers are not there, and the child does not develop BP. There's only.
But sir, point is like if you are dealing with a ELBWs, if you are dealing with a preterm, where I mean NEC is one of the biggest challenge.
They are, sir, that
so I mean how we can balance it? Is it a guideline, or is it like it's depending on the risk?
Sir,
you
still
can decide.
From India there are no studies as such. This is a foreign study. India, no studies there who can claim that yes, we have used it. But since this was the topic was the new things on the horizon, which are occurring in other parts of the world, but still few selective centers they have started using in India, but there are no published trials from India which can claim that yes, we have used it and we have found them to be effective.
So like take home message for a level 2 care, what I want from your side is like
level 2 you should not use it, sir. It's only
exactly.
level 3 highly
level 3, right?
Level 3 highly advanced, where you can monitor everything very closely.
And
otherwise personally I don't recommend it.
Yes,
for a level 2.
One more question is like if you compare with hydrocortisone and dexamethasone, then
DEXA is not recommended, sir. DEXA is a big no. Hydrocortisone, yes, because in Premiloc trial they have tried, so yes, you can go ahead. But again, we have to do our country trials and see that whether it is actually working or not. So it's again like more or less experimental. DEXA, of course, the standard of care for extubation, but hydrocortisone, I think still it is experimental for India.
So very good talk. I think this topic every time in the NNF, I mean whenever it is there, BPD and role of steroids. So from the audience side, if anyone has any question.
Sir, I think I told you in the beginning only that it was not an issue for us for about 20 years back. But now as more and more centers are having babies surviving of 25, 26 weeks, so we are going to see more and more BPD. So we have to start thinking that how we are going to tackle those babies. So this is a step in that direction, that maybe in future when more Indian trials are there, when results are there, we can start thinking in that direction. But I think currently I say it's a no for our country as of now.
Great, sir. Any question from the audience?
Thank you, Dr. Tomar, for such a nice talk. Dr. Vijay want to say.
Yeah, yes. Thank you, sir, for very nice presentation. One question I like to ask you that how long you are giving dexamethasone in case of extubation of the baby? Is
Sir,
there every baby
no,
needs
it's not like it's in this
dexamethasone during
hydrocortisone is fixed. The 7 days plus 3-day tapering. Here we are giving from anywhere from 5 to 10 days. Like if you have been extubated on after 2 days of mechanical ventilation, you may give it for 5 days. If you are giving it for a prolonged period, you may continue it for 7 to 10 days also. But it should be gradually tapered. Like you use 0.15 milligram, then gradually 0.1 and 0.05. That's how you gradually you reduce the dose. There is no standard fixed protocol for the use.
This is for sir BPD patient, a very small baby, and the normal baby, term baby, if they needed ventilation.
It's mainly for the premature baby.
How long, how short course? How
So
many days?
At least for 5 days, sir.
If the baby ventilated only for 2 to 3 days, then?
Then also, sir. Minimum 5 days. You give it for like 48 hours, you give doses, and then you gradually taper it over the next 2-3 days. There is no fixed protocol like 7 days, 10 days not giving, because again you may have a baby who has been ventilated for say 2 weeks, vis-a-vis a baby which was only ventilated for say 2 days. So again you cannot generalize it for a dose for every baby like that.
No sir, we are giving, we are ventilating the baby for 1 to 2 or 3 days, then may not need any steroid for extubation.
That is for these are bigger babies.
Yes.
We are talking for the premature babies who are at risk of developing BPD. Extremely premature babies. Not for the, like you have suppose a baby of say 2.5 kg, there you may not use steroid also.
Okay.
Yes.
Thank you.
Right.
Thank you, sir.
Thank you, sir.
I think no more questions. So thank you, Dr. Tomar, for such a nice talk. I will request all the chairperson and the speaker to please come for the memento distribution. And I will request Shravan sir and other dignitary on of the dais to please assist. Sir, please. Moving on the next, we have a very important talk and very important person all the way from Delhi, Dr. Lalan Bharti sir, President-elect NNF. I need a big round of applause for Dr. Lalan Bharti, please. So, सर घर और ससुराल पे हम लोग कमेंट नहीं करेंगे सर दोनों बिहार में सर So, Dr. Lalan Bharti, please, I welcome you. And for chairing that session, we have Dr. Gaurav Gupta, Dr. K.N. Mishra, sir. Dr. K.N. Mishra, sir. Dr. K.N. Mishra, sir, please come on the dais.
Needs no introduction.
Thank you so much, sir.
He is a great pediatrician working in Delhi, but he is ours, and that is of Bihar. He has so many holding posts, designated HOD pediatrician, workplace is JPC Hospital, Government of Delhi, MD, gold medalist, FNF, FIF, fellow, and so many awards, national faculty, master trainers. Organizing chairperson, and so many achievements, executive editor, Journal of Neonatology. More than 39 publications in the national and international journals, written and reviewed multiple chapters. In spite of all, he is our elect president. So, he is a...
Thank you, sir. Thank you very much, Mishra sir, for kind introduction and blessing.
Nice, sir. You can deliver your speech, sir.
So, at the outset, I would like to thank the organizer for giving me this opportunity. And coming to Bihar is pride and privilege for me, and sharing my thoughts on that. So today I'll be taking you through the major challenges and the evidence-based solution that can help us to ensure that every baby not only survive, but survive intact. So why do we need this topic? Because this perinatal period in the life has the highest risk of mortality. Every year, around 2.3 million newborns die within first 28 hours. And around 2 million pregnancy ends as a stillbirth. Contribution of neonatal mortality to under 5 mortality has been increasing steadily, and a significant proportion of survivors face major neurodevelopmental outcome. So now our focus has been shifting from survival to intact survival. To improve the neonatal mortality, we need to provide quality and nurturing care right from the perinatal period. Although the neonatal survival has improved drastically, the gap between birth and intact survival remains wide. The 3 delays contribute majorly for the intact survival. The delays in making decision to reach the, delayed in the making decision to seek the advice, delayed in reaching to the center, and delays in getting the treatment. The major contributor of neonatal mortality are prematurity, low birth weight and its complication, intrapartum hypoxia, infection, and suboptimal immediate neonatal care. Adding to that, the fragmented maternal newborn services, variation in quality of care, and delayed referral pathways, socioeconomic and geographical inequities. All these lead to gaps in intact survivals. Bridging these gaps is absolutely essential if we want to reduce preventable deaths and improve survival. Maternal health strongly influence the neonatal outcome. The preconception factors include maternal nutrition, anemia, short interpregnancy interval, chronic illness. During the antenatal care, the focus must be on the quality antenatal checkup, like monitoring of the blood pressure, hemoglobin, screening of the ultrasound screening, detection of infection and diabetes, supporting healthy lifestyle and mental health. The important prophylaxis to improve outcome include tetanus prophylaxis, iron and folic acid, aspirin prophylaxis for preeclampsia, and RH prophylaxis. So WHO antenatal care model updated in 2016 and 2020, along with the FOXI and Government of India guidelines, give us roadmap to optimize the maternal health for better pregnancy outcome. The intrapartum period is critical for both mother as well as newborn. The skilled birth attendant very, very crucial for both mother as well as the baby. The proper use of partograms help timely operative delivery. If risk is anticipated, it's better to transfer the baby in utero to the facility where all the facilities are available, and it prevents around 20 to 30% of the intrapartum related death and stillbirth. WHO intrapartum guideline and Lux Labour Room Quality Improvement Initiative of the India has provide a strong framework for strengthen the labour room management. This is our real-time data from the SNSU, which shows that the majority of the neonatal deaths are preventable, and the major deaths are because of the prematurity and the low birth, accounting for around 46%, followed by birth asphyxia 24%, and infection around 70%. We can see that the antenatal care and care during birth have 41% effect on neonatal mortality, and around 30% of the neonatal mortality can be reduced by caring a small and sick newborn baby. So now I'll discuss the key intervention to improve intact survival, like antenatal and interpartum intervention, the measures during the pregnancy and labor to safeguard both mother as well as the baby. Immediate care during delivery, the fetal life into the outside womb life. The postnatal strategy, ensuring health and intact survival after birth. And all these will be discussed in relation to the evidence, guideline, and practices. This slide highlights some of the key antenatal strategy to improve perinatal and neonatal outcome. First one, the antenatal, proper antenatal nutrition, like iron, folic acid, balanced and energy supplement, calcium. All these reduce the preterm birth and stillbirth. Second, the management of the chronic condition, like use of low dose aspirin and this smoking convention for the stoppage of the smoking. These will reduce the low birth weight as well as also prolong the pregnancy. The third one is the preventing and treating infection, especially urinary tract infection, malaria, syphilis. These significantly reduce stillbirth and preterm birth. These interventions, though looks very simple, can make a major differences when applied uniformly and effectively. Some of the best antenatal practices for prevention of prematurity include use of vaginal progesterone during the gestation, in the pregnancy with short cervix, combined cervical length measurement and biomarker test will identify women at risk of early delivery within 7 days, and this will allow the judicious use of other drugs and antenatal steroids. So antibiotic in premature prolonged rupture of the membrane, 22 trials involving around 7,000 women and baby showed that the use of antibiotic following PPO-RM is associated with significant reduction in infection in both mother as well as infant, 1917, showing improved preterm outcome. It gained global recognition in 1990 when featured on Cochrane collaboration logo, and since then it has been used across the world. WHO also endorsed its use, and now today ACH is the standard of care for threatened preterm birth. Antenatal corticosteroid enhance fetal lung development by reducing the incidence of RDS and mortality in preterm infants. A single course of antenatal corticosteroids for infant born before 34 weeks of gestation can reduce RDS and as well as the mortality up to 50%. Its use is also associated with decrease in the rate of IVH and NEC. The decrease in IVS is by around 46% and NEC is around 23%. The current guideline for use of antenatal corticosteroid recommends it should be given between 24 to 34 weeks of gestation with high likelihood of preterm delivery, and it should be given within 7 days after starting this therapy. There are two equally recommended drugs, that is dexamethasone and betamethasone. But in India, we are using only the dexamethasone because in the betamethasone, the dose recommended is for both the salt, that is acetate as well as the phosphate. But in India, only acetate is available. So we should use only, and Government of India is also recommending, that is dexamethasone 6 milligram IM 12 hourly or total of 4 doses. So there was a question whether this antenatal steroids are effective in LMIC like ours or not, because there were chances of infection. For that, there was an action trial, and that shows the result of that action trial was in favor of using dexamethasone even in the developing country. There was significant the evidence from the updated Cochrane 2020 review, including 27 trial and more than 11,000 women, supports the continued use of single course of antenatal corticosteroid. It accelerates the lungs maturation in women at risk of preterm birth. The treatment with antenatal corticosteroid significantly decreased the risk of perinatal death, still in mortality and respiratory distress, and there is more chances of hypoglycemia, so it is not recommended in late preterm. Another vital intervention is magnesium sulfate. It is used for its neuroprotective effect. It significantly decreases the incidence of cerebral palsy in preterm baby. Antenatal magnesium sulfate significantly reduces incidence of cerebral palsy at 2 years of the age, regardless of the gestational age or cause of the preterm birth. The reduction of the cerebral palsy is around 30%, and it improves overall incidence of the intact survival. So magnesium sulfate play a vital role in improving neurodevelopmental outcome in preterm infants. Magnesium sulfate should be considered from viability to 31 plus 6 days with imminent preterm delivery. The best available evidence recommended the dose of 4 grams IV loading followed by 1 milligram per hour until 24 hours or delivery happens, whichever comes first. Now moving to the delivery room intervention. Immediately after birth, the newborn care bundle is critical. This includes provision of the warmth, resuscitation as per the NRP guideline, immediate skin-to-skin contact and early initiation of breastfeeding, delayed cord clamping, and practice of clean cord care. This delayed cord clamping reduced neonatal mortality by 30% in preterm baby and anemia by 60% in term baby. Early initiation of breastfeeding decreases 20% NMR. So such interventions, though looks very simple, ultimately if practiced save thousands of the baby. So we should defer the immediate cord clamping in all baby who do not require resuscitation. Delayed cord clamping definitely decrease the mortality in the preterm baby. But the condition where delayed cord clamping cannot be managed, in that condition, what next? So for non-vigorous term and late preterm infants, intact cord milking can be reasonable compared to the early cord clamping. So if you have to select between the early cord clamping and cord milking, it is better to do the cord milking in baby between 34 to 28 weeks of the gestation. But don't do it below 28 weeks of gestation because of the risk of IV. So why it should not be done below 28 weeks of gestation? Because of the lack of the cerebral autoregulation, right to left shunt result in fluctuation in flow to immature brain with the fragile germinal matrix that lead to IVH. So cord milking is not recommended below 28 weeks of gestation. This slide shows how important is NRP training. So if we do the NRP training effectively, it reduces neonatal mortality by 75%. And it also reduces overall mortality by around 48%. So we must focus still on effective neonatal resuscitation training program, because birth asphyxia is one of the commonest cause of neonatal mortality. So second most common is the prematurity and low birth weight. So morbidity and mortality of preterm baby can be decreased significantly by proper temperature and cord management, judicious use of oxygen, providing proper respiratory support by using TP's resuscitator and surfactant. So almost all delivery points should have blender and pulse oximeter so that we can give judiciously oxygen can be used. In delivery room, thermoregulation is also very important. Even a drop of 1 degree Celsius of temperature increases the neonatal mortality and morbidity by 28%. And RP recommend 26 to 28 degrees centigrade for preterm delivery. Mother's own milk is the best food for all the newborn, and WHO recommended moms to be given to all term, preterm and low birth weight infants. There are lots of advantages of breast mother's own milk. I am not going to enumerate all that. Coming to the kangaroo mother, WHO recommended that the kangaroo mother care should be routinely used in all the facility in 2014. And based on that, there was a Cochrane review in 2016, and it shows that a quarter of newborn death can be averted by universalizing kangaroo mother care. It is a simple, cost-effective, powerful intervention for reducing mortality and morbidity. But this recommendation was for the stable baby. There was a study in Delhi. There was a multi-centric, multi-country study in which it was shown that the incidence of mortality has further 25% decrease when early KMC was started in the IKMC ward. So, but still the KMC rate in India is only 20%. So a scaling up of this KMC along with the IKMC can make a significant dent in neonatal mortality. So this is the slide. I think Sugandha will be taking this lecture on this. I am not going to touch on that. So another is the referral and transport are the another critical link. Wherever possible, in utero transfer should be practiced. And if transport is required, we must stabilize the baby before transporting. There should be a closed feedback to the transferring unit, and use of teleconsultation can further strengthen our transport pathway. So, policy and public health in India are aligned with the goal of intact survival. The National Health Mission had strengthened facility-based newborn care through SNSU and NBCU. Janni Shishu Suraksha Yojana and Lakshya program have improved institutional delivery and labor room quality improvement. Initiative like Suman, HBNC and HBYC expand community-based care through ASA and ANF. India are committed to the Sustainable Development Goal, particularly the target 3.2, aim mortality by 12 per 1,000 live birth and under 5 mortality by 25 per 1,000 by 2030. Achieving these goals will require continued focus on mother and newborn health. So in conclusion, bridging birth to intact survival requires a comprehensive approach from maternal health, intrapartum care, immediate newborn care to effective transport system and robust public health system, along with the commitment from the all healthcare professional, all the government, all the leaders. The proven evidence-based perinatal care include administration of antenatal corticosteroid, magnesium sulfate, prevention and treatment of maternal and neonatal infection, implementation of optimal labor room temperature and delayed cord clamping, judicious use of oxygen by use of pulse oximeter and blender, and early use of CPAP. Mother on milk KMC, immediate KMC can make a significant difference in the neonatal outcome. By strengthening perinatal care, we can ensure that every baby not only survives but thrives.
Thank you, sir.
Thank you.
Thank you, sir, for the enlightening, enriching session, sir. One thing I want to ask you, like you told, is there any evidence of antenatal progesterone for decreasing the preterm birth? And second thing, you told about late preterms giving corticosteroids. So WHO does not recommend, but I think a nice guideline do says that we can give actually even in the late preterms for reduction of the antenatal steroid can be given more than 34 weeks babies also. Nice guideline, I think they says that, and even in the ALPS trial they have shown that within they have given steroid, antenatal corticosteroid ACS to the babies who are more than 34 weeks, and they found there is significant reduction in the respiratory support.
There is a reduction in the respiratory
support,
rate, but overall incidence is not improved.
Okay.
So even the NNF and WHO is not recommending its use in late preterm.
Yes,
and there is also increased incidence of
hypoglycemia was there. Yes.
So till we got the robust evidence, we should not avoid using in late preterm.
Yes, sir. And one more thing, sir, regarding that progesterone you told to for antenatal strategies to reduce the preterm birth, like maternal progesterone ring for cervical.
That is local, and I think the answer could be given from better by the obstetrician colleague.
Okay.
But they are
sir.
using for prolong the
yes, sir.
pregnancy.
Okay, sir. Thank you very much. Thank you, sir.
Thank you, Lalan sir, for such a nice talk. I will request all the chairpersons, Mr. sir, A.K. Jha sir, Gaurav sir, and I will request S.A. Krishna sir. Thank you, sir. Moving next, we have Dr. Devasish Nanda. I will request Devasish Nanda, sir, to please come on the dais. And for chairing that session, I will request Dr. J.P. Narayan, sir, Dr. Randeep Singh, and Dr. Atha Ansari, sir. Devasish, sir. Devasish, sir.
Dr. Devasish Nanda. Dr. Devasish Nanda is our next speaker, who is Professor in Neonatology in IMS and SUM Hospital, Bhubaneswar. His qualification is MBBS, MD Pediatrics and DM Neonatology. And his areas of interest is non-invasive ventilation, focus and ELBW care. His major achievement, 35 publications, a national trainer, FBNC, SSK, NBSU and NRP. His topic is the quality improvement initiative in NICU. And our motto is reducing the NMR and preferably in single digit. And for that, quality improvement in NICU is must. And I am inviting Dr. Devasish Nanda for our enlightenment.
Thank you so much, sir, for the kind introduction. So, from morning, actually, we are listening to various low-cost intervention, as told by Dr. Rajesh sir. Then recently, Lalan sir also told about many various low-cost intervention which are likely to improve the neonatal mortality, like use of antenatal corticosteroids, use of delivery room CPAP, various bundles to reduce nosocomial infections, sepsis. All these things are low-cost intervention. We have been listening, but when actually we come to practice, we know we have the knowledge, we have the resources, but when it actually comes to practice, there is a huge gap between the knowledge and practice. So what we call it as know and do gap. Okay. So to bridge the gap, again, as told by Dr. Bijan Saha also, that quality improvement is a tool that is going to reduce this gap and likely to improve various patient outcome. So my objective of the presentation is to discuss basic functioning of a healthcare system and what is the concept of QI, why it is important, and what are the domains of quality improvement initiative in NICU and how it is done. So just to begin with, so let's have a basic look at the healthcare system, how it works. So it's a very simple model you can see. So there is a healthcare system which can be a tertiary care center, it can be a PHC, CHC, or different level of healthcare are available. Then we have healthcare professionals who are going to deliver the healthcare through various processes. What do you mean by processes? Processes are basically various actions which are being taken for the patient care, which ultimately translates into some of the patient outcome, and we'll get some outcomes. And how these processes are being affected. So we can see there are various factors which actually influences these processes or actions we are going to take. So some of these are the various clinical evidences. So we have been learning throughout the day. So various evidences. Then now there is a concept of competency-based medical education training, various guidelines, CPGs, and availability of resources. So all this culminate into a patient outcome. So why this quality is important? So again, there is a study, it was published in the Lancet Global Health 2018. It basically says that healthcare. So out of this, nearly 3.6 million are because of non-utilization of resources, and almost 5 million are due to poor quality of care. So this is what is a recommendation we are going to discuss. So various institutional or academic bodies like AAP, BPNI, UNICEF, WHO, NNF, IAP, all of them are recommending regarding early initiation of breastfeeding within 1 hour, exclusive breastfeeding for 6 months and continued breastfeeding till 2 years of age. But what is actually practiced? So again, this is as per the NFHS data. So various NFHS starting from 1990s to 2021, you can see there is an increase in the rate of exclusive breastfeeding rate, but it is still 41%. Recommended is 100%, but it is still 41%. So you can see there is a big gap between the evidence and what is being practiced. So this, we know that various evidence-based guidelines exist, but in real practice, the compliance to these guidelines is very minimal, often suboptimal. It can vary from 9% to 36%. And we know that only by providing guideline, we may not be able to improve the health care, and it may not be able to translate to better care. So you can see again a paper published in Lancet Global Health 2019, which basically says that more than 1 million neonatal deaths in low and middle income country are due to lack of high quality healthcare system. And if you see the compliance rate to the evidences, it is below 50% in LMICs. So these are the common bottlenecks for implementing quality care. So there is a lack of opportunities, there is lack of ability, means there is a deficiency in your skill level and knowledge, there is lack of motivations. So it is very difficult to change a people's thought process unless they are working in a group. Then there is some limitation in the supplies and various resources. So again, there is a systematic review again published in Lancet 2018 regarding various effectiveness of various strategies to improve the healthcare provider practices in low and middle income countries. So these are the various strategies. You can see only technology is likely to improve the healthcare practice by only 1%. And if you see the group problem solving, or what we call as quality improvement, it is a group activity. That's why it is called a group problem solving. So it is likely to improve the healthcare provider practices by about 28%. And if you combine this QI with clinical training, then probably your outcome is going to improve by 56%. So then coming to the various domains of healthcare quality. So there are basically 6 domains. So the healthcare has to be safe, it has to be effective, you should avoid any misuse of resources, patient-centric, it should be timely, it should avoid many meaningful delays, it should be efficient and equitable. Then how this QI helps actually? So QI actually increases the efficiency of an individual in a group, optimizes the work schedule, it reduces and saves resources and money, prevents wastage, and it improves the problem solving skill, improve the team dynamics, and it can improve your translational research as well. So there are various issues or challenges to implement quality services in LMICs, like there are problems related to staffing. Sometimes you are getting understaffing, overcrowding, lack of various resources, shortage of basic equipment, issues with sanitation and hygiene, and weak safety and quality culture in general, and sometimes we are getting a disinterested leadership teams as well. So all these actually are contributing to poor quality of services in various LMICs. Then coming to how this QI is being done. So basically we have 4 steps of QI. The first step in QI is that you have to identify a problem, you have to form a team, and you have to write a aim statement. That is the first step. Then after identifying the problem, you have to analyze and measure the quality of care which is already going on. Then after that, we have to develop some changes and develop some tests, develop some hypotheses, and we have to test some changes, whatever is possible. And in the 4th step, we have to sustain what we have achieved in the previous steps. So first step, coming to the first step, which is identifying a problem. So here comes the importance of a data. So all these things are based on the data. So you need to improve your collection of data. So collection of data has to be improved. So review local health facility data and you need to identify the gaps, okay, where the deficiency actually lies. So there are some basic rules to identify a problem, like it has to be a simple and easy to change, and it has to be of some value to for the patient outcome, doesn't need too much of resources, not a very rare event, and it should have a short turnaround time. Then once you have identified certain problems or certain deficiency in the healthcare system, then you have to prioritize. So you cannot solve all the problems at the same time. So you need to prioritize which problem to solve first and which to solve in the next session. So you need to have some prioritization. So basically we are using the prioritization matrix, which is a scale of 1 to 5, and out of a total score of 20, you decide the priority. But the 4 basic questions for prioritization are, so the question should be important for patient outcome, it has to be easy to measure, affordable in terms of limited resources requirement, and it has to be under the control of the team members. Then coming to selecting a team. So without a team, it is very difficult to conduct a QI. So team is a very important, or you can say one of the center of event in whenever you are planning to do a QI. So try to involve people from every level and all the involved departments, and need to assign them a specific role, maybe leader, recorder, communicator, or any other role which is relevant. And try to involve people who are more enthusiastic, involved, and influential, which are likely to influence the other people. So why teamwork? It is very important for doing any QI. Teamwork is very important because healthcare is basically provided by a range of people. It is not provided by a single person. And staffs, if you are providing opportunity, actually the staffs can identify many problems and they can generate ideas for the solution. And participation basically improves your ideas and reduces the resistance to change. And overall it improves the confidence as a team. So coming to the aim statement, which is a very important part in the first step of QI. So what is a aim statement? So you need to, the aim statement has to be clear and has to be specific, means what actually you are going to improve. Then specific patient population means which population we are going to work on. So who will be the affected? What is our goal? Goal means how much actually we want to improve. Certain amount we want to improve, and by what time. So all these things combined becomes a aim statement. So there is actually a mnemonic for that. So we call it as a SMART aim. The aim statement has to be specific, measurable, achievable, relevant, and it has to be time based. For example, we want to improve skin to skin contact after birth. All healthy babies who are vigorous, term babies, and we want to improve skin to skin contact after birth. So here the aim statement will be something like this. So we'll increase skin to skin contact for term vigorous neonates after birth for at least 1 hour from 10%, which is the current practice based on the data, to 40% within next 2 months. And specific timeline also has been mentioned. So here you see, so who is the person? So who is the, we are targeting the population. So here we are targeting the term vigorous newborn after birth. What we are doing? We are promoting skin to skin contact. And how much improvement we want? We want an improvement from 10%, which is current based on the data, to 40%. By when? In the next 2 months. So this becomes a SMART aim statement. So this is the first step whenever you are planning any QI study. Then coming to the second step. So once you have identified the problem, then you have to analyze the problem and you have to measure the problem. Okay, so measuring and analyzing becomes the second part. So why it is important for to analyze the problem? Because we need to explore all the possible causes of the problem. So a single problem may have multiple causes. So need to find out and explore all the possible causes of the problem, identify things which we can control directly as a team, and we need to give opportunity to everyone to provide their insight in the team. So basically what we are doing by problem analysis, we are understanding what is currently happening in the system and we are identifying the possible solutions. So what are the benefits of problem analysis? So identify several causes of a problem, then we need to prioritize and try to find out few causes which account for majority of the problem. So there may be 10-15 causes for a single problem, but out of them 3 or 4 are most important, or that is causing the major of the issues. So we need to identify those problems and prioritize and focus on the causes which are within our control and these are possible for early easy remedy. And we need to simulate a discussion among the team members and involve all the team members in the analysis. And think about how this reorganization is going to help and improve the process of care. So one of the common methods to identify the root cause or to problem analysis is a fishbone analysis. So you know there is a problem and there are many causes of that problem. So just like a fishbone, we can divide these problems into various subcategories like some problems related to policy, some problems related to the procedure, some problems related to the people, and some problem related to place. So we need to categorize the problems into various subcategories and that will help us to pinpoint the various causes of the problem actually. So we call it as a 4P approach commonly used, but there may be some other categories depending on the QI project you are choosing. So then another important principle is the Pareto principle. So what is this Pareto principle? So basically it says that 80% of the problem are due to 20% of the causes. Okay, so we need to find out those 20% of the causes which is actually accounting for 80% of the problem. For example, so we are looking at a problem like there is medication error. So why there is medication error? So when we have analyzed, so we have found that there are various causes of medication error. It is due to wrong patient, wrong dose, wrong route, improper storage, improper dilution. There is some error in the prescription, wrong labeling is there. But when we try to find out, try to plot, so we found that these three problems are actually causing, responsible for the 80% of the problem. So only these 3 important causes are causing 80% of the problem. So we are trying to find out the major chunk which is causing the problem. Then coming to another concept called as process flow chart. So there is a process, okay, there are various steps of a process. So there is a beginning point and there is an end point, and in between there are many steps. So after this certain step we are going to the next step, and after that step we are going to the next step. And sometimes we are getting options. So options means if this thing is there we will go in this direction, and if it is not there we will go in the other direction. So these steps are basically depicted in a square or rectangle, and whenever we have options, so those are represented as a diamond, and whenever the steps are not clear, so it is represented as a cloud. Then coming to this measurement. So you need to measure, you need to use some indicators. So these indicators, basically there are 2 types of indicators. So one indicator to measure the process, and there are some indicators to measure the outcomes. So these are the basic qualities of a good indicator, and due to shortage of time I am just skipping these slides. So developing indicators are very important. So one indicator is for the process. Process means whatever the actions we are taking, and outcome means what are the outcome we are going to analyze. So this is an example. So we want to improve the exclusive breastfeeding rate of the babies at the time of discharge. So here the outcome is the percentage of baby who are being exclusively breastfed at the time of discharge. And what is our process here? Process is percentage of mothers who initiated breastfeeding within 1 hour. So by initiating breastfeeding within 1 hour, we are going to improve exclusive breastfeeding rate at the time of discharge. So here the process is initiation of breastfeeding within 1 hour, and the outcome is exclusive breastfeeding at the time of discharge. And what is the denominator? So the total number of babies who are being delivered in the hospital. So these indicators are basically some rate or ratios. Similarly, this example of another indicators. And then coming to the time series chart. So in a time series chart, basically we are plotting the indicator in the y-axis, and in x-axis we are plotting the time. So against time we are plotting the specific indicator, maybe process related indicator or it may be outcome related indicator. So basically this shows us whether we are achieving the target, we are improving or not, and it also helps in comparison with the other units. Then coming to the third step, I am just going little bit fast. So here the most important thing is a PDSA cycle. So everyone knows that this is plan, do, study and act. So in plan, basically we are planning what we are going to do, like who is doing, what we are doing, where you are doing, how we are doing and why you are doing. So all these things have to be answered during the planning. Then we have to implement whatever we have planned, and in the next step we have to analyze whether we could achieve the desired target. Is there any flaw or how it can be improvised? And based on that, we are going to see whether the improvement is occurring or not. So we are going to analyze here is the change is feasible and did the change lead to some improvement, and based on this we are going to either adopt the idea or adapt. Adapt means we need to modify and abandon the idea. So certain examples of planning, PDSA, then going for changes, and in the final step, so once you have done multiple PDSA cycles and you have observed there is some improvement or the desired indicator or the parameters has improved, we need to sustain the improvement. So for sustaining improvement, it is basically very important to make the system change rather than any individualized change, because once the changes are incorporated in the system, then it is going to be sustained. So at the individual level, it is not going to be sustained. So these are the basic steps. We need to build enthusiasm in the team, motivate the team, share the successful projects widely, and make policies to work in the new way, and making the system change, which is very important. And leadership, it has to be facilitative. That means we have to empower your team members and support them so that they can work in this particular environment. So this is the last slide. So summary or take home message is that QI are context specific. So in one context, the QI project may be different, and depending on the context it may vary, and it's a continuous process. It is not a one-time solution, so it has to be a continuous process, and data are very important. So they help collection of data, analyzing the data and comparing the data. All these things are very important, and group is very important. And finally, PDSA cycles, and you have to check whether you are improving or not, and based on that you need to adapt to multiple PDSA cycle and need to sustain the changes. Thank you.
Thank you, sir.
As sir has said that teamwork is required to implement this. So all the NICUs, we have to give a role to each and every person, so that, and you said that this is a continuous process, so we have to monitor it in between and keep on changing, and the better outcome will automatically come. Thank you, sir, for giving such a nice talk.
Thank you so much.
Thank you, Dr. Devashish.
Thank you, sir.
Thank you, sir, and thank you all the chairpersons for such a nice talk. I will request all the chairperson speakers to please come for the memento distribution. I will request Shravan sir to please assist in the Dr. Bhavesh sir. Dr. Randeep, come here. Yeah, क्या करना है
इसमें जो है ना ये ऑनलाइन प्रेजेंट करेंगे रेडी साहब ये सब ऑनलाइन कहाँ गए
पूरा कर रही है ना, अनाउंस करिए तो वो ये हो जाए। कहाँ से? सुगंधा मैम।
Next, we have a online session from Delhi. Madam Sugandha Arya ma'am from Safdarjung Hospital will join us from the Delhi online lecture. I will request Dr. Siddharth Shankar Reddy to and Dr. Lalan Bharti sir to chair. Lalan sir, please. It's a request. Just join. Please start the online session.
It's an honor to be as a chairperson for this important session, which is being taken by none other than Sugandha Arya, very good friend of mine. She did her MBBS and MD from Lady Hardinge Medical College. Currently, she is Professor Pediatrics, Safdarjung Hospital, in charge of MNICU, working as faculty in newborn unit of Safdarjung Hospital for last 24 years, and she was the clinical investigator in WHO ICMR research project, including Danish study, immediate KMC trial, Action 3 trials, and authors of original article in national and international journal, and many chapters in many books. Just I have shared Sugandha's 2 slides, and she has worked a lot in that multi-center, multi-country IKMC and MNCU research work. So over to Dr. Sugandha.
Yeah, good evening. Am I audible?
Yes, audible.
My video is not visible. Is it visible?
No, your video is not coming. And also, you want to project your presentation?
Yes. I will
Please.
share the slides even if I don't know what is the problem. Otherwise, just see if my presentation comes. That should be enough.
Oh, okay, ma'am.
Is it visible now?
I think yes, it is visible.
And I'll make it full screen. Actually, I'm using this new computer for the first time. Probably the video is not downloaded. Okay, is it visible now? My slides are visible. That is important.
Yes.
Yeah. I'm sorry for this glitch. And first of all, I want to thank the organizers of the conference for giving me this opportunity of presenting at this conference and share my thoughts. And I'm sorry, apologies for not being able to make it possible physically. Yeah. So today I'm going to share with you, and my presentation is on mother newborn care units. What is the evidence available and how to operationalize a mother newborn care unit? Dr. Lalan Bharti, I was listening to his presentation. He has already set the stage for me that how this MNCU concept has come up with immediate KMC trial, but I'll just go into a little bit of more background to make it clear. This all you must have been hearing since morning, so I'll not waste much time on it, but just making a background that since we are all aiming at single digit neonatal mortality rate in India, so in order to achieve that, we have to look at the mortality of the low birth weight babies because they are contributing almost 70 to 80% of the neonatal deaths in the low middle income countries, including India. So if we look at this, even the next presentation I was hearing on quality improvement, and he rightly said that we have such good interventions that if the coverage reaches 80%, almost 3/4 of neonatal mortality is actually preventable by improving the coverage of these interventions. And if we look at the mortality in low birth weight babies, which are now attributing almost 35 to 38% of mortality now, we have very good interventions available in the form of antenatal steroids, kangaroo mother care and breastfeeding both go hand in hand, and CPAP. But unfortunately, our coverage is not enough to achieve that reduction in the mortality. So in 2015, as Dr. Lalan was also telling you, that in 2015, we all know, which we are presently using the KMC guidelines because they have changed just recently. The recommendations were that KMC should be initiated in the facility in babies below 2000 gram. Brief sessions of KMC to be initiated only when clinical condition begins to stabilize, and continuous KMC only when clinically stable. So using these guidelines, when the KMC was being given, Cochrane review showed that mortality reduces by 40% if you give KMC after stabilization. But if you look at the Cochrane review studies, 50% of preterms actually die in the first 24 hours, we all know, and 75 to 80% die in the first week. It means if we follow the 2015 guidelines, majority of preterm deaths actually occur before KMC can be initiated. So they never get KMC. So the research question which WHO took over, and then the IKMC trial and everything happened, I'll come to that. The question which came to the experts was that if continuous KMC is initiated immediately after birth without waiting for stabilization, as compared to the guidelines of that time, that is only after stabilization, can we save more babies by doing this, by starting KMC early? So with this research question, WHO took a multi-center trial, multi-country multi-center trial. It was a randomized control trial, so giving a very good, robust evidence we got from the trial. 5 hospitals or 5 countries actually participated in this trial, 4 from Africa, Ghana, Tanzania, Malawi, Nigeria, and India. Safdarjung Hospital was the site, participated in the IKMC trial. The population where the mothers and babies included were the mothers where the babies were born with a birth weight of 1 to 1.8 kg, and the intervention was KMC to be started soon after birth, within 2 hours, and then given continuously irrespective of sickness. But the control babies were given KMC as per the guidelines of that time, that is after stabilization. Both groups received WHO minimum package so that the other interventions are not compromised. So when we thought of giving immediate KMC, that KMC to be given immediately and continuously, so to operationalize that, I'm just giving you a background how MNCU was born, how this concept was born, and then how the evidence came up. And today we are standing in a stage of where we are operationalizing, and BIHAR, I'm very happy to share, which Dr. Siddharth will also tell, BIHAR is one of the states leading in operationalization of MNCUs. So coming back to the this trial, immediate KMC to operationalize, we had to achieve a zero separation, means the baby mother not to be separated irrespective of sickness. So how can we operationalize that, or how did we operationalize skin to skin at birth, which is a recommendation for all the babies, not even not only low birth weight, all the babies. However, for these babies, immediate KMC, then transplanted KMC position, And then mother and baby or baby and surrogate reach a place called mother newborn care unit where they can stay together for prolonged KMC. And finally, as we have KMC wards, these babies and mother diets will be shifted to KMC ward, just like you shift from NICU. So this is how the zero separation or IKMC was operationalized. Baby was delivered immediately after the birth, was put on skin to skin. After that, immediate KMC initiated and baby and mother transferred to MNCU in KMC position, even if the baby required CPAP, like in the middle of this. So this is how this MNCU concept came, and this is the picture of an MNCU which we created at the time of IKMC trial. It was a 12-bedded unit, and basically MNCU is nothing but a level 2 NICU, just like any other SNCU or level 2 NICU of a government of a tertiary hospital also. The additional part is only the presence of the mother 24/7, and rest it is a level 2 NICU where mother and baby stay together 24/7. And if you look at a single unit, actually in the previous slide, there are 12 units and you are seeing the back part of it, and each unit is separated by curtains. But if you look at a single unit, how a mother newborn care unit, a single unit looks like, because operationalization will happen in the same way. So each unit should have all the facilities of level 2 newborn care for the baby. So level 2 includes radiant warmer, CPAP, monitor, IV fluids, oxygen. And along with that, there is an adult bed with adjustable back support so that mother can stay there 24/7 and give prolonged KMC. And this MNCU we created at the time of trial with the hospital budget only, and that is what is happening during operationalization also for sustenance, and HR also recruited from the hospital itself. So evidence. So immediate KMC led to the birth of some unit called MNCU, because there was nothing rocket science in that. The intervention was keep mother baby together, baby is sick. Okay, so let us create a unit where mother can stay, and this is how MNCU came up. So the results when they came up, how MNCU works with immediate KMC, we found that if kangaroo mother care is initiated soon after birth in babies with birth weight 1 to 1.799, that is up to 1.8 kg, we found in the multicenter trial mortality is reduced by 25% in neonatal mortality in MNCU as compared to NICU, 35% less incidence of hypothermia, and 18% less suspected sepsis. I would like to have questions at the end, if any questions related to the trial as well as operationalization. But many people ask me at this point why we had hypothermia more in the NICU where we had radiant warmers. So this finding was not there from India side where we have radiant warmers in NICU. This finding came from actually African countries where in NICU they have less radiant warmers. So IKMC gave birth to something called MNCU. But once the MNCU came into existence and we started working in MNCU, we realized it is actually a different ecosystem. It is not simply just IKMC. The presence of mother provides a lot of other opportunities which have a lot of different mechanisms to reduce mortality. A lot of people, they argue with me that it's not the IKMC which has led to reduction in mortality. And we fully agree. The presence of mother offers a lot of other things besides IKMC, and all of them contribute to, so it is a package, the presence of mother, if you say, and it leads to different mechanisms of reduction. So first and foremost, definitely if you do zero separation of babies and their caregivers, prolonged effective KMC could happen. We could achieve 17 hours of KMC in IKMC trial. Early and exclusive breast milk feeding, because mother is there right from the beginning. So breast milk feeding rates are obviously very high, and they are definitely going to change the mortality and morbidity. Presence of mother is an ideal situation to provide family-centered, developmentally supportive care. She's the best person to do that. Mothers, by virtue of the presence, they also monitor the neonates, and they are better prepared for post-discharge care of the neonates. So actually when a mother baby died, who have stayed in MNCU, we hardly have to talk at the time of discharge. Mother is already trained, she has done everything herself. She has learned and then done herself. So you hardly needs to do any counseling at the time of discharge. They are ready. And when we talk to the mothers, and a lot of studies also done, and we found that these mothers have less anxiety and stress by staying with the babies inside MSU rather than being separated and visiting NICU intermittently. And parental satisfaction is much better. Mothers are, so therefore, not the visitors like our NICUs, they are the caregivers and stay inside. As far as evidence is there, so a lot of studies which have happened on KMC, and so WHO has created this model that what will happen if we scale up these interventions, how are we likely to impact the mortality. So presently, as we know, the current impact of KMC, the present coverage is 5 to 20% all over the world. And if 40% reduction we expect from Cochrane, and if we don't increase our coverage, we will save only 10,000 babies per year. If you see, WHO also did a scale-up implementation research, and it found that actually you can increase the KMC coverage up to 60 to 80% by implementing, by quality improvement especially. So 60% coverage if we do, we save 150,000. And if we do community-initiated KMC, means the babies who are born in community, low birth weight babies, and start KMC, community trial has shown 30% reduction. And with 80% coverage, we save 2,50,000. And if we add IKMC also, means KMC as a continuum, start as early as possible, prolonged as possible throughout the stay, and later on after discharge also, and home deliveries also. So if the entire spectrum is provided to 80% of the babies, we save 4 lakh neonates every year. Then effect of, there's a very important thing, when MSU came into existence, everybody was very worried. And not only at that time we were worried, even today, when people are stepping into this intervention or they are operationalizing MSU, the first thing comes, oh, in NICU, presence of mother will increase infections. This is an apprehension which is quite genuine to some extent. So, and we have been very obsessive right from years together for having the asepsis in the nurseries and then getting the mother inside 24/7. So there was a lot of apprehension. But actually, the trial showed the opposite of that. In IKMC trial, there was a lot of apprehension that the infection may pick up. So during the trial, lot of monitoring was done that if infections pick up, we terminate the trial. But actually, as the trial went on, we found that the babies who were staying with the mothers had less infections. And at the end of trial, actually the infections in MNCU were reduced by 18%. And then we did a post-hoc analysis, which was published in Lancet later on, post-hoc analysis of IKMC trial. And there were very interesting things which we found in this post-hoc analysis. Not only the infections were lesser in the MNCU group, rather the babies with infections had less mortality in MNCU group because of various reasons, more breastfeeding, better monitoring, early reporting by the mothers. And very interesting thing which we found, which may be responsible for less mortality, was the bacterial isolates were different in MNCU and conventional NICU. Probably some result of mother's microbiota. And what this trial showed us that actually immediate KMC can be an effective infection prevention control tool against MDRs. So as a result of this IKMC trial, I'm just building up you to the stage where we are today, how we have reached that stage that today we are operationalizing in India in different states MNCU. So after the trial, the moment trial was published in NEJM, WHO next year in 2021 it was published, and next year, looking at such a robust evidence, WHO changed the KMC guidelines. But guidelines I showed you before trial was 2015, and 2022 the new guidelines have come up by WHO, in which there are 4 big changes. Earlier, KMC was advised for or recommended for babies less than 2 kg. Now it is recommended for all preterm less than 37 weeks and all low birth weight babies, that is less than 2.5. Earlier, it was a recommendation start KMC after baby starts stabilizing. Now, recommendation is start KMC without waiting for stability. But for that, we need to create mother newborn care units because unstable baby cannot stay in the KMC ward or postnatal ward. And after the discharge, home KMC to be continued. And KMC duration should be as much as possible, but to be effective, it should be at least 8 hours every 24 hours. So with this, we have reached the stage WHO. After the WHO gave the guidelines, now in FBNC operational guidelines, we have taken up the MNCU guidelines, and right now there's a task force going on at Ministry of Health who are going to give recommendations how to operationalize MNCU in India. I'm telling you the guidelines from that reference only. That operational guidelines will tell you how to, if today you wish to start an MNCU in a particular hospital, how do you organize your HR, how do you organize your infrastructure and all. So coming to the space for each newborn, so in NICU, as we know the FBNC operational guidelines, we need 100 square feet per bed for the newborn area, especially if CPAP and CPAP is there. And general support 50 square feet for now. Since the mother is there, so you need to have additional 100 square feet per bed for the mother's bed. So now for each baby mother diet, you need 250 square feet. So we can calculate accordingly how much space to be required if we are operationalizing MNCU. The ancillary and support services for the newborn will be the same as in any SNCU or NICU, gowning area at the entrance, clean area for preparation of IV fluids, medicines, counseling area. They are in any NICU, they will be in MNCU. But the additional ones will be that for mothers, we need to have washrooms and bathing areas since they are going to stay, dining area or the pantry for mother's food, and mother's examination area if obstetricians wish to examine the mother on the table. Otherwise, she can be examined on the bed itself in MNCU area. So we have created some of the designs which Government of India is also going to provide in the operational guidelines, that how this area can be divided into these ancillary services as well as the mother-baby diets. There are certain designs have been prepared in rectangular form and L-shaped form, but actually it will depend on whatever space you have. You will have to see how you accommodate all these requirements. Then there is a lot of controversy, or you can say I'll not say controversy, confusion among the states as well as in the ministry. There are a lot of terminologies coming up: mother NICU, mother newborn care unit. So and there was some other terminology in 2018 of mother newborn care unit, which was actually for only the stable babies, which are already functional since 2018. So there is a lot of confusion that what are we looking at MNCU when the Government of India is saying operationalize MNCU. So I thought I'll take this opportunity to make it very clear from the Government of India perspective is that Government of India is saying to create level 2 mother newborn care units. One thing they have done is they have removed all the terminologies now. Mother SNCU was terminology being used in, I think, UP. BIHAR, I have seen some places, the terminology being used as neonatal HDU, if I'm correct. Neonatal HDU, the terminology for 2018 thing. So now all the terminologies, Government of India is advising that use a single terminology of mother newborn care unit, which is a level 2 nursery like any other SNCU. And some people have this notion that this MNCU is only for the stable babies. Then the whole purpose is gone of making MNCU. So MNCU is nothing but an SNCU, any other SNCU or level 2 newborn care unit along with presence of mother. That is why I have created these slides, and I have just copied from the operational guidelines of FBNC for SNCU. So indications of admission in MNCU are exactly same as SNCU because MNCU is a level 2 newborn unit. So we need to provide CPAP and less than 34 weeks babies and birth weight less than 1800 grams and respiratory distress babies will be admitted like any other SNCU or level 2 newborn unit. Services to be provided are again same as you provide in your SNCUs right now or in your level 2 NICUs. And we know that level 2 SNCUs are supposed to provide CPAP services along with the breastfeeding support, assisted feeding, and care of a sick newborn as per FBNC guidelines. Equipment, again, many people ask me, when you want to operationalize MNCU, what are the equipments I should order, or what are the equipments I should arrange? So let me clarify that the infrastructure of MNCU is absolutely same as SNCU. The only thing extra is mother's bed, and therefore you need extra space for mother's bed. Among the equipment, again, the equipment is absolutely same as SNCU. The additional equipment is only reclining KMC chairs and mother's bed. That's all. And KMC garments. Otherwise, all the other equipment should be copy-paste from SNCU guidelines. Only additional mother's bed, reclining, and KMC chairs and KMC garments. But what is the new thing in MNCU? Since this mother is staying with us who has just delivered few hours back, so services of mothers is something new we need to create in MNCU. She is now the addition in this unit. And since these mothers have just delivered few hours back, we need to provide comprehensive postnatal care, including for cesarean section mothers. Hygiene facilities, she's going to stay 24/7 inside. So we need to have all the facilities of daily care, washrooms, bathing areas with geysers and hand washing stations, just like health staff also. Since mothers are staying with the babies, we need to counsel them how to take care of their newborns, breastfeeding, their emotional well-being and discharge preparedness, and other support facilities regarding their food, dining area, etc.
So, Dr. Sugandha,
So
just wind up. Dr.
Yeah.
Sugandha, kindly wind up.
Yeah. I'll just, I think I'll speed up and finish. I think 2 or 3 slides only left. So facilities, these are the additional ones, and transfer of mothers in MNCU, we can discuss separately when, since the mothers need to provide KMC. So vaginal delivery, obstetricians will usually send mothers after 2 to 4 hours, in cesarean 8 to 12 hours, and till mother is not available, surrogate should be providing the KMC. And providing postnatal care to the mothers in MNCU, as I told, that it is for neonatal nurses are trained into this, and obstetricians make daily rounds for that. This kind of care we call couplet care. And discharge criteria, again same. So just, I think last slide, second last slide. So positioning MNCU in newborn care program in India, as I told you, WHO guidelines have been changed. After WHO guidelines, INAP has been updated, National FBNC operational guidelines have been updated. And now what we are going on right now is professional bodies, all healthcare providers and program managers to be sensitized. And since it was I was supposed to tell you the new evidence, and in Safdarjung Hospital we have replicated this model into a 40-bedded tertiary level MNCU for the outborn babies, although Government of India is presently recommending MNCU at least for level 2 newborn care units. Thank you. I'm sorry if I have gone over the time.
Thank you, Dr. Sugandha, for explaining details about the study design, then outcome and MNCU. I'm happy to see, I was just discussing with Dr. Reddy that this MNCU has been implemented in 4 or 5 SNCU and also in this NBSU. I think Bihar is the first state where NBSU has also established MNCU, right? So this KMC is the low cost, high impact intervention, has definite benefit in the mortality, as you said, around 40% improvement in the neonatal mortality, but that was in the stable baby. And your study has shown that the further 25% decrease in the neonatal mortality, the incidence of the infection is also decreased. So this is the need of the hour, and Government of India has also endorsed it, and many states has already started just modifying the existing SNCU into the MNICU. But now this is not the MNICU, the name is now MNCU across the country. Yeah. And many private hospital has also started, if I'm right, this Amrita Hospital.
Amrita Hospital, Faridabad, and in Gujarat, Dr. Ashish is there.
Ashish.
He has started MNCU in a private sector.
Yeah, started. So all the members who can do it, they can start this MNCU. There are a lot of benefit, but we should not forget to increase the this thing KMC fast, because I was saying the data still the KMC is 20% only. So we have to start KMC, and then gradually we should promote this MNICU, MNCU and IKMC.
Thank you, Dr. Sugandha, for championing MNCU, IKMC and also zero separation guideline in the country. And also I would like to thank you for supporting BIHAR, specifically you and Dr. Harish Chalani sir for operationalizing MNCU. And we are glad that so far we have established around 5 MNCUs at the district hospital level and medical college level, and 15 MNCUs at the sub-regional hospital level. And thank you for the last visit by your Safdarjung team and also Dr. Harish Chalani to Gaya for orientation of a few of the MNCUs. So we are also looking forward for further support from Safdarjung Hospital and from you. And also today I was discussing with NNF how to take this forward in the operational MNCU in BIHAR. And I am also glad to say that AIMS PATNA is also supporting us for operationalizing MNCU, and also local NRF is also supporting. So together we can also achieve a lot, and I am looking forward to see a very good visible change in BIHAR. Thank you very much.
Thank you. Thank you for giving this opportunity.
NNF would be happy to partner for hand-holding and mentoring this MNCU wherever they are, because you have already established in many of the NBCU, right? So if you would like this thing, NNF member can definitely support this center.
Dr. Om Prakash, you want to say something?
We think that this is a new concept. In the morning, I was discussing with Dr. Saugata Chaudhary, and he told me Swami Vivekananda came with this concept when we came from America, and he termed same things, mother neonate duo. He went and learned from the local dyes how to deliver, and in his whole hospital concept, he integrated the mother and neonatal care in a single room. We can have the literature, and we have evidence that this is a concept which was proclaimed in the ancient India, and our Vivekananda, who was died in the age of 32 years, promoted this concept. So this is very feasible, and as we can promote in our government setup, community setup, we also ask for our corporate hospitals and the newer establishment to go with this MNC concept, because एक दिन माँ के पेट में था, अगले दिन कोई दूसरा लेके उसको ले जाए, न मदर को अच्छा लगता न बच्चे को. So the duo should be go together. So this is a very nice concept, and I support very well. Thank you.
Thank you, sir. Thank you, everyone. Thank you, Sugandha ma'am from Patna. Very nice talk about the MNCU and KMC. So by this, we come to the end of the first day scientific session. I thank you all with the support, such a nice support in the whole session. We will break for half an hour, and then we'll start the inaugural session by 6 o'clock. Ma'am is there? By 6 o'clock, we will start the inaugural session. I request all the participants. Thank you, ma'am, from the Patna. And thank you to Reddy sir and all the Lalan Bharti sir for participating in such a nice talk. So we will break for half an hour and we will start inaugural session by 6 o'clock. I request all the guests, all the esteemed members, all the outside faculty to please be here for the inaugural session. And thank you.
Hello, check. Hello, check. Hello. Hello, check. Hello.
So, a very warm good evening to all. On behalf of the organizing committee of ISO Neocon, 6th ISO Neocon and BIHAR Neocon, I welcome all dignitaries, distinguished guests, and all delegates to this conference. The theme, Nurturing New Lives and Shaping the Future. This finds deep roots in the legacy of Bihar. Bihar, a land that has for centuries nurtured wisdom, resilience, and transformation. A place where new ideas, new dreams, and a new journey begins. From the banks of Ganga, where civilization started, to Nalanda and Vikramshila University, where minds were illuminated with knowledge, and Bodh Gaya, where the journey of compassion began. This land is a living example of how nurture shapes the destiny of generations. If you flip back the pages of history, you will see that what I have been talking has its roots in Bihar itself. So today, we continue this heritage by shaping new lives, by nurturing care with care, education, and vision, which is at the very center of this conglomeration of visionaries and all NNF people. So with this, let us join our goals and work for the betterment of all neonates of East Zone and Bihar, and I'm sure the knowledge will be percolated further. So with this, let us begin by welcoming our dignitaries to the dais, and we are very privileged and proud to welcome the entire Central NNF team to Bihar. Let us begin with a huge round of applause as we invite our chief guest, Dr. V.C. Manoj sir, the President of NNF, to grace the dais. Okay, with permission of sir, Dr. V.C. Manoj sir, he is on his way, so we will begin with the ceremonies and sir will join. My privilege to extend a warm welcome to Ms. Margaret Gowda ma'am, Madam Gowda, who's the Chief of UNICEF Bihar. May you please grace the dais, ma'am. Madam Gowda has been in the service of children and dedicated herself with over 27 years of her life. She has been with UNICEF since 2009, and she has headed Kenya and even Madhya Pradesh, Bhopal. Madam has been very supportive of all the activities that we have in Bihar, be it IAP, be it NNF. We always find her as a pillar of youth support, skilled in building partnerships across all sectors. Madam has served the pediatric and neonatal fraternity, for which we are thankful to you, ma'am. So, V.C. Manoj sir, I extend a warm welcome to you, our President of NNF. Sir, an acclaimed academician, is an FRC CPCH from UK, and he also takes keen interest in lifestyle medicine and sports nutrition. Having retired from Indian Navy as Lieutenant Commander, that is very evident in his gesture of allowing us to begin the ceremonies. So I welcome you, sir. Our co-guest of honor, Dr. Lalan Bharti sir, is a son of the soil. It's my proud privilege to welcome Lalan Bharti sir, who has been my senior in post-graduation days in PMCH. The journey which sir has carved for himself from PMCH to the dais that he occupies here today as President-elect has been a mark of the labor and the toil he has put in. almost all the posts of NNF, treasurer, secretary, and the other posts of IAP from Delhi have also been occupied by him. He is an ardent teacher and has done so many of NRP trainings and all the other programs. I welcome you, Lalan sir, back again to Patna. We are blessed to have with us the presence of Vice President NNF, Dr. Dinesh Tomar sir. Sir, please grace the dais. Sir has been former Secretary General of NNF and he hails from Rohtak. I welcome you, sir. To complete the team from Central NNF, again I must add that we are really thankful to Central NNF for showering so much blessings on this East Zone. I would like to welcome Dr. Ravi Sachan sir, who comes from Delhi. Sir is Professor and HOD of GTB Hospital and UCMS. And stepping into Patna, he's taken the role by guiding us in places where we might have faltered. So thank you so much to Dr. Ravi Sachan sir. My privilege, I made a small mistake. I had to welcome Secretary General Dr. Amit Upadhyay sir. Oh, sir is there. I'm sorry, sir. So, sir is Secretary General of NNF and he is also the director of the hospital at Meerut. Sir, a DM from AIIMS Hospital is always there lending us support. Even he's just a phone call away for any inquiries serving the purpose of secretary. So I welcome you, sir. That completes the central team and now we move forward to the organizing chairperson, Dr. Vinod Kumar Singh sir, who is ex-HOD, NMCH and Superintendent NMCH. Sir is a living example of rock-like strength and commitment and trustworthiness when it comes to shouldering responsibilities. It is very evident by his act going through a personal rough patch in his life. He stands to be with us and shoulder the responsibility of organizing chairperson. I thank you for that, sir. And sir again has shouldered almost all the responsibilities of all the posts in Bihar, be it IAP and NNF. Currently, he is helping us as academic coordinator of IAP as well. I would like to mention about A.K. Jaiswal sir, Professor Dr. A.K. Jaiswal sir, who could not be present with us today due to inadvertent situations. He is overseas, but his blessings have always been felt by us throughout this journey. With that, I move on to invite Chairman Reception Committee, Dr. S.A. Krishna sir. Dr. S.A. Krishna sir, a very senior pediatrician for us, is always standing as a huge pillar of support and guides us all through. Sir is served as Vice President and President of East Zone Academy of Pediatrics, and he is still very, very active in all the social platforms, spreading the light of taking care of pediatrics and newborn at the grassroots level. I welcome you, sir. Now I would like to welcome Co-Chairperson Reception Committee, Dr. Nigam Prakash Narayan, sir. Sir, a rare blend of academic excellence and exceptional leadership qualities has graced the post of Vice President East Zone in IAP and the President-elect of IAP Bihar presently. President and Secretary Bihar NNF and governing body member of NNF, I welcome you, sir. My proud privilege to welcome President NNF, Dr. V.C. Manoj sir. Thank you so much, sir, for giving us the permission to begin with the ceremonies so as to save time. Sir has his background in Indian Navy. He has served as Lieutenant Commander, and that is evident with the discipline he follows. There should be no delay in starting any program. So let us welcome the President NNF with a huge round of applause. Now, I would like to welcome the President NNF BIHAR, Dr. Om Prakash sir. Dr. Om Prakash sir is the President NNF currently and a very, very active member of our fraternity. He is the pioneer of SNCUs in Bihar, presently consultant of Rajgopal Healthcare Center in Darbhanga. Sir is the principal investigator of ICMR as well. I welcome you, sir. To welcome the Chairman Reception Committee, I am honored to welcome Dr. Professor Alka Singh ma'am. Ma'am has served as Superintendent NMCH and HOD NMCH. Currently, she is gracing the post of IAP Respiratory Chapter President, and she is much loved by her students, me being one of them. I have the honor of studying from ma'am since my graduation, post-graduation days. I welcome you, ma'am. Chairperson, Reception Committee, Dr. Professor Bhupendra Narayan sir. Sir is well known and currently heading the Chairman Scientific Committee, sir, Dr. Bhupendra Narayan sir. I remember when we make mistakes, even till this time, sir is the one who can really shout out and say, "Kya ye tum galat bol raha hai." So, I welcome you, sir. Sir is Chairman Scientific Committee, and he is heading the very prestigious Patna Medical College Hospital. And sir also very instrumental and very encouraging to all his juniors. I welcome you, sir. Now the time has come to invite the two people who have toiled day and night to make this conference a success with inputs from all of us and with the help of the organizing chairpersons. I would like to welcome Dr. Shravan Kumar sir, organizing secretary. Sir, his looks defy his age. So, sir is a very, very dynamic person, and he is having approximately 4 decades of roaring practice as a neonatologist in Bihar. He is also the accreditor of NNF and had graced the position of President IAP Bihar. I welcome you, sir. With sir, we have Dr. Bhavesh Khan Chaudhary, a very young but a very promising secretary who is the HOD of AIMS Patna. Dr. Bhavesh is also very active and he is very humble, I must say, heading such a prestigious department also. No one has ever felt that he is talking to one organizing secretary of ISO Neocon. I welcome you, Dr. Bhavesh, to this platform. So with this, the dignitaries on the dais, we now move on to the ceremonial presentation as a token of our respect and gratitude, our warmth and hospitality, which is a landmark of Bihar. So just to complete the hospitalities, may I request Dr. Chandan to please step on the dais and assist Dr. Saloni in presenting a plant to our chief guest with the honors. A plant, chief guest, a plant is akin to a neonate. It leads with hope and freshness and the period of growth, which is akin to a newborn. to present the plant to our guest of honor, Madam Margaret Gorda from UNICEF. To honor our President-elect, may I request Organizing Secretary Dr. Shravan sir to step from the front and present a token of our gratitude, and I must add love to our own person, Dr. Lalan Bharti sir. So this is a moment of great nostalgia. I'm transported back to time where during the PG days, we would just move behind him, Lalan boss kuch pada dijiye. So now he's in a position where he can really do that. Thank you, sir. May I request Shravan sir to please honor our Vice President, sir. Thank you, sir. And to honor Secretary NNF, sir, Dr. Amit Upadhyay. Shravan, sir. Dr. Bhavesh, please join in from here. To honor Dr. Sachand, sir, Treasurer NNF. I hope the central team carries back good memories of the conference and this inaugural ceremony. May I request Shravan sir and Dr. Bhavesh sir, please honor organizing chairperson Dr. Vinod Kumar Singh sir. It is really a warm moment for us to see Vinod sir here. We were really in a dilemma whether sir would be able to make it or not. So thank you so much, sir. To honor S.A. Krishna, sir, Chairman Reception Committee. Dr. Nigam Prakash, sir, who stands as a youth support system for all of us. Whether he is there, whether he is involved or not involved, it really doesn't matter. He's just a phone call away for all of us. Shravan sir, to honor President NNF Bihar, this conference is ESO Neocon 6th and Bihar Neocon 2025. So Dr. Om Prakash sir, who's currently the President of NNF Bihar. A huge round of applause as we honor the President NNF Bihar. Chairman Reception Committee, Dr. Alka ma'am, to be Chairman Scientific Committee, Dr. Alka Singh ma'am, to be honored by Shravan sir. Om Prakash sir, President NNF. May I request Dr. Bhavesh? Come, Devi. Now I request Shravan sir and Dr. Bhavesh to present a bouquet to Dr. Bhupendra Narayan sir, Chairman Reception Committee. Chairman Scientific Committee. I don't know why this reception committee comes to me, because I think all of them are working in all the capacities. So there is really no demarcation between scientific and reception. I know it's a mistake, but that is why I'm probably doing it. So, बैठेंगे सब अब दिलो. May I request Dr. Chandan to please step in to honor our organizing secretary, Dr. Shravan Kumar sir. Please take the help of Central NNF President. Move a little further. Sir, please move a little further. Stand with the President. Dr. Bhavesh, please join Shravan sir. Dr. Chandan, please assist in presenting a plant over here at the center to the second organizing secretary, two dynamic people belonging to two different generations, but they have gelled so well. So with this, we complete presenting our respect, our gratitude, our hospitality, and our love to all the people on the dais. There are still a lot many senior people and people who are behind every activity off stage. So my respect and gratitude to each one of you for making this program a success. So with this, I would like to invite Chairman Organizing Committee, Dr. Professor Vinod Kumar Singh sir, to give his welcome address. I welcome you, sir.
Thank you, Dr. Rasmi, for inviting me to welcome the delegates and our chief guest. To begin with, I must pay my sincere regards and thanks to our National President, Dr. V.C. Manoj sir, for giving his precious time to our state, who is growing very fastly in the field of neonatology. And a lot of thanks from the core of our heart for getting you here at the land of Patna. And our guest of honor, Dr. Margaret, this is a privilege to find you here. You have been helping our state a lot so far as the child health is concerned, and this is great to see you here. Our another guest of honor, Dr. Lalan Bharati sir. He is the son of this soil, and I always feel proud when we see him at the top at the National Neonatology Forum level. So this is, you are a pride child of this soil, and we all feel great out of you. So thank you a lot for getting you here and just helping us in different ways. We had used to discuss with him how to go through this conference. Our National Vice President, who has given his precious time, Dr. Sachan sir, Dinesh Tomar, yes, sir is the National Vice President who is here, and this is our privilege to see him here. Our Treasurer, yes, Dr. Ravi Sachan, so this is great, and we welcome you all on this occasion of this conference of East Zone NNF. The other dignitaries on the dais, our teachers, Professor N.P. Narayan sir, Professor S.A. Krishna sir, the Chairman Scientific Committee, Professor Alka Singh ma'am, Dr. Bhupendra Narayan sir, our National State President of NNF, Dr. Om Prakash sir, and the organizing secretaries, Dr. Shravan sir and Dr. Bhavesh Kant. So a lot of thanks and warm welcome on this occasion of this East Zone NNF conference, and other dignitaries of the dais, Professor Bijay Jain sir, our IAP President, Dr. Dr. Shiv Bachchan sir, our EV member, Dr. Golwara sir, another dignitaries of the dais, Dr. Rizwan. So we welcome you on this occasion with our folded hands and warm heart. And this is great that you all have gathered here to participate in this conference. With these words, I stop, and I think there are many more people who will say their feelings in few words. So thank you so much for coming and participating in this conference. And I think that we will deliver the best out of us so that this conference could be a great success with your help, your cooperation, and your blessings. So thank you.
Thank you so much, sir, for your encouraging words. To dispel darkness and ignite the path of knowledge, let us illuminate and inaugurate this beautiful event together. I request all dignitaries, our chief guest, Dr. V.C. Manoj sir, with the guest of honors, Madam Margaret Gowda, and President-elect Dr. Lalan Bharti sir, Secretary NNF, Vice President NNF, Treasurer NNF, our reception committee people, all to please ignite the lamp and spread the flame of wisdom. As each flame joins the other, light grows brighter, just as our collective efforts will brighten the future of neonates of East Zone and Bihar. Let us have the music, please. The Ganesh Vandana.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
As each flame joins the other, the light grows brighter. So is the concept of these conferences, where knowledge unites, wisdom grows, and we are able to make a difference at the grassroots level. With this, the Shanknath, it's already a sign of victory. The first day over, we move on to the next day, and with this, we illuminate the path of wisdom and inaugurate the 6th East Zone and Bihar Neocon 2025. Thank you so much to the galaxy on the dais. please have a seat. With this, I would like to call upon Chairman Reception Committee, Dr. S.A. Krishna sir, to address the gathering.
बहुत बहुत धन्यवाद डॉक्टर रश्मि. The dignitaries on the dais and off the dais, you all are welcome on the land of Patliputra. We have gathered here for the 6th East Zonal Neonatology Conference as well as the BIHAR Neonatology Conference. जीवन की शुरुआत नवजात शिशु से होती है. उसके पहले भी होती है, लेकिन नवजात शिशु से हम लोग बात करेंगे. और ये नवजात शिशु हमारे देश के भविष्य हैं. ये पूंजी हैं. ये जितना ज़्यादा दिमागी तौर पर और शारीरिक तौर पर मजबूत रहेंगे, सुदृढ़ रहेंगे, हमारा देश उतना ही मजबूत होगा. इन्हीं चंद शब्दों के साथ, क्योंकि मुझे आदेश दिया गया है कि 2 शब्द से ज़्यादा नहीं बोलें, रश्मि जी को मैं फिर से धन्यवाद देता हूं, पूरी ऑर्गेनाइजिंग टीम को धन्यवाद देता हूं, बाहर से आए हुए सब लोगों का मैं धन्यवाद देता हूं, खास करके सेंट्रल ऑफिस से जो लोग आए हैं उनका भी मैं बहुत बहुत धन्यवाद देता हूं. बहुत बहुत धन्यवाद. थैंक यू.
Thank you so much, sir. Our Chairperson Reception Committee, Nigam sir, please address the gathering.
Thank you, Rashmi. Because we are really having very dearth of time, respected chief guest of this function, Dr. V.C. Manoj, President Central NNF, guest of honors, Dr. Madam Margaret Gowda, Chief of this Bihar Jharkhand office of UNICEF, and Dr. Lalan Bharti, who is the President-elect, and all the important teachers, and there are all the office bearers of NNF. They are here to bless us. It will be difficult to name each one of you to waste time. I'll just cut short because we have been asked to end up in just 2 minutes. I think it's a matter of great pleasure that this is Bihar. As Bihar actually is a sheet anchor of knowledge, religion, mathematics, astronomy, and whatnot. And mind you that though we are called that Bihar is one of the, not that developed state, but our parameters, SRS 23, they say you that our parameters are better than the national average. In both, you see, the infant mortality and the neonatal mortality. So we are no less than anybody, and moreover, we have got a very good way of reception, and I'm as chairman of reception committee. I welcome you all, and I wish that everybody of you should really gain the best of knowledge by these important faculties. Yesterday we had a very good workshop, 3 workshops, and they went so well. You see, we went to inaugurate at each venue, and they were real success. And I'm sure that today's deliberations also, you must have taken it very, very, ably and efficiently. And all the subjects were of great interest. Thank you very much for inviting me as a reception chairperson. Thank you.
Thank you so much, sir, and more so for maintaining the time. May I request President NNF Bihar, Dr. Om Prakash, sir, to address the gathering. We have a very good program waiting, so that is the reason why we were not able to have more time for the speakers.
मंच पर उपस्थित और सभागार में जितने भी हमारे शिक्षक और वरिष्ठ जन उपस्थित हैं और सारे विद्वत जनों को मेरा नमस्कार। मैं इसे आभार प्रकट करने के लिए इस्तेमाल करना चाहूँगा। हमारे नवजात शिशुओं के लिए हमें सबसे ज़्यादा सहयोग शुरू से सेंट्रल एनएनएफ का तो था ही था, यूनिसेफ का मिला। हमने बिहार में जो एसएनसीयू मूवमेंट और बेसिक एनआरपी का जो मूवमेंट शुरू किया, हमारे यहाँ जो एनएनएफ के लोग थे उन्होंने लोगों ने नहीं किया। घनश्याम शेट्टी हुए, अभी एसएस रेड्डी सभागार में बैठे हुए हैं। उस समय में मेरे साथ अनुपमा थी, राकेश थे, इन सारे लोगों ने, और उसके भी पहले से तो इन्होंने हमें न सिर्फ फंडिंग दिया बल्कि ट्रेनिंग के लिए भी किया। और जब इनैप 2014 में आया, उसके पहले हमारे माननीय मुख्यमंत्री जी ने 2010 में ईयर ऑफ न्यूबॉर्न डिक्लेयर किया था। हम लोगों ने, उत्पल कांत जी अब नहीं हैं और हमारे कई वरिष्ठ लोग नहीं हैं, उन लोगों ने मिलकर हम लोगों ने 2010 में रोड मैप ऑफ न्यूबॉर्न ऑफ बिहार तैयार किया था। और वैशाली में यूनिसेफ ने सबसे पहला एसएनसीयू तैयार किया। आज वो लोग उससे बहुत आगे बढ़ के एमएनसी ऊपर चले आए हैं। और दरभंगा मेडिकल कॉलेज में हमने सबसे पहला किसी भी मेडिकल कॉलेज में एसएनसीयू तैयार किया, और जिसे बिहार सरकार ने बाकी सारे 36 जिलों में इसको ले गए। मैंने दरभंगा मेडिकल कॉलेज में एक टीम स्थापना की, जिसके द्वारा मेरे सहयोगी रिजवान हैदर मौजूद हैं, उन्हें सारी बात याद होगी। हम लोगों ने आधे बिहार को 18 जिलों को ट्रेन किया और ये मूवमेंट आगे बढ़ते चला गया। मुझे इस बात का बहुत गर्व है कि ललन भारती जी ने एक तरह से हट के सहयोग किया। यहाँ पर जितने बैठे हुए हैं, मैं वीसी मनोज साहब को बहुत कम धन्यवाद दूंगा, उनसे बहुत ज़्यादा एसोसिएशन नहीं रहा, लेकिन जितने लोग हैं, सचिन जी हैं, तोमर जी हों, सब लोगों ने 2000, सुषमा नांगिया थी, उस समय के जो कलावती शरण की टीम थी, उस समय ये गंगाराम की टीम थी, सारे लोगों ने। और मैं उड़ीसा का, बंगाल का तहे दिल से धन्यवाद करता हूँ, दिल्ली का, बल्कि यूपी का भी। वहाँ के लोगों ने जब हमारे पास नहीं थे संख्या बल में, तो उन लोगों ने मुझे मदद दी। तो मैं सारे देश के सारे नवजात शिशु रोग विशेषज्ञों का धन्यवाद करता हूँ। और आज की हमारी जो पहल थी, उसमें सबसे ज़्यादा इम्पोर्टेंट था लो कॉस्ट इंटरवेंशंस, जिन्होंने उन्हें 11 पॉइंट्स दिए। मैंने 2 और जोड़ने के लिए कहा, जिसमें कि फैमिली सपोर्ट की भी बात हुई थी। तो मैं सभी का धन्यवाद करता हूँ। और अभी इस प्रोग्राम के लिए भवेश कांत जी ने और हमारे सरवन जी ने, जो मेरे सीनियर रहे थे, जितनी मेहनत की, और जो गाइडेंस हमारे विनोद जी ने दिया, निगम प्रकाश जी ने दिया, जायसवाल जी तो अभी नहीं है लेकिन उनका भी रहा, सारे, और हमारे परम गुरु डॉक्टर एस ए कृष्णा सर, गोलवाला सर, सारे लोगों ने, शिवचंद सर, जो उन्होंने हमें गाइडेंस दिया, आज हम कह सकते हैं कि हम पूरे देश में किसी भी दूसरे राज्यों की तुलना में, भले सांख्यिकी बल में हम लोग कम हैं, भले ही हमारा अभी भी स्ट्रेंथ उतना नहीं है, केरला से हम बहुत पीछे हैं नवजात शिशु, लेकिन तब भी राष्ट्रीय जो एवरेज है उससे हम नीचे जा चुके हैं। और इसके लिए हमने बहुत लंबी लड़ाई लड़ी है। हम लोग करके दिखाएंगे, हम लोग सिंगल डिजिट में ज़रूर लाएंगे। एनएनएफ प्रतिबद्ध है, और ललन भारती जी के सहयोग से मैंने मुहिम चलाई है एनएनएफ के मेंबरशिप बढ़ाने के लिए। पिछले 1 महीने में काफ़ी नए मेंबर जुड़े हैं, और आप सबों से आग्रह है जो एनएनएफ के मेंबर नहीं हैं, हम लोग ड्राइव चला रहे हैं, अधिक से अधिक लोग नियोनेट्स के सर्विस के लिए मेन स्ट्रीम एनएनएफ के मेंबर बने। तो मैं सभी का तहे दिल से धन्यवाद करता हूं, जिन्होंने बिहार को चुना इस जो नियोकॉन के लिए, और इसे इतना सक्सेसफुल बनाया। सबका धन्यवाद।
Thank you so much, sir. We now move on to the souvenir, the opening of the souvenir in the hands of the August gathering. May I request Dr. Chandan Singh. Dr. Chandan Singh was not directly on the editorial board, but his presence can never be undermined, because in all the activities we found him. So I invite myself most humbly, Dr. Rashmi Agarwal, the chief editor, and Dr. Chandan Singh to please help in the opening of this souvenir. The souvenirs are in the bag. The registration kit that you've received would be carrying a souvenir, but in case you don't find it, please connect to us. So with that, we move on to the address by the national team. With pleasure and proud privilege, welcome you to the land of Bihar. I invite Dr. Amit Upadhyay, sir, Secretary NNF, to say a few words.
Good evening, everybody. It's really wonderful to be over here in this East Zone Neocon, being organized by PATNA NNF team, BIHAR NNF team, and in Patna, a very historic city. I have a personal bonding with Patna. My half of the family side comes from Patna itself, and Bihar. So it's a personal pilgrimage for me to come to Patna and meet my seniors over here. Organization of NNF is growing fast and rapidly, and as you know, an office bearer in NNF, I would request all of the Bihar pediatricians who have even little interest in neonatology to please join NNF. We are a 10,000 plus organization now, but we need much more because most of the pediatricians do practice neonatology, and NNF offers its members expertise in training every level of neonatology which we are doing, from office practice to level 1 SNCUs to level 2 SNCUs and also level 3A and 3B NICUs. So we should all pledge on this East Zone Neocon to become a member of NNF, and our President and President-elect have announced that special discount of 2,500 to be given to all people who become member today and tomorrow at a concessional rate of 7,500. Normal rates are 10,000. So you can just even give your names that, okay, I want to become a member, and you would be paying soon, and you can pay later as well. So because the drive was only for the first week of October, but we can extend it over here for these 2 days. So I wish all the best to the organizing team for the workshop which was conducted for QRNP, which is part of our NNF Presidential Action Plan, and led by Dr. VC Manoj sir. And thank you very much for inviting us and having this wonderful academic feast. Thank you.
Thank you so much, sir. It was really nice to know that you also have roots in Bihar. So that strengthens us. Now may I request President-elect Dr. Lalan Bharti, sir, who hails from PMCH Patna, to please address all of us, but in the capacity of President-elect this time.
Thank you, Dr. Rasmi. Rasmi was just junior to me during the PG time. Respected chief guest, my friend Dr. Manoj, Margaret, other guests of honor, my teachers, Dr. Nigam Prakash Narayan sir, Dr. Binod sir, Dr. Alka ma'am, Dr. S.A. Krishna sir, my dynamic secretary, Dr. Amit. He is very tough कि पैसा खर्च करने में, but since his connection is with Bihar, और आज हमारे साथ बैठ करके जब हमने बात किया तो बोला जब हम लोग यहाँ हैं तो कुछ ना कुछ करना पड़ेगा. So you announced only one thing. One more thing here we have decided कि जो Neocon का रजिस्ट्रेशन है वो भी हम आज 7,000 में 2 दिन के लिए इस कॉन्फ्रेंस में करने जा रहे हैं. So dignitaries on and off the dais, dear friends, Namaskar, Pranam, warm greeting from National Neonatology Forum of India. Being from Bihar, completed my MBBS and MD from here. It's a moment of great honor and personal pleasure and honor for me to be guest of honor here in the East Zone Neocon. In fact, this Neocon, zonal Neocon, was conceptualized by Dr. V.P. Goswami when I was the secretary of NNF in 2019. कोविड के पहले ये शुरू हुआ था और इसका एम यही था कि सारे लोग नेशनल कॉन्फ्रेंस में नहीं जा पाते हैं, सो ये होना चाहिए. बट सिंस अब इतने ज़्यादा कॉन्फ्रेंस हो रहे हैं, प्रॉब्लम तो आ ही रहा है, बट नेक्स्ट ईयर वी विल बी प्लानिंग समथिंग. ऐसा करेंगे. वी वर जस्ट डिस्कसिंग विद आवर सेक्रेटरी डॉक्टर अमित कि ये क्लस्टरिंग नहीं हो, सो विल प्लान इन दैट मैनर. सो एट द आउटसेट I extend my heartfelt thanks for the organizer, Shravan boss, Binod sir, and Dr. Bhavesh, whom I know since 10 years when he was doing DNRB in Chennai, for their kind invitation and warm hospitality. I also congratulate the entire team for planning and delivering this conference in a very impressive and impactful manner. From venue to hospitality, menu, and all were exceptionally planned and executed. The energy in this hall reflects your teamwork and your dedication for improving the neonatal care in East Zone. So, you all really deserve a big round of applause. I sincerely acknowledge the gracious presence of many senior people in the hall. Dr. Vijay Jain sir, SBP Singh sir, Dr. Reddy from the UNICEF, whom we discussed many things in the morning, Neelam ma'am, Dr. Ajit Singh, Satinder Singh ji, sir, IAP President, Dr. Rijwan, Dr. Galwara, and our East Zone EB, Dr. Jagdish Sahu. I think Jagdish Sahu should be there only because you are representing this zone, so I may request organizer, yes, to call Jagdish Sahu on the dash. समय की कमी के कारण मैं सभी सीनियर का नाम नहीं ले पा रहा हूं, लेकिन आपकी उपस्थिति added value to this conference, really. I would also like to extend my deep gratitude to all my seniors, teachers, and friends from Bihar and entire East Zone for their blessing, support, and guidance during my professional journey for last 10 years. As President-elect of Central NNF, I carry with me not just a title, but a shared responsibility. Together, we are custodian of the health of newborn of this country, which is not simple job, which is both profound challenges and powerful responsibility. India has made a significant stride in decreasing the neonatal mortality rate from 47 to around 19. In 19, so recent is 19. And Bihar is not less than that, far from that. It is 18. So, but sir, abhi is data ke, we cannot challenge this data, but recent government of data. So abhi main, yeah, so government of Bihar, IAP, NNF, and all the senior leaders really need a big round of applause, and NNF, Central NNF really commend this job. और यही नहीं रुकना है, हमें सिंगल डिजिट NMR को लाने के लिए अभी बहुत सारे मेहनत करना है. सो अगर इसी गति से हम बढ़ते रहें, अगर अभी 19 है, तो 2030 तक जो हमारा सिंगल डिजिट नहीं रहेगा, ये अभी भी डबल डिजिट रहेगा. अराउंड अगर सेम पेस से हम चलते रहें तो नियोनेटल मोर्टेलिटी रेट अराउंड 15 के आसपास होगा. सो फॉर दैट we need to accelerate our work. We need to collaborate better. We need to have a state-specific strategy based on the local need. हमें कुछ बात करना पड़ेगा, वैसा बनाना पड़ेगा. क्योंकि there is a vast variability in neonatal mortality rate. It varies from 3 to 30. अगर मनोज के स्टेट में हम चले जाएं तो वहाँ 3 है. And Manoj, if you go to some district, still that is 30. So we need to have a state-specific strategy to decrease the neonatal mortality rate of the India. So for that, we don't need a high-end technology and infrastructure. What actually need for that is the low-cost, high-impact intervention like antenatal care, corticosteroid, a skilled birth attendant in the labor room, early initiation of breastfeeding, KMC, IKMC, अभी हमने दिन में सुना IKMC. So all these things can impact significantly in decreasing the neonatal mortality rate. So we need to work on that. So अब बिहार के लीडरशिप से हमारी 2-3 गुजारिश है. सारे लोग बैठे हुए हैं. ओम प्रकाश सर के साथ हमने काफ़ी काम किया हुआ है पहले भी. जब व्हेन आई वाज इन आईएपी तो बात हो रही थी कि एनआरपी ने, दिनेश इज ऑल्सो हियर, तो उस समय ओम प्रकाश सर को एनआरपी का दिया गया. एंड वी वर्क, ओम प्रकाश सर एंड डॉक्टर भवेश, यू बोथ वर मेड द कोऑर्डिनेटर. तो उसके बाद काफ़ी काम हुआ. आई कैन vouch for him that under his guidance and leadership, Bihar will continue to grow and take this NNF to greater height. लेकिन आपसे कुछ है सर गुजारिश. एक तो ये है कि हमें कोलैबोरेट करना पड़ेगा अच्छे से. We need to strengthen our collaboration. We cannot do everything alone. So collaborate with the government, collaborate with the UNICEF, collaborate with IAP, फॉक्सी, सारे के लोगों के साथ मिल करके अगर हम करेंगे तो नियोनेटल मोर्टेलिटी में रेट में डेफिनेटली डेंट आएगा. दूसरा हमारा ये है कि क्वालिटी ऑफ केयर, उस क्वालिटी ऑफ केयर को हमें कॉम्प्रोमाइज नहीं करना है। मे बी कि हम यहाँ पटना में बैठे हुए हैं, यहाँ क्वालिटी ऑफ केयर अच्छा है, अगर हम पूर्णिया के किसी दूसरे जगह चले जाएं तो वहाँ क्वालिटी ऑफ केयर बहुत अच्छा नहीं होगा। सो एक मिनिमम क्वालिटी ऑफ केयर शुड बी मेंटेन, और उसके लिए एनएनएफ से अच्छा और कोई नहीं कर सकता है, बिकॉज आवर मेंबर्स आर एवरीवेयर। तो हम इसमें मदद कर सकते हैं, कोलैबोरेट कर सकते हैं। और दूसरा ये है कि इक्विटी, हम कहीं भी बैठे रहें लेकिन बच्चे को एक मिनिमम केयर मिलना चाहिए। इतने सारे अच्छे काम कर रहे हैं, इतने लोग हैं, इतने टीचर हैं, टीचर्स के स्टूडेंट सब जगह है, अगर सारे लोग मिल के करेंगे तो ये मुमकिन नहीं हो सकता है। उसी से हम रीचिंग टू अनरीच्ड जो हमारा एनएनएफ का है, ये एक दिन में नहीं हो सकता है। दिस ईयर टुगेदर विथ मनोज हम लोगों ने जो प्रोग्राम बनाया वो एक साल के लिए नहीं बनाया। रीचिंग टू अनरीच कैनॉट बी इन 1 ईयर, इट हैज टू बी मैनी ईयर, काफी समय तक चलते रहेगा तभी हम रीचिंग टू अनरीच पहुंच पाएंगे, नहीं तो एक दिन में नहीं हो पाएगा। सो वी नीड टू रीच एवरीवेयर। सो और ये गवर्नमेंट को भी हमें थोड़ा सा, चूंकि मैंने पहले भी श्रवण बॉस से और इनसे बात किया था कि गवर्नमेंट को भी बुलाइए, सो दैट कि हम लोग सेंट्रल एनएनएफ के सारे लोग आ रहे हैं, वी वांट टू वर्क टुगेदर, हम कुछ डिस्कस करें, हम कुछ कर सकते हैं, बट गवर्नमेंट के नहीं है। बट यहाँ के जो एनएनएफ लीडरशिप है, मैं रिक्वेस्ट करूँगा कि गवर्नमेंट को भी आप थोड़ा सा एनकरेज करिए, समझाइए, सो दैट कि वो नियोनेटल हेल्थ को प्रायोरिटाइज करे, मैटरनल हेल्थ को प्रायोरिटाइज करे। एंड सेंट्रल एनएनएफ की तरफ से मैं एश्योर कर रहा हूँ कि जहाँ भी जो मदद होगी, वी आर रेडी टू डू दैट, वी आर रेडी टू कोलैबोरेट। यूनिसेफ के साथ भी हमारी बात चल रही है, हम बहुत सारे प्रोग्राम के साथ यहाँ कोलैबोरेट करना चाह रहे हैं। नेक्स्ट ईयर वी आर प्लानिंग सम प्रोग्राम फॉर ए स्टेट लाइक बिहार, जो कि बहुत ज़्यादा प्रोग्रेस कर रहा है, जहाँ और प्रोग्रेस करने की ज़रूरत है। तो वो प्रोग्राम में मैं आप सब लोगों का साथ चाहता हूँ, उसमें आप लोग और कोई सजेशन दीजिए, सपोर्ट दीजिए, सो दैट वी कैन टेक दैट प्रोग्राम फॉरवर्ड। 2-3 प्रोग्राम अमित से भी हमारी बात हो रही थी कि कुछ हम रिसर्च की भी बात करेंगे यहाँ पर 2-3 जगह, और कुछ पेरिनेटल सिनर्जी के भी एक प्रोग्राम है जिसमें कि हम सिर्फ नियोनेटोलॉजी वाले नहीं कर सकते, उसमें गायनेकोलॉजिस्ट और लोगों को भी लाएंगे और उस प्रोग्राम को आगे ले जाएंगे। उसमें आप सबों का हमें साथ चाहिए। So before I conclude, my personal invitation to all of you to our National Neocon 2025 to be held at the beautiful beachside venue in Vizag from 12 to 14 December. It will be a great opportunity to meet, greet and learn together. और इस कॉन्फ्रेंस के लिए हमने पहले ही बात कर लिया कि हमने उसको स्लैश कर दिया है रजिस्ट्रेशन को, एंड दैट विल बी 7,000 ओनली। अच्छा, इसमें से कितने लोग रजिस्टर हैं अभी हमारे इसमें? हाँ, हैं, काफ़ी लोग तो हैं। और लोगों से मैं रिक्वेस्ट करूंगा कि काइंडली गेट रजिस्टर्ड, एंड आई विल ऑल्सो रिक्वेस्ट द सीनियर, जितने भी फैकल्टी सीनियर मेंबर्स यहाँ बैठे हुए हैं, उनसे मेरा एक और रिक्वेस्ट है कि काइंडली पार्टिसिपेट इन ऑल आवर ऑनगोइंग एंड अपकमिंग प्रोग्राम्स एंड गिव योर सजेशन ऑल्सो कि हम कैसे न्यूबॉर्न हेल्थ को आगे ले जा सकते हैं, ठीक है। एंड ऑल्सो मोटिवेट, एज अमित सेड, ऑल्सो मोटिवेट all the youngers one to become the member of NNF and participate in all our incoming and upcoming programs. So with that, once again, I extend my heartfelt thanks, gratitude and best wishes to all of you for the successful conference. Wishing you all a very happy learning. Thank you. Jai Hind, Jai NNF.
Thank you so much to Dr. Lalan Bharti sir. I can totally understand the nostalgia that he must be feeling addressing the gathering here. I would like to request Shravan sir to please Welcome Jagdish Sahu sir, who's the AB member for NNF from East Zone, with a token of gratitude. With that, I would like to request our guest of honor, Miss Margaret Gowda ma'am, who's the Chief of UNICEF Bihar, to please address the gathering. I welcome you, ma'am, to please address.
Thank you, Dr. Rashmi. I don't know how many minutes I have because I'm told the program after this is fun, so I'll keep it very brief. And I'll start by recognizing the dignitaries on the dais, Dr. V.C. Manoj, Dr. Bharati, Dr. Amit, Dr. Dinesh Tomar, Dr. Ravi Sachan, Dr. Jaiswal, Dr. Binod Singh, Dr. Krishna, Dr. Narayan, Dr. Alka, Dr. Om Prakash, Dr. Bhupendra, Dr. Sharwan Kumar, and Dr. Bawesh. I also want to recognize all the dignitaries and seated off the dais. Ladies and gentlemen, corporate attendees who have come in, my UNICEF colleague, Dr. Reddy, who sits with you every day and works with you in your facilities. Ladies and gentlemen, namaste. Ladies and gentlemen, namaste. Thank you. It's indeed a privilege to be here this afternoon, this evening, to join this 2025 BIHAR Neocon, which is also the 6th East Zone Neocon. I think I've participated in a number of these conferences where we have a lot of scientific information and a lot of discussions around how we can improve child survival and maternal survival with all the different cadres of the medical professionals. And so indeed, it's a privilege to be seated amongst such brilliant minds who are looking at the situation of children, and most specifically, the neonates. And as has been mentioned, there has been significant progress in BIHAR. And we really want to applaud and appreciate and recognize the work that the government of BIHAR and the National Neonatal Forum for your steadfast leadership in advancing maternal, newborn, and child health, and for nurturing partnerships that put children at the heart of our shared development goals. BIHAR's progress, as mentioned by Dr. Amit right now, health, achieving over 95% of full immunization, strengthening newborn care admissions, and scaling interventions to tackle malnutrition and anemia demonstrate both political commitment and systemic resilience. These achievements resonate strongly with the Every Newborn Action Plan, INAP, endorsed by the World Health Assembly, which calls for reducing neonatal mortality to fewer than 12 per 1,000 live births and stillbirths to fewer than 12 per 1,000 total births by 2030. And I think the challenge that I've had on the table this morning is that we are bringing down BIHAR's digit to 1. We've progressed quite significantly to 17, and we are coming down to 1 digit, and that is all our effort put together. The imperative ahead is that yet we are acutely aware that the Sustainable Development Goals remain an unfinished agenda. BIHAR continues to face significant challenges in neonatal and under 5 mortality, demanding sustained investments, equitable service delivery, and innovations that leave no mother and particularly no child behind. The imperative is clear: to build on progress with equity-focused system-strengthening approaches that combine quality of care, accountability, and community engagement. UNICEF, in partnership with the government of Bihar and NNF, is prioritizing the scale-up of evidence-based interventions aligned with global best practices. These include the zero separation policy and the immediate kangaroo mother care to ensure survival and bonding of small and sick newborns. The establishment of and strengthening of mother newborn care units, MNCUs, that embody WHO's standards for family-centered, respectful care. Third, optimizing CPAP and other proven innovations for neonatal respiratory support. And fourth, embedding a quality of care framework across facilities aligned with WHO UNICEF's quality of care network, which has shown measurable results in reducing preventable maternal and newborn deaths across 10+ countries. UNICEF calls on pediatricians, neonatologists, and private sector providers to partner with the government in strengthening special newborn care units, advancing home-based newborn and young care child, and building robust mentoring and monitoring systems. Together, we can ensure that every child, regardless of geography, regardless of their circumstances, has access to life-saving quality health care. Let us remember that investing in newborns is not only a moral imperative, it's a smart investment in the human capital that will drive Bihar and India's future. With partnerships, innovation, and unwavering commitment, we can envision a state and a nation where preventable child deaths are consigned to history and where every child and mother survives childbirth, and where every child has the right to a healthy and a dignified start to life. Ladies and gentlemen, UNICEF stands ready to walk this journey with you as a convener, a knowledge partner, and an advocate for every child. I conclude, as we always say in UNICEF, Bihar, that bacha bachi aage to Bihar aage. Bahut bahut dhanyavad. Thank you.
Thank you so much for your encouraging words, ma'am. We have felt everything that you have spoken. You have always stood by us, and we are extremely grateful to you for that. With that, it's time for us to listen to our chief guest, President NNF, Dr. V.C. Manoj, sir. I welcome you, sir, from East Zone in Bihar.
Respected dignitaries on the dais, respected seniors, and my dear friends. I bring warm greetings from National Neonatology Forum, Central. It is indeed my proud privilege. I consider it a great honor to be here with you all today, because somehow the positive vibes that you get the moment you land in the airport is something unexplainable. I'm not saying it just for the sake of saying. I just reached only at 6 o'clock. Since then, it is the positive feelings are building up. So thank you so much. I have always felt this very few times I have visited Bihar. Every time this is something, probably something to do with the great ancestral history that the state has. we at NNF and all of us who have this mission and philosophy of welfare of newborn babies always have had this challenge: managing resources, practicing evidence-based neonatology in resource-limited settings, and managing the whole scenario. I meaning reaching the unreached areas. Keeping this in mind, this year, for the next 2 years, myself with Dr. Leland and all of us together, we have decided the theme of reaching the unreached as the theme of our action plan. Some of the programs which you might have been part of, like the crash course in neonatology for the nurses, the crash course in neonatology for the doctors, otherwise called quick review of neonatal practice, the all about sepsis course, and then some of the specialized those who are doing tertiary care, like the ventilation course, the sonic course, and all these have had this aim in mind. Now, looking at the theme of this conference, shaping the future by nurturing new life, I think it has absorbed the whole essence of what we have been thinking when we devised this reaching the unreached, and then probably over a temporal profile right from the early days, the last decade, when we all started practicing newborn, last century, when we all started practicing newborn care, where survival was the great thing, to this early decade when we talked about intact survival, and then later on about nurturing care, and now helping the babies reach their full potential, free from adult diseases. We have come a long way in neonatal care. Somehow we are sometimes missing the larger picture. Probably the lack of infrastructure is a big hurdle that we face. Not just equipments, the infrastructure. The same thing goes for the literacy and things like that of the society. I am coming from a state where we have reached a NMR of 3.8, not because the healthcare is so great. The overall standard of living has gone up. So there are areas where even if we bring down the NMR and IMR, we can't reach a limit until we have the support of the administration. And that is where license comes in. And we at NNF are very good in advocacy. We should have license missions as well in this regard. As we progress further, our smartness lie in rediscovering the smart interventions, not the ones like the saving the small baby, 600 gram, 500 gram baby with spending huge chunks of money. I am not saying, I am myself, I do intensive care, but I am not saying that is bad. We have to look at the larger picture. We have to have smart interventions. You have to make something work everywhere in the country. And we have such interventions, beautiful interventions. Unfortunately, they also don't rest always with us neonatologists, pediatricians. This starts much earlier. Probably as pediatricians, as adolescent girls' health, the health of the health and wellness of the girl when she conceives probably has a part, but mainly it is the fetal well-being that we need to now concentrate if we want to make a difference. This is where we need to collaborate with our obstetric partners as well. fetal health is a paramount thing as far as our neonatal, infantile, pediatric health is concerned, because we cannot repair a damaged engine and make it work like as if it is brand new. We need to have the best substrates. Of course, we need to do our part as well. And as Madam was mentioning, there are some very low-cost interventions like delivering the baby onto the mother's abdomen, zero separation, IKMC, continuing with kangaroo mother care, exclusive breastfeeding, aggressive feeding even for the babies who unfortunately land up with some parental nutrition, and start understanding and believing in the concept that less is more in so many of the interventions that we do in neonatology is what is going to help us achieve that larger goal. And this is where we need to actually do an introspection. We need to know something about knowledge that we all know, but we tend to not really realize it. There are three types of knowledge. I'm not the first one to say it. You must have heard it from so many people. One is the kind of knowledge that we know. So we will always do right. So wisdom says you practice that. Then there is another kind of knowledge. You know that you don't know how to do something. There the wisdom says, okay, if I don't know, there are people who know how to do it. Let me get their help or let me pass it on to them. That is the second part. But the most dangerous part where we err unknowingly is the third type of knowledge. The knowledge that we don't know that we don't know. And unfortunately, with the fast pace of evolution of newborn care, most of the 1+1 is not 2 in neonatology. It's always there are shades of gray. So there are lots of areas where we don't know that we don't know the right answer. We think, yes, intubating and ventilating this baby is the way to go. Probably may not be. Or maybe keeping this baby nil hourly is the way to go. Probably may not be. There are areas where we need to introspect. And that is where events like this, the conference like this come. This is the time we all meet and greet each other, but it has a larger purpose as well. Update ourselves with what is happening. Previously, the previous era was all about expert opinion, talking about last century when we all started practicing, it was all expert opinion. Yes, someone says this is the way to do, so it has to be done. Then slowly the evidence-based medicine crept in, and now is the era of evidence-based medicine. But future is going to be something else. You need to be smart in using smart interventions and do precision medicine. That is what is going to be the future. If you want to really make a difference, the same disease requires different treatment. How are you going to do it? Of course, then you need tech, artificial intelligence, you need large data to be collected and things like that. But you need to realize that the way forward is not just getting stuck with the knowledge that we have learned. We need to actually learn more and more things. Just a small example, and I will wind up. Like during our days, babies used to be delivered. I'm talking about my MBBS days, 84. Babies used to be delivered, held ulta, and after that give a shot of bicarb, give a shot of Dexona, and babies, that's all. Then you send the baby to mother. Now we say all these three things should not be done. So look at how, but that was the right thing at that point of time. So if we do not update ourselves, this is of course an extreme example, nobody does that, but even the things that we think we are doing now, there are so many things in this category. So let us all introspect, and conference is the best time to do this, because after a period of life, when you are consultants, you don't feel like, I'm asking somebody something, but this is a forum where the passive and active learning takes place. Let's make use of that. And before I I know I am the hurdle between the great let go and the entertainment and the official function. So I would again taking echoing what has been repeated by Dr. Amit and Dr. Lalan, invite all of you for our national conference. This year it's going to be in Visakhapatnam, not very far from here. And it's a beautiful city. The venue, Novotel, is a beautiful hotel. You can see the beach. You can just get out of the hotel and run in the beach. Such a beautiful venue. Come there, meet people and contribute, and let us all make it a great event. So, and probably let us promote more and more people to come into the culture of NNF, where we have only one philosophy and mission: welfare of babies. Let us all strive for that. Again, from the bottom of my heart, thanks. I thank the organizers for having called me here. It's a great honor, and I wish all the very best for this conference. Thank you.
Thank you so much, President Sir. And of course, the way you have described Visakhapatnam, I'm sure we'll register in large numbers. So I would like to call upon a very senior pediatrician, Dr. Vijay Jain sir from Gaya, to have a few words about the Asian Congress of Community Pediatrics that's going to be held at Gaya. Dr. Vijay Jain sir, please come and update us.
Thank you, Dr. Rasmi. The learned persons on the desk and equally learned persons of the desk. Pranam, Namaskar, good evening, and Namaste. It's my privilege and it gives me immense pleasure in telling you and inviting you the first Asian Congress, I'm using the word, first Asian Congress and 25th National Congress of Community Pediatrics, going to be held in Gaya. I think you know about Gaya. The Gaya Ji, the land of salvation and enlightenment. Gyan और मोक्ष की भूमि, वर्ल्ड हेरिटेज टाउन बोध गया. ये होने जा रहा है कॉन्फ्रेंस 8th and 9th November 2005. That happens to be Saturday and Sunday. And I tell you, it is 7 days after the Chhat. So Chhat festival will not disturb us. And the most important thing is, this conference was going to be held on 8th, along with the Bihar Assembly elections. ये 8 तारीख को होने जा रहा था बिहार असेंबली इलेक्शन के साथ. बट होता ना, नथिंग इज इम्पॉसिबल. माई सेल्फ विथ डॉक्टर निगम, डॉक्टर विनोद कुमार सिंह, वी वर अप्रोचिंग द इलेक्शन कमीशन सिंस लास्ट मे कि सर ये प्लीज अवॉइड द इलेक्शंस इन गया ड्यूरिंग द असेंबली इलेक्शंस. इट शुडंट कंसाइड विद the Bihar Assembly elections. We would be disturbed because more than 500 delegates are coming from different parts of the country as well as from the Asian countries. So, आप सोच सकते हैं इलेक्शन कमीशन किसी की बात मानता है? नहीं. But they accepted our genuine demand. They cooperated with us, and I tell you, 8 तारीख को जो इलेक्शन गया में होने वाला था, now it has been postponed. It would be held on 11th. So please give us a big hand, and it's a big victory of ours. So मैं आपको invite करने जा रहा हूँ उस conference में. The venue is Hotel Mahabodhi. It has been taken over by Ramda. That is one. Second, you know about the Bodh Gaya. Third, the बात हो रही थी the charges of the conference. हमने उसको रखा है only registration charges only ₹4,000. Only ₹4,000. these early bird charges शुरू से चल रहा वही है, and this will continue till 30th October. इतना ही रहेगा, 4000 ही रहेगा. आप सबको मैं दिल से हम लोग इनवाइट कर रहे हैं. Being I am the patron of that chapter, the chairman organizing committee and the founder of that chapter. We found that chapter in 2001, or along with, I invite Dr. Shivachan Singh. He is our chairman reception committee. हम लोग दिल से आपको बुलवा रहे हैं, आइए दिल से. और वो था नहीं, लास्ट में पधारो हमारे देश, पधारो हमारे देश, आप समझते होंगे. आप पधारिए गया में. We will give you a very red carpet welcome, and we will roll our eyelids to welcome you. हम पलके बिछा देंगे आपको स्वागत करने में. And we are getting the cooperation from UNICEF. Dr. Margaret, Dr. Sanjeev, Dr. Reddy is there, and we will be continue to have cooperation from those people also. So thank you so much. Thank you for giving us 2 minutes time. Thank you so much, Dr. Vinodji. Thank you, Dr. Shravan, and thank you, Dr. Nigamji, and thank you all persons sitting on the desk.
मगही में कहने के लिए बोल रहा है, तो मगही में एक ही लाइन, आवल जाओ हमने सेवा कर पे वहाँ.
So thank you so much. We are definitely looking forward to the Asian Congress. With this, now it's time for vote of thanks by Organizing Secretary Dr. Shravan sir.
Thank you everyone. And I'm really, by core of my heart, I'm thankful to our National President, Dr. V.C. Manoj. And he is coming from the state that is icon for neonatology. I should say the NMR is in 1 digit, and we are just running behind that target. And NNF is supporting since we had started neonatology in Bihar, and everyone that we are being supported by NNF, and we want that it should be continuous process. And thank you, and all that my friend and Dr. Lalan Bharti, he is now President-elect. Thank you for coming. Mrs. Margaret Goda, from UNICEF, I am thankful. And I will not name all the dignitary because of short of time, and all the dignitary of the dais. I am really very much happy that this conference is satisfactorily going in very good way. And I am thankful to all the organizing team. I should say that I am very much happy with that my Chandan. Chandan is not less than us. I will clap. I want to clap all that he is doing a very good job, and he is really the main heart of this conference. Please come. I want to give a plant to honor him. I also like to honor she is not only the chairman of this souvenir committee, but she is supporting me since I was president IAP, and she is very much, but in enough, okay, but I know that, but you are very good in every way. Thank you, and I want to honor you. And really, you all, whether the pharma, whether this media, are supporting this conference is John Neocon in very supportive manner, and I am very much thankful, especially the Medway has supported us in every way, and Mr. Mihir and Avinash was also not only with monetary support, but actually what we want, he knows what we need. That is the main. That is the importance of our success. That is the yes. And really, I am very much thankful, and really this I don't want to Dr. Vijay Jain, Dr. S. Reddy, our Siddharth, yes, Shankar, Madam Neelam Verma, Dr. Golwara, Dr. Everyone is there. I don't want to name, but thank you, thank you, thank you.
Thank you so much, Shravan sir. We are overwhelmed with gratitude at the blessings and affection that you shower on us. Whatever little we do is applauded so much that it gives us new energy to work. With that, I would like to call upon Dr. Bhavesh Khan Chaudhary to propose his vote of thanks. Dr. Bhavesh has worked day and night, and his humility is being par.
अपने सभी गुरुजनों का मैं तहे दिल से स्वागत करता हूं, और ड्यूरिंग दिस प्रोग्राम हमें हमेशा से सेंट्रल एनएफ की टीम के सभी सर से मैंने कंटिन्यूस इनपुट लिया है। सर ने हमेशा इनपुट दिया भी है ड्यूरिंग दिस प्रोग्राम। एंड आज हम लोगों ने जो किया बेसिक न्यूबॉर्न केयर से एडवांस केयर, कल जो हम लोग करेंगे AIUG इन NICU, क्योंकि ये एक हॉट टॉपिक है। एट द सेम टाइम विद द ये कि बोथ एंड ऑफ द कॉर्ड, जो हमारे जो सेंटर प्रेसिडेंट सर हैं, जो डॉक्टर VC मनोज सर, वो करेंगे, जिसमें कि न्यूट्रोलॉजिस्ट एंड ऑब्स्टेट्रिशियन दोनों को एक टेबल पे लाने की कोशिश करेंगे। कर एट द सेम टाइम जेनेटिक्स, बिकॉज नाउ द इन्फेक्शन कंट्रोलिंग तो जेनेटिक बढ़ते जा रहा है। तो ये सब के साथ मैं आप सभी का तहे दिल से स्वागत करता हूँ और बहुत बहुत धन्यवाद करता हूँ। इसके साथ ही हम आप सबको जो है गाला डिनर के लिए इन्वाइट करते हैं। थैंक यू वेरी मच।
Thank you so much, Dr. Bhavesh. And with that, I invite the galaxy on the dais and all present of the dais to proceed for an enjoyable evening, which has been organized with a lot of care by the organizing team, over to the gala dinner with the musical program. So thank you so much to all on the dais.